1500 प्रीलोडेड गानों
Good evening. My greetings for the Apollo Neuro Conclave 24 held in Bangalore. I wish I am personally being present there, but we are very happy that
G. Good morning. Welcome to day 2 of Apollo Neuro Conclave. There is a slight change in the conference schedule. Stroke and the neuro intervention is happening here. And, the neurosurgery talks are going on in Hall B. Yeah. Just opposite the... No, that's I told two medical reps just to guide people. Otherwise,
ಹಲೋ, ಕೇಳಿಸ್ತಾ ಇದೆಯಾ?
ಈಗ ಕೇಳಿಸ್ತಾ ಇದೆ ಪ್ರದೀಪ್.
ಅಲ್ಲ, ಅವ್ರಿಗೆ ಅಲ್ಲಿ ನಾನು ಇನ್ನೊಂದು ಆಲ್ಗೂ ಹೊರಗಡೆ ಮೊಬೈಲ್ ಕನೆಕ್ಟ್ ಮಾಡಿದೆ.
ಸರ್ ಕೇಳಿಸ್ತಿದ್ಯಾ?
ಕೇಳಿಸ್ತಿದ್ಯಾ?
ಈಗ
ಕೇಳಿಸ್ತಿದೆ
ಕೇಳಿಸ್ತಾ ಇದೆ.
ಕೇಳಿಸ್ತಿದೆ.
ಓಕೆ, ನಿಮ್ದು ಇನ್ನೊಂದು ಈಗ ಸ್ಕ್ರೀನ್ ಕಾಣ್ತಿದೆ, ಅಪೋಲೋ ನ್ಯೂರೋ ಕಾನ್ಕ್ಲೇವ್ ಅಂತ. ಕ್ಯಾಮ್ರಾದ
ಹೌದು.
ಏನಾದ್ರು ರೆಕಾರ್ಡ್ ಮಾಡೋದು ಅಟೆಂಡೀಸ್ ಅಲ್ಲಿ ನೋಡ್ಬೇಕು ಅಂದ್ರೆ ಹೆಂಗೆ? ಅದು ಚೆಕ್ ಮಾಡಿ ಒಂದ್ಸರಿ.
ಒಂದ್ ಸೆಕೆಂಡ್ ಸರ್, ನೋಡಿ ಸರ್.
ಪರ್ಫೆಕ್ಟ್.
2 ಸ್ಕ್ರೀನ್ ಮಾಡ್ತಿರಲ್ಲ?
ಅದು ಕೊಡ್ತೀನಿ ನೋಡಿ ಸರ್. ಓಕೆ
Okay.
ಸಿದು
ಎಲ್ಲ
ಪಿ
ಆಗ್ತಿದೆ ಅಲ್ಲ?
ಎ ಪಿ ಮಾಡಕ್ಕಾಗಲ್ವಾ ಸಿದು?
ಸರ್, ಪಿ ಎ ಪಿನೇ ಮಾಡಿರೋ ಸರ್, ಅದು ಇಷ್ಟೇನೆ ಬರೋದು.
ಅಂದ್ರೆ ಇನ್ನೂ ಚಿಕ್ಕದ್ ಬರುತ್ತೆ ನೋಡಿ ಸಿದು ಲೇಔಟ್.
ಇನ್ನು ಚಿಕ್ಕದ್ ಮಾಡಕ್ ಹೋದ್ರೆ ಇದಾಗುತ್ತೆ ಸರ್, ನೇಮ್ ಕಟ್ ಆಗುತ್ತೆ ಪ್ರೆಸೆಂಟೇಷನ್.
ಹೌದಾ?
ಈ ವಿಡಿಯೋನೂ ಕಟ್ ಆಗುತ್ತೆ ಸರ್ ಅದಕ್ಕೆ.
ಓಕೆ
ಓಕೆ ಸರ್, ಓಕೆ.
ಓಕೆ.
ಓಕೆ, PPT ಬರ್ತಿದೆ ಯಾರಾದ್ರಲ್ಲಿ? ಓಕೆ, ಆ ಸ್ಟೇಜ್ ಇಂದ ಮೈಕಲ್ ಮಾತಾಡಕ್ ಹೇಳ್ಬೇಕಿತ್ತು, ಅದು ಒಂದ್ಸರಿ ನೋಡ್ಕೊಂಡು ಹೋಗಿತ್ತು. ಸಿದ್ದು ಅವ್ರೆ?
ಮಾತಾಡ್ತಾರೆ ಒಂದ್ ಸೆಕೆಂಡ್ ಸರ್.
ಸರಿ, ಆಯ್ತು.
ಹಲೋ
ಲೈವ್ ಹೋಗಿದೀವಿ ಯೂಟ್ಯೂಬ್ ಅಲ್ಲಿ.
ಹಲೋ ಚೆಕ್. ಹಲೋ ಸ್ಟೇಜ್ ಮೈಕ್.
ಕೇಳಿಸ್ತಿದೆ. ಈಗ ನಾವ್ ಮಾತಾಡೋದು ಮೇನ್ ಎಲ್ಲಾ ಸ್ಪೀಕರ್ ಅಲ್ಲಿ ಹಾಲಲ್ಲಿ ಕೇಳಿಸುತ್ತಲ್ಲ ಎಲ್ಲಾರ್ಗು?
ಹೌದು ಸರ್, ಕೇಳಿಸ್ತಾ ಇದೆ.
ಓಕೆ, ಫೈನ್.
ಒಂದ್
ಎಲ್ಲ
ಸೆಕೆಂಡ್,
ಓಕೆ ಅಲ್ಲ ಹಾಗಾದ್ರೆ?
ಒಂದ್ ಸೆಕೆಂಡ್ ಸರ್, ಜೂಮ್ ಮಾಡ್ತಾರೆ ಕ್ಯಾಮ್ರಾ. ಹಲೋ ಹಲೋ
ಝೂಮ್ ಆಗ್ತಿದೆ. ಝೂಮ್ ಇನ್ ಆಯ್ತು.
ಓಕೆ ಸರ್.
Doctor,
Okay.
I'll share an updated too.
ಪರ್ಫೆಕ್ಟ್.
ಓಕೆ ಸರ್.
ಯೂಟ್ಯೂಬ್ ಒಂದ್ಸರಿ ಚೆಕ್ ಮಾಡ್ಕೊಳ್ಳಿ, ಇನ್ನೇನಿಲ್ಲ ಅಲ್ಲ ಅಷ್ಟೇ. ಶ್ರೀನಿವಾಸ್, ಆಮೇಲೆ ಹಂಗೆ ಇರಿ, ನಾನು ಅಲ್ಲಿ ಹೋಗ್ಬಿಟ್ಟು ಪಿನ್ ಮಾಡ್ತೀನಿ ಇವ್ರನ್ನ. ಅಪೋಲೋ ನ್ಯೂರೋ ಕಾನ್ಕ್ಲೇವ್ ಇದೆಯಲ್ಲ, ಅದನ್ನ ಪಿನ್ ಮಾಡ್ತೀನಿ, ಅದೊಂದೇ ಬರುತ್ತಾ ಎಲ್ಲಾರ್ಗು ನೋಡೋದ? ಈಗ ಎಲ್ಲಾರ ಸ್ಕ್ರೀನು ಕಾಣ್ತಿದೆ. ನಿಮ್ದು, ಮಂಜಿತ್ ನ್ಯೂರೋ ಕಾನ್ಕ್ಲೇವ್ 3 ಸ್ಕ್ರೀನ್ ಕಾಣುತ್ತೆ, ಅದ್ರ ಬದಲು ಬರೀ ಸಿಂಗಲ್ ಸ್ಕ್ರೀನ್ ಕಾಣಂಗ್ ಒಂದ್ಸರಿ ಚೆಕ್ ಮಾಡ್ಕೊಂಬೋದು.
ಓಕೆ.
ನೀವು ಲೈನಲ್ಲಿ, ನಾನು ಮೊಬೈಲ್ ಡಿಸ್ಕನೆಕ್ಟ್ ಮಾಡ್ಬಿಟ್ಟು ಹೋಗ್ತೀನಿ.
ಓಕೆ.
Just need to get people in this. That's the only task. I think we should announce there. A lot of people don't know because
You're waiting for people to come there as well to start making.
they thought that such number of and more. Swarna is not Swarna. According to his family.
Yes. Hello. Hello.
I will go. Make yourself comfortable. Just mobilize some people. Who will come with me? Ashwini, come.
ಸರ್, ನಿಮ್ ಪಿನ್ ಮಾಡ್ಲಾ? 2 ಪಿನ್ ಮಾಡ್ಲಾ?
ಎರಡಿದೆ ಆ ಕಡೆ ಒಂದು. ಅಲ್ಲಿ
On time.
Good morning. May I request all the delegates and members to kindly take their seats so that we can start the session. There are few announcements to make. Here, stroke symposium is going on here. The neurosurgery symposium is going on in Hall B. So our volunteers and the hotel staff will help you to move to Hall B. So the stroke and the neurointervention symposium will happen in this main hall. So without wasting much time, we will invite you to the proceedings of the scientific program of day 2 of Apollo Neuro Conclave. Hope you all had a wonderful time yesterday. So there is a slight change in the program here. Dr. Vinit Suri had to leave early yesterday, so he had given his talk on IV thrombolysis in acute stroke, revisiting the indication. So what we are planning to do is we will, skip his talk for now. The 3 talks will go on, and the surgical management of stroke talk also will be merged in the first, session, and then we will break for tea. Post tea break, actually we are having 20 minutes. There is a panel discussion. In the panel discussion, we will have first 20 minutes discussion on IV thrombolysis in stroke for the benefit of the delegates who are coming today. And then we will go ahead with antiplatelets and anticoagulation. So may I request Professor B.K. Mishra, can I have slides of the chairpersons? Dr. B.K. Mishra to chair the session. May I request Dr. Karthik? Dr. B.K. Mishra? No, before that. Go up. Chair, first slide in there. Yeah. Professor B.K. Mishra, I request him to take over. And may I request Dr. Sharath? Dr. Sharath, Senior Consultant Interventional Neurology. And Dr. Karthik is a neurosurgeon in our hospital. He'll be joining soon. So may I request the chairpersons to take over the proceedings, please.
Good morning. Good morning, everyone. It's a pleasure to be part of Apollo Conclave, Neuro Conclave 2024. And special thanks to Satish Chandra sir for arranging such a beautiful meeting. Without wasting time, I would invite Professor E.K. Mishra for the talk on stroke epidemiology and clinical subtypes. Gustaki Ma, but to introduce sir into this symposium is something which is unheard of. Who doesn't know him? And many of his students, including me, are sitting here. I would request sir to start his talk.
Thank you, Chairperson, sir. Ladies and gentlemen, I've been given the subject of stroke epidemiology and subtypes. So I will briefly review the stroke subtypes and epidemiology, and then take some time to discuss some of the questions in stroke which I have learned. So briefly, I'll present some of my learning points which I have learned in due course of time. As you know, is a rapidly developing clinical signs of focal or global disturbance, symptoms lasting for more than 24 hours and no other cause. Or a wider definition is that if we have objective evidence of brain, spinal cord, or retinal cell death due to vascular etiology. And as has been discussed yesterday also, that stroke is a leading cause of mortality and morbidity. It's the second leading cause of death globally. And incidence is 12.2 million and prevalence 1.1 million persons according to global burden disease. Now, is the stroke a problem of developed countries or developing countries? Probably it is more of a problem in the developing countries. As you can see in the lower part, the mortality in the developed countries 1.6 million and developing countries 4.85 million. Similarly, the disability. And this is the global stroke problem, mainly in East Europe, North Asia, Central Africa, and South Pacific. And India, this epidemiological studies have been done mainly from Bengal and from Punjab, and the prevalence rate and the crude incidence rate and mortalities have been defined. The important thing is that in India, majority of patients are not aware of hypertension. And even if they are aware, they are not adequately treated. And this is a study from India which shows that only 12.9% subjects were on hypertensive or on antihypertensive medication. And 51.4% were aware of the disease, and very few were adequately treated. Ischemic stroke and hemorrhagic stroke are the two major types. Ischemic stroke occurs in 80% and hemorrhagic in 20%. But in the developing countries, there are higher incidence of hemorrhages compared to the developed countries. In high-income countries, the ischemic stroke are in 91% and hemorrhages in 9%, whereas in Africa, Nigeria, and Ghana, you see the much higher incidence of hemorrhages compared to ischemic stroke. And the by treating the blood pressure and other risk factors, there has been a decline from 90% to 60% from 1954 to 1988 in Ghana. And therefore, it's very important to look at the reversible risk factors. The TOS criteria are well known: large artery, small artery, lacunar, cardioembolic, cryptogenic, and other causes. And they are, their distribution is shown in this slide. Intracerebral hemorrhages may be intraparenchymal, hypertensive, due to rupture of Charcot Bouchard aneurysm, or subarachnoid hemorrhage because of secular aneurysm, vascular malformation. And it results in high mortality, and half the patients who survive are with disability. This slide shows the modified risk factors. 90% of the risk factors are shown here. They are hypertension, most important, diabetes, lipid, coronary artery disease, atrial fibrillation, sedentary habits, smoking, alcohol, poor diet, and stresses. History of stroke and sickle cell disease also increases the risk of stroke. Hypertension, more than 140/90 should be treated, and there's always a debate, and the criteria are changed for a period of time. But the ideal target blood pressure keeps on changing every 5 years, and we have to keep on checking that. In diabetics, especially, the blood pressure has to be more strictly controlled, even in renal failure, because to avoid other target organ damage. Hyperlipidemia, again, is an important risk factor, and 1 millimole or 39 milligram per DL using statin therapy results in decreased incidence of ischemic stroke by 17%. The important is that, hypertension is poorly controlled in the developing countries, and therefore there is a high incidence of hypertension. Whereas the risk factors like smoking, hyperlipidemia, cardiac disease, atherosclerosis, etc., lead to atherosclerotic heart disease and subsequently ischemic stroke. And it's also related to the lifestyle, which is changing over a period of time, and therefore influencing data significantly. Then, there are a large number of genetic factors which have been into a Jiva study shown that EBO, MTHFR, ENOS, factor V, F2, beta fibrinogen, etc. They all have been linked to stroke, and they have been linked to other epigenetic factors which has been there. A bigger stroke study, a meta-analysis of a large number of patients, involving large area, Europe, North America, South America, Africa, and Australia, identified 35 new stroke loci. And the 22 were novel ones. And then these loci have been attributed to be resulting in stroke. And in combination with other risk factors, they lead to a severe risk of stroke. Other risk factors like oral contraceptive, vasculitis, inflammatory process, migraine, obstructive sleep apnea, prothrombin activator inhibitor complex deficiency, hypotension, C-reactive protein, neurocysticercosis, other infections, and hyperuricemia all have been linked to stroke. We also looked at hypertension in our cohort in young hypertension and looked at the risk factors, and hypertension was an important risk factor and was poorly controlled. Hypertensive hemorrhages have a very typical location. They are either ganglionic or they are in the pontine region or on the cerebellum, and sometimes they can also be lobar. Interestingly, this was a patient with thalamic hemorrhage, and 15 days later, she had yet another thalamic hemorrhage on the other side. Now, usually in the books, we were taught that hypertensive hemorrhage is a one-time event and they don't recur, but this was surprising. Then we kept on following, and then you saw this patient sequentially, she had 3 hemorrhages, and typically in hypertensive location. This is putaminal, this is putaminal, and then caudate putaminal. And then, we found a patient having 3 times hemorrhages. And, then we started looking at these patients. There were 3 episodes in one patient and 2 episodes in the remaining patients. 11 hemorrhages, 9 were ganglionic, 1 pontine, and 1 lobar. And there have been reports of recurrence of hypertensive hemorrhages from Korea and China, and there have been such reports. Then we looked at, is it a poor control of blood pressure? That Charcot-Bouchard aneurysm on one side bleeds, and then after some time, another one bleeds. It doesn't happen on the same side. Or it is something else. So we looked at the genetic factors, and we looked at 2 genes, ApoE and ACT genes, and we found that it's a small study, but then the E2 and E4 alleles were significantly related, but ACT gene was not related. Then it's a small study. We needed a larger study. We were 11 incidents, 11 patients here and controls. But you have to look at a larger number of C and look if there is a predisposition for recurrence of hemorrhages and hypertension. This is an interesting girl. She is a migraine, 1.5 year, 4 to 5 attacks, headache, vomiting, altered sensorium, right hemiparesis. So she was admitted with putaminal hemorrhage, and we admitted her, but her blood pressure was extremely high. So we worried, young hypertensive having such hemorrhage, why? So history of migraine, putaminal hemorrhage, and should we rule out renal artery stenosis? So we found that she had a dissection of aorta. Infrarenal aorta was dilated, and this is what you see on, you got a flap here. So dissecting flap, the whole aorta was dissected, and there was also renal artery stenosis. So these were leading to uncontrolled hypertension. We were not able to control it with drugs. So, then she underwent, this is the aorta, and then she underwent thoracic endovascular aneurysm repair, and then after that, her blood pressure was controlled, and then she was married, had 3 children, was okay for 13 years. But last month, she has again come back with probably, dissection giving way or something problem. So we have not yet investigated. She has been sent, she has been advised to come back immediately. And therefore, this was a very problematic case, but so nicely managed and remained all right for 13 years. She completed her MBA, had a family, and was doing fine till she has another dissection. Now, transient renal impairment. This is a question which I have been seeing as a resident, that often the hypertensive patients will have a transient rise of urea creatinine, and after some time it will settle down. We attributed it to dehydration, drugs, poor control, and all those things, but then all recovered. So then, we looked at it some time back, and we ruled out renal causes, dehydration and nephrotoxic drugs, etc. And then in selected cases, we found that the mean was creatine rose by 3.5 median, that is 1.7 to 7.7 milligram per DL. And they returned to normal in 2 to 4 weeks, all of them. We hardly did dialysis in one patient, otherwise they were all conservatively managed. It was related to GCS, pulse pressure, and were significantly related to were also related to the renal impairment. So later on, we have again looked at the catecholamine levels. So at that time, we postulated that it could be because of sympathetic stress. sympathetic overdrive. And we have done catecholamine levels. I'm not presenting here. And the catecholamine levels during acute phase rise, and they may be related to vasoconstriction and therefore the transarterial impairment, which improves over a period of time. So we generally manage them conservatively. In very exceptional cases, we have to do dialysis, otherwise they all come out nicely. Now, this is another patient of recurrent headaches in a 40-year-old man, policeman, migraine-like headache, no history of diabetes, recurrent ICH for 7 years. He was having seizures and no systemic manifestation of suggestive vasculitis. These are different stages of, here 13, 14 hemorrhages he has had at different time points. So we had to do his biopsy, and then we found it was a vasculitis, and then he was treated with steroid, and because of which he put on weight, and then he was immunomodulation and has been doing fine. So recurrent small hemorrhages were occurring in a patient because of vasculitis. Tuberculous meningitis again is an important cause of headache, and we often see that, and this is a girl who lost her vision and has not yet improved. And then what is important is in TB meningitis we get, mainly we have been told that it's the ganglionic hemorrhages which occur more commonly. But they can occur at different places, which is well known. But we were interested in looking that what are the basal ganglia infarcts which occur, how are they different from atherosclerotic infarct? So we just, one of our colleagues, Dr. Nair, my student at that time, but now professor at Pondicherry. So he did that study, and we looked at 24 TBM infarcts, basal ganglionic infarcts, and compared them with the lacunes in ischemic stroke, and 24 and matched group. And we found that in TB meningitis, the infarcts were mostly in the anterior region and the caudate region, and other regions were not significantly different. So this is the type of thing infarct which you will see in tuberculous meningitis, and this is the posterior one which you get in atherosclerotic stroke. So it was the lacunes which are mainly anteriorly located, 70%, and posteriorly 91% in ischemic stroke, whereas TB meningitis 70% will be. So most of the lacunes in TB will be anterior, and most of the one in atherosclerotic will be posterior. It's not a 100% rule, but majority of them. So medial side thalamotuberal and thalamoperforate vessels are involved in tubercular zone, and lateral side vessels are more commonly involved in ischemic infarction. Now, in TB, any infection, whether it is pyogenic infection or viral infection or tubercular, there is a prothrombotic state, and there is a excessive coagulability, and that results in stroke. Now, therefore, this gave us an idea that look at the aspirin, the role of aspirin in preventing stroke in TB meningitis. So this is what we thought to do this study, and we did a randomized trial in 46 patients versus 53 patients, evaluating the role of aspirin, and we found that mortality was lower, and incidence of stroke was insignificantly less in the aspirin group compared to the no aspirin group. So aspirin resulted in significantly lower stroke and significantly lower 3-month mortality in TBM patients. After that, there are 2 more studies have been done, and they have also found, at least Thwaites has found similar results in his cases, in definite cases of TB meningitis, whereas in children, Schoben did not find a significant difference. Now, the last thing is that quite often you see in TB meningitis, hyponatremia. In hyponatremia, we have found that is mainly because cerebral salt wasting. Cerebral salt wasting means excessive polyuria. Polyuria means hypovolemia and dehydration. So with this background, a stroke in TB meningitis occurs in about 40%, salt wasting occurs in 40%. So we wanted to look at the relationship between stroke and hyponatremia, salt wasting. And, this is the important slide, that this is the type of stroke we saw, bilateral border zone infarcts. And during this study, I'll not talk into long study, but here you can see this lower panel shows the duration of polyuria, from 200 to 350 days, from day 0 to 180 days, So polyuria goes on for months together. And therefore the patient, you increase the intake, output will increase. The patient will be in a state of dehydration. For 3 months, 4 months, he's in a state of dehydration. You can't admit him. So what we did, we gave him a notebook and he was to report the intake output chart every day and come back and inform us. So we have calculated this fine. And we found that 10 out of 16 patients with cerebral salt wasting had infarcts during the polyuric phase. And during that period, the BP has fallen down. So we thought that one of the mechanisms of stroke in TB meningitis could be hypotension. Hypotension because of salt wasting. This may be a defense mechanism. I'm not saying that, but this is what happens. So, the blood vessels in what we measure in the arteries is much higher, 192. Perforator, it may be lower, and further branches may be 60/30, very low. So in normal person also, there is a gradient of blood pressure. So when a patient is having vasculitis and stroke and salt wasting, there will be multiple things which may be leading to his stroke. So this slide shows to you. So there are exudates, which may leading to strangulation and then there may be vasculitis, which lead to thrombosis. And then there may be hypotension because of cerebral salt wasting and polyuria, and there may be prothrombotic state. So these multiple factors may be contributing to stroke. So aspirin is not the only treatment. We have to see the overall condition and manage him, and the multiple prong approach may be required. Now this whatever I have shown you, the lacunes in anterior region, they are not specific to, this is a case of cryptococcal meningitis. And here also we find similar things which can lead to stroke, So cryptococcal meningitis has not been studied. We need patients. So you collect all your patients, see if their strokes are there, whether they are anterior or posterior, and whether they are related to hypovolemia or not. So this is the question which I have no answer, but should be looked into. Neurocystic sarcosis, we all have seen occasional cases who have neurocystic sarcosis and can have infarcts. And this is a 52-year-old cognitive impairment and behavioral abnormality, fell down, had hemiparesis 1 day back. And 46 cells in the CSF, protein 205, and ADN negative, cysticercal antigen positive. These are cysticerci, and this is a diffusion weighted, this infarct. So cystic sarcosis can also lead to rare, but it can lead to. Coming to B12 deficiency and ischemic stroke. Now, we all have known, there has been a lot of work from Dr. Nagaraja that he has seen that folate deficiency, B12 deficiency can lead to hyperhomocystinemia and thrombosis. We also have seen and reported such cases who have B12 deficiency, hyperhomocystinemia, and venous sinus thrombosis. We have to correct hyperhomocystinemia, and they improve. Similarly, in arterial stroke, also we have a young stroke, you have searched everything, nothing is found, but you find hyperhomocystinemia, 42, 55, and then you have low B12 or folate and combination, and then you have to treat accordingly. I took a ICMR project with the same aim that maybe in our vegetarians, there will be higher incidence of hyperhomocystinemia because they are B12 deficient, and that we could have a higher incidence of stroke. That was the hypothesis. We did the study for 3-4 years, could not prove it, so it was a negative study. But everything does not come in epidemiological study, or short study of 3-year project does not give all the answers. You need much longer sample, and nobody will give you a project for that long. But that was a question in the mind. And we occasionally see patients who have hyperhomocystinemia because of B12 folate, and then you treat them and they become all right. Probably you follow them with that. So hyperhomocystinemia can lead to atherosclerosis, and homocystinemia lowering treatment with B12 folic acid may prevent stroke. So a BetaTop study was a double-blind trial, and they found that they did not reach statistically significant thing. But WISP and HOPE studies have also found that homocysteine levels can be reduced, but direct evidence of coronary artery disease or atherosclerotic strokes, etc., is not there. So one meta-analysis found a role in reducing stroke, but another one did not find. So increased homocysteine leads to increased risk of stroke and coronary artery disease. Hyperhomocystinemia can be lowered with folic acid, B6, and B12. Routine use of homocysteine lowering treatment for venous sinus prevention is not supported by available evidence, and therefore, but individual case, we have to keep our eyes open and treat accordingly. So daily requirement is 2 microgram per day. But I think B12 deficiency is not a nutritional disorder. It's probably a genetic disorder. It's, you have well-fed people coming from high families, still they have low levels, and they are all non-veg. Sometimes non-vegetarian also you have it. So I think it needs further work, further evaluation. But at the moment, old people are more prone for B12 deficiency, so we have to monitor it and treat it if possible. And the treatment is, I usually give injection, but now nasal treatment is available. Well, that is supported to be as good, but see for yourself. I think injection is cheaper and safer and straightforward and once a month, but well, there are people who give nasal or oral treatment also. So to conclude, I'd like to say that stroke is commoner and more serious in the developing countries because of obvious reasons. Intracerebral hemorrhage is commoner in the developing countries. Blood pressure control is the most important and should be carefully done. And infestations are important in the developing countries and in our setup also. And occasionally hyperhomocystinemia and B12 deficiency and folate deficiency are also associated with stroke. And they are not epidemiological evidence, but still occasionally case by case you can see it and we have to monitor. Thank you very much.
Thank you, sir. Thank you for such a beautiful talk. I'd request if the audience has to ask any questions to sir or any doubts.
Very nice talk, Misha, and always, as always. So I just wanted to find out, you must have seen a lot of cases of hemorrhage long before with the infarction in the same patient coming afterwards. Do you think it is just the hypertension which is causing, or is there a genetic cause for that, wherein you get hypertension sometime and also infarction sometime? You said about the recurrent hemorrhages. I'm asking about the hemorrhage and infarction in the same individual.
Yeah, absolutely. You see, in ischemic, hypertension may aggravate atherosclerosis. That's one way. But hypertension directly is responsible for lipohyalinosis and hemorrhages. But we can have both in a hypertensive patient. As I told you that, there are some genes which have been implicated for, everybody with hypertension does not have recurrent hemorrhages. Some people have, and some people not have it twice, but even 3 times. And maybe if we follow them further, maybe 4th time also we'll get. So I think, it's a very complicated problem. It cannot be answered very easily unless we look very sincerely and in a dedicated manner and do all the studies of the conventional risk factors and also look at the genetic studies. So I think it's a difficult question to answer, but at least we should be aware that this is an area which is difficult and we have to probe in rather than brush aside and say just, one simple method, maybe it's hypertensive, control the hypertension will be all right. No, we are not there to prove or disprove it. So I think, I think all the hypertensive patients do not have such hemorrhages or such stroke. I mean, somebody manifests with renal impairment, somebody manifests with ocular involvement, somebody manifests with cardiac involvement. So this is a different target organs are damaged differently. Now, what determines that? I mean, it's a $1 million question. I don't have an answer. But then, we have to be aware of it. And then we have to keep our mind open to investigate.
Second, and small other question, small question.
Sir, I have a question. Looking at your vast experience of treating so many patients and in the academic sphere for such a long time, what is the difference why the venous stroke and arterial stroke, they do behave differently so far as the manifestations, incidences, as well as the outcome is concerned? Is there any pathophysiology?
Very, very good question. I think, venous stroke is a different problem. Venous stroke is blockage because of the thrombus formation, and then the stagnant anoxia, and then you correct the thing, the whole thing recovers. So there is a damage to the neurons occurs much less, much slower, and to a much lesser extent. So this is all reversible. Whereas in arterial stroke, there is ischemia and there is an acute necrosis. And then, the recovery is poorer. So I think, venous stroke is, my message is that venous stroke, venous infarcts recover. Don't leave them. They recover, they improve over a period of time. Arterial stroke is a difficult problem. Because of severe ischemia. And, here there's a blockage and there's a stagnation and there's stagnant anoxia. So this damage is slower and therefore the recovery better.
It's just the difference between the low flow and high flow mechanism, like the ischemic strokes, which are tap like the water tap getting bursted and then the waste pipe getting bursted is the venous stroke.
You see,
It's the
venous
pressure that is important.
Yeah.
That's what I am.
Yeah, I think, venous stroke has a very different mechanism. You see, you may have a venous stroke patient. I mean, patient may have venous thrombosis and present with one month history of headache and seizures. You find that the sagittal sinus is thrombosed. So this is different. Whereas an arterial stroke, a blockage of 1 minute or 30 seconds also will manifest. And if it's a long, 5 minute, 10 minute, the whole thing is gone. So I think it's a totally different temporal profile and, yeah.
I just wanted to make a comment.
Yeah.
We were talking about the venous stroke and the arterial stroke. And we were seeing with a retroviral infection, and we have published some papers on venous strokes in retroviral infection. They recover very well. And the mortality is almost nil, practically.
Yep.
So I myself was surprised, and then we went ahead with the series. And the series showed that their recovery is excellent.
Absolutely.
Compared to that.
I think venous stroke, I mean, my message is don't leave them. However bad they are on ventilator, just carry on. The nature will take care, We just have to prevent further thrombosis and then, they recover over a period. Now the new technologies are coming and now interventionists are there. But, if you can manage even with the, anticoagulation, most of the patients recover. If they don't, you can take up the help of colleagues.
Good morning, sir.
Yes, sir.
You showed us a patient's slide wherein that same patient had 3 consecutive hypertensive hemorrhages. In the same sitting, have you seen a patient with having bilateral, same area hypertensive hemorrhages in your vast experience?
I have seen a patient, I have seen a patient of severe hypertension with bilateral thalamic hemorrhage, but she was a case of Conn syndrome. She presented with flaccid weakness. I mean, we did not report it, but it was surprising. Hypokalemia, and suddenly patient flaccid quadriplegia and comatose, CT shows bilateral thalamic hemorrhage. Yeah.
We had a bilateral.
But not same, you see, generally you will not see, I have not seen a bilateral hemorrhage, hypertensive hemorrhage same time. I don't know why my feeling is that, is the Charcot's aneurysm on one side. They are present bilaterally, but one gives way. And this one gives way, the other side is there. He recovers, other side bleeds. So they generally don't bleed bilateral simultaneously, maybe, but I have not seen.
We had a patient who had symptoms on one side.
Yeah.
And we did a CT scan.
Yeah.
The other one was an asymptomatic bilateral basal ganglia hypertensive bleed.
Yeah.
It was a poster in one of the national conferences.
Lovely. Yeah, maybe.
So recently we had TBM, one of the cases we were managing with arthritis. So we were then reading up and your paper also came up. So the data looks good, sir. I mean, is there enough data for us to actually recommend to use aspirin in most of our patients with TB, tubercular meningitis? That was one thing. And second, was there any harmful events like when you incidentally used in your study, were there any bleeds which happened?
Yeah, absolutely. But what I'm saying is that in a patient with TB meningitis, we use 150 milligram aspirin during the period of ATT because, the hemorrhages, the infarcts can occur anytime. They occur in the early stage, they can occur in the later stage. So I think we maintain, aspirin during the treatment of ATT, continuing anti-tubercular treatment. Harm we have not seen as yet. Yes, if the patient is, severely large infarct and hyperventilating, phoning and all that, you may not do it because the purpose is not to treat. The purpose is to, to prevent further stroke. And we have got a reduction in mortality. So therefore, we would like to use it as early as possible. And 150 milligram is what we have used. You may discuss why not use 75. Dr. Thwaites has used low and high dose aspirin. And, they are further looking at it, they got resources and, people to look at it, they are looking further into it. But we have used 150 milligram and that's what we think half a tablet of aspirin doesn't make much difference. Make it quarter, I don't know. Yeah, maybe.
Thank you, sir.
Thank you.
Another, like tubercular.
So, would like to call upon the second speaker, Dr. Chinmay Nagesh, who is a senior consultant at Apollo Hospitals, Gynaecology. He is a budding upcoming neurointerventionist and very well-read person. And he will be talking about role of various modes of imaging in decision-making of management of acute strokes.
Morning. Thank you for the kind introduction, sir. I'd like to thank the organizers for giving me the opportunity to present today. So today we'll be going over the role of various modalities in acute stroke. So what is the goal of an acute imaging stroke protocol? So of course, we want to give the patient the best chance at having a favorable outcome when there is a vessel occlusion of any kind. So the secondary implied goal is what? We want to achieve a revascularization using appropriate selection, appropriate treatment in the fastest time possible. That is what we're looking at. So what are the basic needs? Of course, we need to have it fast. It needs to be easily implementable. It needs to be reliable despite it being as simple as possible. It needs to have as few contraindications as possible. And of course, it needs to be as safe as possible. So what are the basics? Of course, we need to rule out mimics, find an occlusion, and assess the extent of parenchymal damage. Hence, we're looking at a combination of parenchymal, vascular, and functional imaging. Simply put, we're looking at the core, whether there's a clot, and how's the collaterals. Okay, so what are the modalities that we have for stroke imaging? If you want to consider it as hospital-based, you have conventional CT and MRI, as well as a direct endovascular therapy treatment paradigm, which includes cone beam CT and DSA. Or you can have portable within the ambulance, for example. You have TCDs and a mobile stroke unit such as an O-arm. So when do we choose which modality? So basically, when we're looking at all the factors involved, we can simplify them as what are they in terms of hospital-based, what personnel do we have involved in the stroke team, based on the patient at that time individualized, as well as what kind of stroke are we suspecting. So, of course, each of these has an impact on treatment. So, if you were to go about the factors in a hospital-based management, what are the modalities available? So, most of them have CT, which is more ubiquitous than MRI. Of course, a cath lab with a CBCT, a cone beam CT facility, is an added advantage. What about combination? Is your CT and MRI right next to each other? Is it the same console? Maybe you can use a combination. Maybe a diffusion with a CT angiogram is the ideal protocol. What about the volumes of a center? Is it low, high, medium? What about monitoring facilities during the scan? A CT allows your inotrope infusions. It allows all kinds of monitoring equipment. An MRI doesn't. So is the patient unstable? Telemedicine. In the middle of the night, who's going to be seeing the images on what? A CT is much, much more difficult to see on WhatsApp or any other kind of this one, unless you're directly viewing it on your mobile PACS or app. And of course, what kind of post-processing and AI facilities do you have? Next, we come to personnel. So who's the imagologist involved currently who's going to be the first responder? Is it an INR, an interventional radiologist? There are exceptions to every rule, but maybe they'd be equally good at looking at plain CT versus an MRI. Is it a neurologist who might be more comfortable with MRI? Is it an ER physician who would be comfortable only with MRI? What about your radiology technician? Are they good at perfusion? Do they do good post-processing? What about your stroke nurse? Are they available for patient monitoring? Will they be able to look after everything within an MRI? What about on-table thrombolysis? More difficult in an MRI, maybe easier on a CT. What about the patient? Look at what their age is, because immediately when the age starts crossing 70, 75 plus, you look at the creatinine, pre-functional functionality. What about the comorbids? What is their expected life expectancy? Do they have a pacemaker? MRI is out. If they have onyx, it causes significant metallic artifacts on CT. So that's out. What about cooperativeness? Pretest probability again. A low GCS and hypertension, you would think more along the bleed. Ask for CT first. What about a moderate to high NIHS? You're suspecting an ELVO. Maybe get a CT, if it is rule out bleed, get a CT angio directly. And then while the CT angio, you've already found an ELVO, counsel the patient, start doing a diffusion during that time if you have the facility. What about a mild NIHS? Probably you're looking at an embolic stroke. If it's embolic, maybe you need to do a CT angio to rule out a neck vessel disease. If it's lacunar, you need to find it. Maybe it's difficult to find on a CT. You need to do an MRI. What about family? Costing is, of course, always an issue in India. To counsel and educate the patient as well is a challenge with CT. Sometimes an MRI would do a better job. Finally, what about stroke itself? Is it a wake-up stroke? Is it less than 6 hours or is it 6 to 24 hours? Is it Wake-up stroke means you need to use a window of flare versus diffusion. What about anterior versus posterior? Clearly, posterior is inferiorly detected at CT. You need an MRI. What about a large vessel occlusion versus a medium vessel occlusion? MRIs are better for medium vessel. A large vessel is better with CT. ICAD, sometimes you need to find a susceptibility sign on SWI. If that's absent, it's a stenosis. What about ESUS? Many a times we find that plaque is not seen well on the routine MRI, the carotid plaque. You need to see that better on your CT angiography. Similarly, cavernous areas, again, seen poorly on MRI, may be better seen on CT angiography. Prognostication. A diffusion would give you a better idea of what all areas are involved. Most commonly, we see that coronary radiata as early infarction versus the basic ganglia are almost always established. Again, maybe you can reverse the coronary radiata rather than saying no. Again, what about intermixed? You've got a lot of chronic, say, cardioembolic infarcts, and now you've got a new infarct in the middle of all that. Again, an MRI would be superior to a CT scan. And of course, mimics and chameleons, you have a combination of both. Okay, so what are the impacts? So we look at workflow times, we look at expenses, what are the chances of converting a patient towards mechanical thrombectomy, and finally, how does it relate to outcomes? So looking at workflow times, clearly there is an increase in scan times and door-to-needle times with MRI. MRI is more expensive. Maybe you would, after you finish your initial 24 hours of treatment, you'd want to repeat either a CT or an MRI. Now, if you've done an MRI, your comparability with the next CT is going to be difficult. What about converting a patient towards IV or mechanical thrombolysis, thrombectomy? Ease of depiction towards the family. Again, you can make an impact. These are all societal, social things that make an impact medically. Versus you look at the MRI and get scared and you say, oh, I'm not going to offer mechanical thrombectomy in this. It can work both ways. What about microbleeds? If you have more than 10 microbleeds, you would try to prevent the use of IV thrombolysis. Finally, outcomes. You can always do an etiological workup that is better with a CT angiography in terms of artery to artery. You can find aortic thrombi, for example, which may be missed on an MRI. You can also look at what are the possibilities of recurrence rates based on initial plaque imaging using carotid plaque imaging. What about immediate prognostication? Again, like I said, on MRI might be better. Both CT and MRI would be probably better at predicting what the 90-day outcome would be. MRI is clearly better in preventing SICH avoidance during mechanical thrombectomy. So how well is this data driven? So there are 3 papers that I found, one from 2019 in stroke, another one in the Egyptian Journal of Neurology, Psychiatry and Neurosurgery in 2022, and a more recent paper from 2024 from the Green Journal. So as you can see, they've basically found, at least this is an Indian paper, interestingly, these 2 are abroad. So the 2 foreign papers say that there is no difference in outcomes at 90 days between CT and MRI. Very important. What did this paper find? They were unique in that they went after endovascular thrombectomy perspective, and they found that an MRI was better at predicting 90-day outcomes post endovascular thrombectomy. And this one was comparable to the 5 major endovascular trials. What else? These 2 papers also found that there was these 2 papers also found that MRI was better at reducing the risk of symptomatic intracranial hemorrhage in all these patients. So again, just to summarize, MRI equals CT in terms of final outcomes at 90 days. MRI is better at reducing SICH complications. Okay, so let's quickly go through some of the modalities and what they can offer. So looking at the CT protocols, you've got non-contrast, CT angiography, and CT perfusion. Looking at the NCCT, you've got axial, which is preferred over helical. It helps in identifying mimics, looking at identifying the signs of a stroke, quantification, identifying the large vessel occlusion, even on a non-contrast, as well as timing it sometimes. So of course, mimics, we all know the bleeds and tumors, things like that. You've got early ischemic changes and evolving infarct and established infarct. Of course, you have to look at your stroke windows always. You've got your name signs. Another thing is gaze deviation. Even on imaging, you can see that the gaze deviation is towards the side of the stroke. What about quantifying, we use the older, simpler 1/3 rule versus the aspect score. You can even use your non-contrast CT to predict what's going to happen. We all know that atherothrombotic strokes are more common in posterior circulation. This is the CT angiography. You can see the NCCT is actually showing a cholesterol hypodense plaque over there. And we achieved successful thrombectomy with the stenting of this patient. What about ELVOs? We all know the name signs, hyperdense, dot signs, and MCA signs. What next? So once you've finished your CT, you start off with your CT angiography. Remember to never wait for a creatinine. Nephron is inferior to neuron, at least in our context. CT angiography, of course, is the next thing. So usually we have a very low rate of contrast-induced nephropathy. It's less than 3%. The radiation risk is acceptable. It is better for proximal LVOs, and it's good for catheter. This one, it also helps the interventionist to plan for the thrombectomy. What else? What kind of CT angiographies do we have? We have the single phase and the multiphasic angiography. So what do we do in a single phase? We usually just take one acquisition from thorax to cranium, and we are done with it. That's inadequate. The better thing to do is to take at least 3. The first one covers the usual. The second and third cover the cranium itself. What is the advantage? In addition, you can also do a cardiac coverage to see for cardioembolic sources. Now, what is the addition, this one? What is the advantage of this? Now, a single phase, of course, will give you the usual, where is the location, etc. But collateral estimation is where multiphasic CT angiography is better. You tend to have sometimes very slow pial collaterals from the ACA to the MCA, and this is better picked up on a multiphasic CT angiography. So there's actually a multiphasic CT angiography scale, which is quite complex, but at least eyeballing it, you can look at it that you can slowly find that there is a slower filling of the collaterals on the occluded side. Okay, so here's another example. So posterior circulation stroke again, you do a multiphasic CT, or in my case, the first phase of the multiphasic CT. You can see that there is retrograde filling. There's a vertebral occlusion over here. The other one is hypoplastic. You can see that there's retrograde filling of the basilar. Now, at in this first phase, you would presume that the entire vertebral is occluded. But is that so? It isn't. You can see that on the second and third phases, there is gradual slow filling in over here. And you finally find that it's just a focal occlusion. So again, endovascular thrombectomy wise, it becomes a very simple thing. I know exactly what I have to go in and do. I have to just get past this, stent it, and come out. That's it. Very simple. Okay. Now, what about CT perfusion? So, of course, once we have reached less than 4.5 hours, we'd have to do, if it's less than 4.5 hours, we'd give IVTPA. More than 4.5 hours, we need to quantify using CT perfusion. So, CT perfusion, so when do we have to use CT perfusion? So, the usual thing that we go to is a clinico-radiological mismatch. So you've got your core, which is dead non-functional tissue, and you've got your penumbra, which is viable but non-functional tissue, electrically inactive. Okay, so how do we differentiate? Clinically, we have the NIHS core. Radiologically, we have the core. It is this clinico-radiological mismatch that we use in almost majority of our cases, 80 to 90% of them, to differentiate whether there is a penumbral effect. Now, the way to objectively show it is using CT perfusion. So with CT perfusion, we use basically the diffuse 3 criteria, where we have a CPF of less than 30% that says that this is the core. We've got a penumbral Tmax of greater than 6 seconds that says that this is the penumbra. And when we want severely ischemic tissue, we say it's more than 10 seconds. Now, what is the target perfusion profile? We want a mismatch ratio of more than 1.8. A core volume of less than 70 ml, and an absolute penumbral volume that should be more than 15 ml. Now, this is the objective way of looking at it, both from in patients beyond the early window period, as well as patients who you want to prove medico-legally that they are candidates for endovascular therapy. So the usual acquisition, we use a 4.5 ml injection per second. We use the central volume principle, where the mean transit time is the cerebral blood volume by the CBF. What you need to understand is that the MTT has now been replaced by the Tmax, which is for deconvoluted, this one. Okay, so how do we make out what is going to happen to the patient? So we have something called the hypoperfusion intensity ratio. So you've got a Tmax area where the filling is so that it takes about 10 seconds or more. You've got a medium area of hypoperfusion where the filling is less than 6 seconds. Divide the two, and basically when it is more than 1.8, you know that it is going to be a low HIR is a slow progressive. This patient is going to give you time. This would work in the hub and spoke kind of model. A high, hypoperfusion intensity ratio would be a fast progressor. Get this patient faster, closer to as wherever possible. Okay, so this is what is the importance of, this would help in a hub and spoke model. Okay, what else? So of course we finished CT. What about MRI? MRI is better at core. It gives you a clot burden sometimes better, and there's less inter-rater objective subjectivity. The disadvantages, of course, it takes longer, more preparation, things like that. So what is your stroke protocol? You need a diffusion, flare, SWI, MRA, maybe an ASL. That's it. So a non-contrast MRI versus a contrast MRI can help you pick up times. So your usual routine non-contrast MRI would be 24 minutes. You can shorten it to 13 minutes, sometimes even 7 minutes using contrast and MRI. You can even use your initial preparation images to pick up a major vessel occlusion. Diffusion, of course, works on the basis of the Brownian motion of water between tissues. Once there is cellular edema, that is cytotoxic edema, there is reduction in interstitial space, resulting in a diffusion hyperintensity. 1.5 Tesla is inferior to 3 Tesla. A P2000 can pick up really hyperacute infarcts. You can also have diffusion reversal in many such patients. The other way, apart from perfusion, to objectively maintain a clinical radiological mismatch is to look at the diffusion infarct volumes. So if you had an NIHS of more than 10 or 10 to 20, you'd use an infarct volume of less than 30 cc and 50 cc respectively in a patient less than 80 years to say that this patient is viable for mechanical thrombectomy. What else? Reversal of acute diffusion is possible. This is one of our cases which we did a basilar thrombectomy. You can see reversal. Same thing with the large MC occlusion. You can see the hyperintense areas reversing post thrombectomy. What else? Flare, of course, is for looking at the presence of vasogenic edema, which happens usually at around 4.5 hours. So what is it? What is the importance? When you have both diffusion and flare hyperintense, it's more than 4.5 hours. Less than that, it is less than 4.5 hours, the flare is not yet turned hyperintense. So useful for thrombolysis. What else? SWI can give you an idea of whether there's a penumbral effect going on with the prominence of veins or the vessel occlusion that you can see clearly over there. MR angiography, remember that the TOF only gives you caudocranial flow. It is not going to give you collateral status. For that, you need a contrast enhanced MR angiography. Okay, MR perfusion, you've got the non-contrast ASL and you've got your usual contrast enhanced susceptibility perfusion. Now that we've finished MRI and CT, what about cone beam CT? So instead of going through the usual thing of going to emergency, CT, MRI, then giving a blood thinner, things like that, etc., you can skip directly and save almost something like 20 to 25 minutes if you take the patient directly to the cath lab. Now, this works only in high volume centers. What do? Basically, you do a expert CT, what we have in Philips, and you can detect bleeds. And then you can do an actual IV injection of contrast and do a similar CT scan, slightly a longer rotation time, but it takes 20 seconds. And you can do a CT where you can detect a major vessel occlusion. Artificial intelligence, of course, you've got 3 major softwares now, which help you in predicting what is happening. Rapid is the one that has been used most. You've got Viz AI and Brainiomics, which also have various advantages and disadvantages, which I won't go into. So to simplify the protocol, when you've got, the last few slides, to simplify the protocol up to 6 hours, you would use ideally a CT plus a multiphasic CT angiography. If it's a wake-up or unknown onset stroke, you'd ideally use an MRI. Beyond that, you would use CT perfusion. Now, remember, increased information is not always relevant. And whatever it is, have a standardized sort of algorithmic approach to how you would do this one, how you would do imaging. Now, just to give you an idea of how that algorithm might look, if you had a suspicion of an acute ischemic stroke with a large vessel occlusion, of course, you'd look at parallel factors, things like ruling out other mimics, etc. If the time of onset is known and it is less than 6 hours, you would have a patient who would fit in ideally using either CT or MRI with a NIHS of 6 to 25. That is a moderate clinical stroke, a small core, and good collaterals. Nowadays, you treat even patients sometimes with minor stroke or a large infarct with both with thrombectomy. Now, if the onset is not known, onset is known and it is more than 6 to 24 hours, if you have perfusion, you would use the Dawn 3 criteria, the diffuse criteria, sorry, and you would use it based on the infarct volume. If you had no perfusion, you'd use a objective clinico-radiological mismatch. Finally, if the onset is not known, you would look at a diffusion flare mismatch, or you would look at perfusion and just go ahead based on what is the core penumbra mismatch. So finally, in conclusion, I'd say that stroke imaging does require expertise and requires practical knowledge. You need to know what all modalities that are available in general for future improvement versus what you have. You need to realize that the choice of modality does not fit everyone. You need to be individualistic. You need to know what all the protocols are, how to analyze them, as well as clinical-based decision along with AI. Thank you.
Thank you, Dr. Chinmay. With the available time, you have comprehensively covered with the beautiful slides. Thank you again. If there are few questions in the audience. Mike.
Predicting the with the application of imaging and also artificial intelligence, predicting the in case of TIA, if it is not under the acute stage, what about your message?
So I'm not sure about TIAs. TIAs are more of looking up.
Primary patient TIA is the very common thing that we
True.
usually
So
we get.
I'm not sure about the role of AI in predicting outcomes of TIA. Whether there's a sorry. Okay. So yeah. So TIAs are of course multifactorial, sir. So true. So when you've got an artery to artery embolism, AI is useful at only picking up significant occlusions. It is not good at picking up stenosis, which are the more common cause for your TIAs. Another common factor is vulnerable plaques. Now, vulnerable plaques are things that are non-stenotic plaques, non-critical, but are ulcerated or they have intra-plaque hemorrhage, things like that. Again, AI has not yet come to the level of that. AI right now is useful for two things. One is it is useful for predicting whether there's a large vessel occlusion and helps in analyzing images to help you come
message wherein we say that the importance of training the general physicians, general practitioners, and other physicians. No neurologist can work 24 hours to save a stroke patient. It's our, responsibility, rather the community's failure to percolate the, importance of stroke thrombolysis to the tier 2, tier 3 system.
Absolutely correct, sir.
Sir, I just want to add one more point. I just again compliment to our entire team. Because we are all talking about the community, this thing. What about in-hospital strokes? So, thing is, they've taken a challenge and this thing every week they're going and training one nursing homes in making it a point, they bring awareness to the nursing staff. So, which is last 2 years consistently they are doing. I think I compliment them. I thought I should bring it up so that
absolutely
can take up this topic. Thank you.
Sir, door to needle time is the longest in hospital strokes. That's been done, that's really. Because they don't recognize, we don't even know.
Okay, I think we did it in epilepsy. The epilepsy model we use for all these general practitioner training for a long time. I think that has to be replicated. We have to train them when to refer the patient and what for. That is what exactly we do. I think Karnataka has taken a lead under Subhash and Sonan Sharma, and they are doing it already. The district quarters, they are going and doing it. I think that is the way forward for this.
Thank you, Dr. Meenakshi Sundram.
Thank you, sir. Thank you.
Now I welcome on stage Dr. Sandeep VK, my dear colleague and consultant neurosurgeon at Apollo Hospital, Gynaecology, for his next talk on another interesting topic, STMCA bypass. Welcome, Dr. Sandeep.
Good morning, everyone. Thank you for the opportunity. So today we'll be talking about STA-MCA bypass and other revascularization procedures, in generally cerebral ischemia in general, in steno-occlusive disease or in acute stroke. So cerebral bypass as a surgical procedure, it is just performed to restore or revascularize blood flow to the brain. It involves connecting blood vessels from another part of the brain, either outside the brain or inside the brain, to reroute blood flow around an artery, which is stenosed, thrombosed, or damaged. The main goal is to provide blood supply to target region of the brain. So coming to the history of revascularization procedures, the first procedure was performed in 1942 by Credel. He did an indirect bypass in the form of encephaloduro-angiomyosin angiosis. Then subsequently, Warringer and Kunlin in 1963 did a CCA-ICA bypass. And Asargil in 1968 famously performed the first microsurgical direct anastomosis between STA and MCA. He did it in a patient of a 20-year-old with Marfan syndrome who had a M1 occlusion. Then subsequently, the different bypass with vein grafts, FNS vein graft, were developed in 1971, 77, 78, and 82. So seeing the benefit of the bypass surgery, two study groups were done. One in 1985, which was the ECIC bypass study group, which showed no benefit in STA-MCA bypass in reducing ischemic events, although some criticism was there for the study. So subsequently, again, on carotid occlusive surgery study was performed in 2010. Then they abandoned the surgery thinking that because medical management was only better off in preventing the subsequent strokes. But still, nowadays, some studies are going on for STMCA bypass even in acute strokes where the endovascular therapy has failed. So coming to the types of bypass, the type 1 bypass is where the external internal carotid artery is completely replaced by the saphenous venous graft. In the type 2, what happens is the ECA to MCA or occipital or posterior cerebral artery bypass is done using a venous graft. The type 3 is direct bypass where STA or an occipital artery is anastomosed to the intracranial vessels. And in type 4, it is done in aneurysms or in tumor surgery where the part of the vessel is excluded and direct anastomosis is done. So the direct bypass is again classified depending on the choice of donor artery. So when the donor artery is either extracranial, that is ECIC, and the other is the intracranial artery, that is ICIC. Depending on the rate of flow also, it is divided into low capacity flow, intermediate flow, and high flow. The low capacity flow is the direct bypass like STA-MCA bypass. The intermediate flow is when the radial artery graft is used. And the high capacity flow when the saphenous venous graft is used because of the higher diameter, they have higher flow capacity. So the indirect bypass, it acts through promoting new capillary network formation, but revascularization in this procedure takes time. It may take up to 4 months. There is a flow augmentation, but it is a very small amount of flow and it is restricted to certain small areas where the burr hole is done. Here, the recipient vessel size is not very important and the ischemic brain is unable, when the ischemic brain is unable to accommodate a higher flow, then also this indirect bypass is used. The different types are as encephalomyosyngiosis, duroarteriosyngiosis, and duroarteriomoyosyngiosis. There is a omental graft which has been placed and also multiple burr holes to promote vascularization from the surrounding tissues. In direct bypass techniques, there is vessel-to-vessel anastomosis, and it is done when there is the requirement of immediate revascularization, and the flow augmentation is dependent on the vessel conduit, the size of the vessel conduit. Generally, the recipient vessel size should be at least more than 1.5 mm ideally, or more than 1 mm also it is done. So different techniques are like STA-MCA anastomosis using an arterial or venous graft, Petrus ICA to supraclinoid ICA, either cervical external carotid artery to MCA or cervical external carotid artery to supraclinoid ICA. And there is a what is called as bonnet graft where the opposite STA is anastomosed to the saphenous vein of the opposite side. So direct is done when there is immediate flow required and where the brain can handle the higher flow rates. And there is availability of acceptable recipient vessel where there are the M4 arteries are patent enough or M1 artery in the high flow bypass. The indirect is done when the immediate flow is not required, generally in chronic steno-occlusive disease. And when the collaterals may not develop in 40 to 50% of the adults. Sometimes the mass effect of the muscle which is placed on the brain can cause some defects like aphasia. And the revascularization area, as I said, it is dependent on the craniotomy size and shape. Coming to the donor vessels, the low flow vessels are superficial temporal artery or middle meningeal artery, external carotid artery, or internal carotid artery. Now, the internal carotid artery, we use a graft from there to anastomose to MCA or PCA. Then occipital artery and vertebral artery segment. Coming to the conduit, there are different types. One is the pedicle graft where the direct vessel is anastomosed. The STA superficial temporal artery is used, but it should be at least more than 1 mm in diameter. Occipital artery in the posterior circulation it is used and middle meningeal artery. For free arterial graft, we take either radial graft or other arteries, and free venous graft is the great saphenous vein. The vein grafts have a low resistance to circulation, hence they have higher flow rates. And STA and occipital artery and middle meningeal artery have a lower flow rates because of the lesser diameter of the vessels. And the radial artery, as I said before, it has 50 to 150 ml per minute at anastomosis. And the saphenous vein graft has 100 to 250 ml per minute at anastomosis. The recipient vessel in a bypass graft where a saphenous vein or a radial artery is used generally will be M1. But we should be very wary of occluding it temporarily because of the ventriculostriate perforators, which can cause even temporary occlusion can cause strokes. The implantation should be done at the bifurcation, and at least it should be at 2.5 mm in diameter. If the M1 segment is short or MCA unsuitable recipient, we can use supraclinoid ICA if aneurysm is infraclinoid. If that supraclinoid ICA is used as a recipient collateral from ACA, collaterals from the ACA is essential, which has to be checked pre-op because there is temporary ICA occlusion will be done during the surgery. And generally, suturing should start from the heel end and then go to the foot end. Coming to the indication for bypass and stroke, mainly in cerebral ischemia, the moyomyovasculopathy, chronic steno-occlusive disease, and nowadays some studies which have started for acute ischemic stroke also. The indication for flow preservation is one is intracranial aneurysm surgery, where we have to exclude the aneurysm from the circulation, and also in skull-based tumors where the tumor is completely encasing the vessels. In cerebral ischemia, where it is used is where there is failure of medical management to control the TIA symptoms or stroke, or if there is an atherosclerotic plaque that is not treatable by endovascular means, or the CT angio or MR angio shows complete arterial stenosis or occlusion. In bilateral vertebral artery or basilar artery occlusion, it is also done, but care should be taken that posterior communicating artery are sufficient size and collateral flow. Coming to the procedure proper, before doing the procedure, there has to be a preoperative angiogram that should include an ECA injection also to adequately define the patency, course, and caliber of the STA branches. Generally, the STA branches are identified and largest STA branch should be taken, but ideally it should be a parietal branch because sometimes frontal branch will have ophthalmic artery anastomosis. Coming to the procedure, the STA is identified to the Doppler and a linear incision is taken along the segment of the STA. The superficial temporal muscle is split and along the vessel it is exposed. The burr hole is placed between a line joining lateral canthus and tragus at 2/3 and 1/3 junction, and a perpendicular line drawn from that point around 6 cm above that. A burr hole is placed around 3 cm to 4 cm in diameter. And the anastomosis, the M4 segments are identified and anastomosis is done. The fish mouthing of the donor artery should be done and a teardrop incision over the recipient artery is done and the anastomosis is performed. The post-anastomosis Doppler should be done to identify flow across the anastomosis. And also the bone flap should be placed such that, that it is not pressing over the anastomosis. So the advantages are of STA-MCA bypass are it is readily available and there is only requirement of a single anastomosis. It has a good patency rate comparable up to 88% in 3-year follow-up. And also as compared to free vein and arterial graft, which have a little lesser this one. So the disadvantages may be the flow rate is little low, that is around 50 to 30 ml per minute, which can be bypassed by doing a double barrel bypass, like using 2 STA branches to anastomose to 2 different M4 segments. So coming to the bypass study, which was done in 1985 and 2010 to establish the clinical efficacy, they concluded that it is not effective in preventing ischemia or any reduction in bypass. So what were the criticism of the study was the antiplatelet was not started to everyone who had undergone the surgery. Only half of the patient received antiplatelet. So that may have caused the blockage of the arteries. There was no pre-op evaluation of the cerebrovascular hemodynamic status of the patients. Both the patient and therapist were not blinded. So there may have been randomization to treatment bias, and no angiographic determinants were identified at the entry of the study. In the carotid occlusion surgery study, the inclusion criteria for the study were complete occlusion of an ICA, TIA or ischemic stroke in hemisphere territory of an occluded internal carotid artery in preceding 120 days. The outcome measures were measured in surgery arm, any death or stroke 30 days from the surgery, or any ipsilateral stroke within 2 years. And in the medical arm, the death or stroke within 30 days of randomization and ipsilateral stroke within 2 years. They stopped the study on June 24th, 2010 in between because the medical management showed far better results, and they didn't want, even though the surgical part also showed better results, but with medical management it was comparable, hence they abandoned the study. But recently in Germany, they have performed one more study comparing to this because there is a population change, which shows, even though not statistically significant, but significant improvement in STA-MCA bypass, the revascularization part. Recently, many studies have been conducted for emergency STA-MCA bypass surgery for any progressive ischemic stroke, which are not amenable to treatment with endovascular treatment, where there is a large vessel occlusion, like a ICA or M1 occlusion. It has shown the comparable results, and also the MRS scores have improved, but still it is not statistically significant. But even in Japan, they are attempting to do acute emergency STA-MCA bypass when it is within 72 hours of the surgery. Sometimes it is included along with the decompressive craniectomy part also. This is one case where we did in acute emergency setting where the M1 was completely occluded and it was not, they were not able to continue the circulation through endovascular means. So we attempted, as the patient also required decompressive craniectomy, during the procedure we did a STA-MCA bypass, which shows the patent STA-MCA bypass and refilling, retrograde refilling. Patient had a little improvement in the weakness of the right side. Whether that was due to the brain having neuroplasticity or due to the circulation, we don't know, but the patient has survived. He's localizing to pain and he's E4. Coming to STA-MCA bypass in aneurysm surgery. So in aneurysm, which is occluding M1 segment, what we do is we first perform a STA-MCA bypass to provide some sort of circulation to the M4 areas branch. Then an EC-IC high flow bypass is performed to the proximal part of the M1 aneurysm. Then during this one, it is either endovascularly excluded or it is like surgically excluded and a bypass graft is done. So now the bypass surgery is actually performed, the 67% is performed only for flow augmentation and 27% is done for flow preservation. That is, flow augmentation is in cerebral ischemia cases. 27% where the bypass is done is for flow preservation. It is in aneurysm or tumor surgeries. The indications for flow augmentation bypass, where we do most of the augmentation bypass, is in 50% is moya-moya disease, and in 44% where ICA occlusion or chronic steno-occlusive disease, and very little in 5% of the acute strokes. And flow preservation bypass, the main flow preservation bypass is done in 94% of the cases, it is in aneurysm. Coming to the present status of revascularization, in cerebral ischemia, most randomized controlled trial have shown no benefit, but some studies have shown comparable results and also some benefit, but which is not statistically significant. And in moya-moya disease, there is class 3 evidence of benefit. Complex aneurysm, the class 3 data is, there shows some benefit, but it is only when intracranial artery to intracranial artery bypass is done. If the long segment bypass is done, there is no benefit. And in skull-based tumor, there is also class 3 evidence of benefit. Although now people advise to go for alternative strategies of treatment of residual diseases. Coming to the complications of bypass, one is early graft occlusion. This can be avoided by having an intraoperative Doppler and to avoid the kinking or pulling of the anastomosis, any tension between the vessels that should be avoided, and also the bone placement should not be over the graft. If any aneurysmal rupture can be avoided by completely occluding the aneurysm before doing the bypass. Then any neurological deficits we have to reduce the temporary occlusion time, and any transient neurological deterioration secondary to postoperative hyperperfusion. The long saphenous vein graft for cerebral revascularization, the early patency rate, this is 1 year follow-up, it was 88%, and at 13 years was at 73%. Coming to the take-home messages, in COST study, they showed that they did not reduce any risk of recurrent ipsilateral stroke at 2 years. Although they abandoned the study, stating that even medical management also didn't show any ischemic strokes in the next 2 years. The emergent STMCA bypass can improve clinical outcome in acute cases. It can reduce the risk of morbidity. It is only a option for acute stage revascularization at present moment when there is no effective endovascular therapy. And in clinically difficult cases, there is no gold standard therapy. And it is only used when there is endovascular treatment failure. Thank you.
Thank you, Dr. Sandeep, for this interesting talk. Topic is open for discussion.
Especially for the follow-up of these STMCA bypass patients, what we practice is we do a transcranial Doppler once in 6 months. It's very, I can say non-invasive and real time, and it's very safe. And, most of these patients, we can avoid invasive procedure like CT angiogram or DSA on a regular basis. Otherwise, you can't definitely say whether the vessel is open or not. So you put a Doppler probe on both sides, and within few minutes you can come to know. This was very common in when I was working in Singapore. So every alternative patient we used to have was moya, wherein they were either operated cases or they were due for surgery. So this is one good bedside tool which we can.
Generally, we use a handheld Dopplers which produce sound. Just to demonstrate the patency, we had done one angiogram for that patient.
No, that's good. That's good. But I'm just telling you, as a bedside, you can do almost like daily follow-up after the surgery. Thank you.
So, I'm sorry. The only question is always about the graft patency, endovascular work versus the graft. So where do we on that? Because cardiologists and cardiac surgeons, with respect to neuro interventions and neurologists and neurosurgeons, how are the study outcomes results as of now, and how it will be futuristically?
So at present times, endovascular treatment is the first choice. Only if it fails, then we go for this one. And in moya disease, where there is a lack of vessels or there is ischemia part, there it is little helpful, more helpful. In the emergency cases, it is always endovascular first. Only if it fails, it can be used as an option. Still, it is not, that doesn't have class 1 evidence. Studies are going on for acute stroke cases. So the results of this may be out.
Was there any hemorrhagic transformation of this stroke, the revascularization you did?
No, sir. No, sir. But in the study group, which the study was done, no. So there were 18 patients. In that, 2 patients had hemorrhagic transformation. So large stroke, generally it is avoided to prevent hemorrhagic transformation.
So neurosurgery is a fast slipping specialty. Soon surgeons will have no job is what Dr. Yatish is implying. We are a rare minority here, even in this hall. So I don't think there are any questions from anybody else. Thank you, Dr. Sandeep.
Thank you.
I welcome Dr. Karthikeyan, our next speaker on stage, to give the presentation on another neurosurgical intervention in stroke, which has probably not yet got any other substitute as of now. So this is not yet. The bone flap has to be removed surgically. So we have some job left. Dr. Karthikeyan, please take it.
Yeah. Before Dr. Karthikeyan begins, I have a small announcement. We have 15 e-posters. So the poster session is going to start in the outside lunch area. So there are two, e-poster provisions in just as you enter outside. That is for neurology. And there is one more e-poster little away from the dining area. That is for neurosurgery and neurointervention. I request all students to be around at 12 o'clock. Judges will come at 12:30. So there are some exciting prizes for you all, which will be handed over in the valedictory function. Thank you. Yeah, 1 o'clock. 1 o'clock judges will come. That's all.
Yeah. Can start? Yeah. Good morning and namaskara. So today I've been given the topic of surgical management of stroke. So not necessarily surgical management of stroke is not necessarily removing the bone. We can do slightly better than that. So we'll just see. So this is our neurosciences team working at Apollo Hospital, Sheshadri. So surgical management of stroke can be divided into two. One is preventive and another one is palliative. So preventive can be carotid endarterectomy to prevent further strokes. The STMC, a bypass or revascularization, as my previous speaker has spoken about. And the last one, which everybody knows commonly, decompressive craniectomy. So first we'll start with carotid endarterectomy. So we routinely do our carotid endarterectomies with continuous video EEG monitoring. So consider the spectrum of patients in stroke. So patient 1 coming with acute stroke in window period in a stroke-ready hospital. Note the point, stroke-ready hospital. So if you want to do a mechanical thrombectomy for the M1 cutoff, the clot is removed and patient has excellent outcome. No questions asked. So the other extreme is acute stroke, established infarct, referred from a distant place. By the time he lands up having established infarct, lands up with decompressive craniectomy. So these are the two extremes. So what I would like to stress upon is the patient 3, that is who comes in between. So having recurrent TIAs, minor strokes, investigation showed carotid stenosis. So next, there is again that controversial, whether you find the stenosis, then it has to be treated. So many trials have proven that carotid stenosis prevents the reduction of stroke in prospectively. So whether to do stenting or whether to do endarterectomy, that is a separate talk by itself. So I won't go much into it. So carotid endarterectomy is still a viable option and it reduces the morbidity and mortality and prevents future strokes. So we can put carotid endarterectomy as tertiary prevention. So all the studies till now, all of them have shown that symptomatic carotid stenosis, along with best medical management, gives the best outcome for the patient. And it gives a reduction in stroke rate for maximum for 50 to 70% stenosis, about 15 to 17% at 5 years. Even for asymptomatic stenosis, 70 to 90%, it gives a reduction in stroke rate to the tune of 13.4%. So we routinely work up our patients with carotid Doppler. Then we do a CT angio of the neck to see for the extent of the plaque and more so to see the level of the bifurcation. If there is a very high bifurcation, if it is reaching C2 level or above, it's very difficult to access surgically and we preferably don't prefer those patients for endarterectomy. Then we do a MRI brain with MRA to see for existing strokes, which side, which is on the symptomatic side or on the non-symptomatic side. Then we do a DSA to see the ACOM, PCOM, the collateral flow, which gives us a rough predictor about what will happen when there is cross-clamping. We continue on single antiplatelets. Aspirin is continued throughout the day of surgery also. Clopidogrel is stopped. Cardiac and systemic evaluation for prognostication. Intraoperatively, general anesthesia we use. Then on incision, we give 1 gram levetiracetam, 20 grams mannitol, 4 grams of Dexona before cross clamping. 500 units of heparin given 3 minutes before cross clamping, and all procedures are done under continuous EEG monitoring. So till now, we have from May 2012 to March 2024, we have done 68 patients, majority are males. 41 is for symptomatic carotid stenosis and 27 is for asymptomatic. 5 patients had a floating thrombus. 13 patients had varying degrees of bilateral stenosis. 22 patients underwent carotid endarterectomy and CABG in the same setting. So the average cross clamping time in our series is 32.64 minutes. So I'll show you the some interesting cases. This is one case where there is a patient age was the most important determining factor. She was 81-year-old. Generally, surgical intervention we avoid above 75 and above. But since she had only hypertensive, she is well preserved, and we found there is no contraindication for her. So we went ahead and did a endarterectomy. And this is a patient on follow-up. She is absolutely fine. And we'll show you the scar. It's almost invisible. So this is the intra-op EEG monitoring. There was no drop in the EEG, and it remained the same for a cross-clamping time of 36 minutes. This is a second slide. So this is a young patient, hypertensive, smoker, hyperhomocystinemia, presented with left hemiparesis for less than 1 day duration. It showed a shower of emboli on MRI, and on CT angiogram, it was found to have a soft thrombus with a floating thrombus. So this is, we are opening the carotid artery. This you can see the soft thrombus here, floating thrombus, which is very friable and it can get embolized anytime. So first we dissect out the floating thrombus. Generally, it is attached to an underlying plaque. So it is not enough you just remove the floating thrombus, even the underlying plaque should be removed. Otherwise, the floating thrombus will recur. Here you can see the blood clots there. That was ulcerated part of the plaque where it was stuck, the floating thrombus. So that is the removal of the floating thrombus. Then this is the ulcerated part of the plaque. So now we go ahead and remove the plaque also. So to prevent recurrence. We just dissect it off from the intima and then it just comes out. That's it. It's clear now. So, and we close it. This is his cross-clamping time. Again, there will be found no changes on EEG. This is another interesting case. So here we found the carotid stenosis and the ICA is completely thinned out. And then we did a DSA. So the external carotid fills first, and then the faint blush of the internal carotid appears. So there is a significant circulatory delay. So for this patient, we went and did endarterectomy of the external carotid so that it would facilitate our revascularization. We did an external carotid endarterectomy. Then we did a STMCA bypass. So after the bypass, you can see the bypass is working and the cerebral circulation time has improved. And this is a patient on follow-up. He's doing absolutely fine. Sorry about it. There's no voice over here. Cross-clamping time in him, when we did, there was on cross-clamping, there was a drop in the right frontocentral leads, but on releasing of the carotid clamp, it settled down, and even in the follow-up, he had no deficits. This is just to show that 76-year-old, even asymptomatic carotid stenosis, on serial follow-up, he had increasing level of stenosis. So we did a carotid endarterectomy on the right side. This was a stenosis. So on follow-up, he is doing well. There was no problem. And the carotid was fully opened up in the post-op angiogram. Same, no changes on EEG. This one showing because some patients with CABG who are planned for CABG on doing angiogram, they have a significant carotid stenosis. Most of the times they are asymptomatic. But since they'll be put on a bypass during CABG, the cerebral circulation can get reduced and may be prone for infarcts. So in this setting, we do a carotid endarterectomy, followed in the same setting under the same anesthesia, they go ahead and do the CABG also. We have around 20 cases in our series. This one I have specially introduced because this has this patient was difficult. So you can see this plaque here. This was highly calcified. So this highly calcified plaque had thinned out the vessel wall so much that the vessel wall was very difficult to suture. So on suturing, post-op this thing angiogram showed a flap like this, intimal flap. Sorry, there was an intimal flap. So we could have followed it up, but to be on the safer side, we put a stent over it. So endarterectomy followed by a stenting also was done in this procedure because to save the patient from the complications. Primarily, why stenting was not preferred because it was a completely calcified and it was concentric, and we thought it would not be favorable for stenting. So our results on 63 endarterectomies, no carotid shunt was used. Everybody was cross-clamped and under EEG monitoring. Post-op CT MRI angiogram was done in all patients. One stroke patient died on the 12th post-operative day. This patient had multiple cardiac comorbidities and there was post-operative lot of ischemic insult. So one patient we lost. The other patient with poor cardiac function returned to the emergency and he died of sepsis from the cardiac valve replacement. Then one patient required a carotid shunt in non-flow limiting intimal flap, this case which I discussed. So the question is EEG really necessary? So EEG both ways, till now we have not found any patients, we have not found any major deficits. One patient had an intraoperative EEG changes that reverted after cross clamping and he had no deficit. In the other patient whom we lost, he had no changes on intraoperative EEG, but the patient had an ischemic insult. These are the two outliers in a series. So to summarize, intraoperative EEG monitoring predicts the safety of carotid endarterectomy under GA, and meticulous carotid endarterectomy technique rather than the cross-clamping time is the key. So moving on to the second part of my talk, decompressive craniectomy. So as we all know, according to our cases we discussed, the second case which I discussed. So if he comes in such a bad state, the only thing which we can do is we can salvage his life. Anyway, we can't salvage his brain. So we need to do a decompressive craniectomy. So this is a sigmoid curve for the ICP. So this part from this yellow part is there. This is the only part where there is compensatory response and where the brain can be salvaged or the life can be salvaged. Once you cross this part, then there is increase and there is very minimal changes after very minimal advantage of doing a decompressive craniectomy. So what happens after decompressive craniectomy is there is a shift of curve and there is increase in the compliance. So this is why we need to do a decompressive craniectomy. So decompressive craniectomy outcomes are: one, there is reduced infarction size, increased cerebral perfusion, reduce the overall mortality and the hospital stay. Factors are: one, the technique of surgery, the anatomical site, age, and the rate of deterioration. Complications: it reduces the in-hospital mortality and local wound complications are expected. So all the studies, the decimal study, Destiny study, Hamlet study, all of them have shown: one, there is reduction in mortality and there is reduction in hospital stay. So clinical and radiological predictors, NISS score of 20 for the dominant and 15 for non-dominant strokes, younger patients, early hyperdensity more than 50% of the MCA territory, infarct volume on imaging of at least 145 ml or more, that has almost sensitivity of 100%. And diffusion or perfusion MRI done early 6 hours post-ictal can predict malignant transformation with high specificity. So timing of surgery is again controversial. So in general, if you want to do a decompressive craniectomy, the dictum is we do it as early as possible in order to salvage the patient. We don't wait for the patient to herniate or watch for signs of herniation. If it has to be done, do it early. So generally, early surgery before the onset of clinical signs has shown better outcome, and dominant hemisphere decompression are less favorable. Patient selection, any early signs or refractory intracranial hypertension if you are doing ICP monitoring. Younger age patients are associated with better outcomes, but age alone should not be a criteria to decide because elder patients given up done properly and adequately early do well. Pre-existing underlying comorbid conditions, diabetes, hypertension, and cardiac illness do play a role in their outcome. Large infarct volume and signs of brain herniation, obviously we have to do. And last part is very important. We need to discuss with the family what they are going through and what is expected after surgery. Because just doing a surgery by themselves, you should explain to them about the rehabilitation, what they are going to get. After that, proceed with surgery. So from 17 to 24, 2017, we have done 46 patients. Most common indication is malignant infarct. On follow-up, we have found best functional outcome with venous infarct patients. In our clinical practice, what we follow is aggressive and early decompression for younger patients and those with venous infarcts. Early decompression before the onset of clinical and radiological signs of herniation. We use a small silicone sheet or which we place it under the temporalis muscle. So the muscle dissection and the postoperative muscle atrophy doesn't happen. And cranioplasty, we preferably use the autogenous bone flap. We preserve it in the anterior abdominal wall. Just a few slides. This is a venous infarct, decompression, and this white line which you see is the silicone sheet. It's not the bone. So it helps us in doing the cranioplasty and reduces the muscle dissection. This is again one more case for venous infarct. This one is for MCA infarct. So I think I kept it brisk. Thank you.
Thank you, Dr. Karthikeyan,
Thank you,
for
sir.
this life-saving talk. Before we go to the audience, I would like to ask you a question which haunts even the neurosurgeons probably. Now we have clear guidelines for decompressive craniectomy in younger patients. There is a sort of cutoff for what we need to do for an elderly patient who comes with a malignant stroke. So how do you go about it?
So generally in elderly patients, we are also not very aggressive. We see we see a patient as a whole, his clinical comorbidities, what are there. If he is highly comorbid, lot of comorbidities, diabetes, hypertension, renal failure, we generally explain to them saying that, see, it's not a very worthwhile. And preferably we give preference to the dominance also. If it is a non-dominant, then we give. If it is a dominant side, we generally tell them better to have best medical management. We are not playing God, but you have to take a balanced decision.
Exactly. So that's the dilemma there. Do you influence the decision of the bystanders or
we don't try
them a
to.
neutral stand?
No, sir. We don't try to influence the decision. We lay open the options. We help them make a learned decision. We don't tell them don't do.
Thank you. Topic is open for discussion.
Thank you, sir. Nice experience of share. Sir, my doubt is that patient whom you did that endarterectomy, you said within 24 hours. Usually it is recommended that endarterectomy should be done as early as possible. Up to 6 months we could do. Within 2 weeks, best results. But sir, after 48 hours.
You are talking about the floating thrombus, sir?
You had a patient who underwent endarterectomy within the first 24 hours. Ischemic stroke, acute ischemic stroke.
Yeah.
You did a carotid dissection and opened the thrombus.
Yeah, see, that patient had a floating thrombus. We didn't want to risk of the embolus of the floating thrombus. So we went ahead and did.
Oh, is it recommended, sir? Because generally it is recommended wait for 48
Generally, we
hours.
wait for 48 hours, sir, since it was a floating thrombus and it's very risky. Even if a small thrombus breaks out, it will just embolize and it will be an in-hospital stroke. So that's why we went in. I agree, sir. We have to wait for 48 hours just because of that young patient, and we just went ahead and did that.
And the another out of the box was the picture which you showed, an intracranial stenosis. You had done a stenting there.
Yes, sir. So that is because of the intimal flap.
Sir, just to clarify your question, Dr. Meenakshi, that was a young patient who had a very tiny ischemic stroke. So he had very little deficit, and there was a huge donut sign with a floating thrombus which is attached to the intima, which was producing significant obstruction also, 70 to 80% obstruction, and it was floating. So this was a high risk in a young patient. So we took an informed decision, taking the family into consideration. And then the patient did very well after that. So it was not the usual guideline. Sometimes we give only anticoagulation and floating thrombus, we wait. But when there's an obstructive thrombus and minimal stroke, we felt that the patient might benefit. Coming to the second one, sir, that was not intracranial stenosis. That was a large stenosis of the internal carotid artery, and a flap was there post-carotid endarterectomy, intimal flap, to flatten the flap and open up the vessel completely. And the patient had very tiny stroke as well. So we did a additional, Dr. Sharak did a carotid stenting as well, sir.
Is there a role for awake? You can ask that.
This is regarding the hemicraniectomy for venous stroke. So unlike the arterial stroke, venous, even though we call it venous infarct, it is more of an edema. So I think we have to be a little more conservative in going for hemicraniectomy, because most of the time it is in the superficial, not deep. They may have some, they may not go in for an uncal herniation. In case they have a severe ICT, a low GCS, it would be preferable to go for an intervention and open up the superior sagittal sinus rather than go for, because whatever in my experience, I found that doing hemicraniectomy invariably causes some deficit. Most of these patients recover without deficit, but hemicraniectomy invariably leads to some deficit.
Sir, the two parts of your question. So for a venous infarct, whatever the mass effect is causing, we don't want to produce any other infarct, like a PCA infarct or any other damage, further damage. So one is that. Second thing, all of our patients, initially we try with conservative medical management. On serial imaging follow-up and the clinical condition, if there's deterioration, we take up for surgery. And to the second part of our question, none of our patients have deteriorated after decompressive craniectomy. I mean, just a small point, that age is the contraindication and we should not, but age is a very chronological age is not the only thing. People with 70 years of age may be worse than a person of 80 years. Yes, sir. Get, comorbidities and other things. So I just wanted to make a point.
Yeah. Regarding the venous stroke, what you were highlighting, what I feel is the decompression is one part, and the revascularization or even the decongestion of the venous sinuses is another part. Both the mechanisms are different recovery. If patient needs a decompression, 100% he needs a decompression. But the question is whether you want to do a catheter-based intervention and then do a decompression. That's a bedside decision which we have to take case on case basis. What do you say, Dr. Sharath? We have done at least 3 or 4 cases wherein we have shifted to cath lab, recovered the clot and then shifted for decompression.
Yeah, we have done 5 to 10 cases till now where the combination has worked better than standalone procedure.
Correct.
We have reopened and shifted the patient so many times from directly cath lab for the decompression, where we could save so many bad cases, and they have come back very well actually. So we open it and try to, because unlike a mechanical thrombectomy in arterial stroke, here the thrombus load is very high. We don't try to give angiographic results, but it's like a debulking of the clots and increase the cerebral circulation time. And simultaneously, the most important is to manage the ICP here. So we do often simultaneously, and in our short experience, the simultaneous, both the procedures complement each other, and the combination has done much better than standalone.
Unlike the arterial stroke, where once the infarct is set in, you do you do decompression and leave it, and you send for rehab. But in venous strokes, definitely, as you said, debulking, reducing the thrombus burden, and then doing decompression would be ideal in a given situation.
Actually, if I want to put one word about it, decompression craniectomy decision is a very complex decision taken together by the neurologists and neurosurgeons, and the role of neurocritical care team, or the people those who are treating actually or monitoring the patients, their role is equally important. In most of the hospitals in tier 2 or tier 3 cities, I'll tell, it's a common ICU when the patient goes there. So the ICU team keeps on looking at all kinds of patients. A second aspect is venous stroke. What you're saying that those who have decompression done, the venous stroke patients, they do have some deficits. It's actually those are the ones who require decompression craniectomy. They are the worst kind of candidates. They are rapidly deteriorating. There is a source of herniation. There is a evidence of herniation. So you are putting them for this thing. And that's one part of the life-saving measure for such patients. And decompression craniectomy is always, as usual, taken as a life-saving procedure for the patient. Because those who survive, they only cry. So keeping that in mind, I think decompression craniectomy is a very individualistic decision. In every particular case, it might be different. Like a patient whose age is not a bar, but see, if patient has got a dominant hemisphere large infarct and 85 age who has lived his life, doing a decompression craniectomy is actually putting salt into his problems.
So, but then again, it is the family member's decision because you have to clearly say them why you are doing it and what could be the best outcome for it. And what are their liabilities and responsibilities after taking the patient back home? Because any stroke patient who requires a deconflictomy will certainly not be walking in a couple of weeks. So they take months together for being bedbound and with the all rails, tube catheter and all those things and strict physiotherapy and nursing care, home-based nursing care. So how far actually people are ready to do that? And in particular, like wherever this decompression kind of facilities are available, I mean to say when surgeons, neurointerventionists, neurologists, everybody is available, it's mostly urban area. And patients do come from the rural areas. Do they have that facility to monitor those things? We do a tracheostomy, we put up a TU, we do everything, patient goes back and after 7 days, patient comes back with sepsis and died. So keeping, we need to keep all these things in mind. This is not very simple and clear.
Just one comment regarding the monitoring during carotid endarterectomy. It makes quite intuitive sense to have continuous TCD also.
Yes,
Along,
sir.
probably along with the continuous EEG monitoring. TCD also would show you hits. So we use that sometimes during carotid stenting.
Hello, sir. Even though CA has shown like long-term efficacy and better, lesser recurrent strokes rather than endovascular carotid stenting, but recent some studies they have shown that carotid stenting also has comparable.
See, I'm not
So how do you
advocating
go-
or getting biased towards endarterectomy. We in our series, all the patients have a team discussion. We have done equal number of stenting also. And second thing is, once you have stented, he's on dual antiplatelets. So we know the complications of dual antiplatelets. So that is there. And second thing, all patients who are undergoing CABG, stenting antiplatelets is a strict contraindication. So in those patients, it becomes an absolute. We have to do endarterectomy. We can't put him on a stent. Thank you.
A last question.
Yes, sir.
Is there a role for awake carotid?
Yes, sir.
endarterectomy?
There are series which have been described where endarterectomy can be performed under cervical block. Patient remains awake. Two things, one for patient, one for us. Patient, it's very uncomfortable to stay in this position for a prolonged period of time, say around 2.5 hours with 30 minutes of cross clamping time where he has to be absolutely still. If you get such a motivated patient, can definitely go ahead. And second thing is surgeon comfort.
Thank you. Thank you, Dr. Karthikeyan, for this wonderful talk. We'll have a tea break now.
So, thank you, one and all. So before the tea break, can we all assemble for a brief photo session, sir? I request all the speakers and the organizing committee to join on to the dais, sir. There is an important announcement as well. I request all the delegates to vacate their rooms by 12 noon today. They can check out. They can keep the luggages down at the reception. At the cloakroom, yes. After the photo session, we shall be breaking for the tea. It's a 15 minutes break. And we shall rejoin for the panel discussion.
Amongst the antiplatelets, I would say rather they're broadly into three categories, and they have their pros and cons, what and how I tried or studied. Aspirin is a cheaper, age-old drug, well-time tested, and is the first preference in most of the cases. However, there are issues and situations where you need to go for dual antiplatelets or you go for phosphodiesterase inhibitors like silestazole or what's the role of dipyramide. We can have a discussion over it. But the first choice, if you ask me, I think the consensus goes for aspirin.
Okay, thank you very much. So, Dr. Moin, so there are certain situations, as Dr. Mishra was referring to, is sometimes you need to use dual antiplatelets. So could you kind of elaborate just a little bit on that? What are the indications for dual antiplatelets?
So dual antiplatelets, based on the current guidelines, can be used for conditions where you have a mild stroke, wherein you have an NHS score of less than 5. You have a TIA, which is high risk. You have an ABCD score of more than 4, or you have an intracranial vessel stenosis of more than 50%. You can give dual antiplatelets for 3 weeks, 21 days. And in case of a stenotic lesion of more than 50%, you can give up till 3 months.
Right. And so what dual antiplatelets would you use under these circumstances?
Commonly, I use aspirin and clopidogrel. If a patient is already on aspirin and clopidogrel and develops another stroke, then maybe I'll think of changing it to maybe aspirin and ticagrelol, preferably.
Yeah. So that's great. So you've already covered one of the questions I was supposed to ask. If a person has a stroke on antiplatelets, what would you do? So thank you very much for that. Ticagrelol seems to have a little more risk of bleeding. Is that right, or is that not right?
Yeah, dual antiplatelets, the studies have shown that they have a little more higher risk of bleeding episodes than that of the single antiplatelet use. I would like to add upon one thing is that if there is associated peripheral vascular disease or coronary artery disease, if the patient is on one antiplatelet drug and has again got it, or the patients do have atrial fibrillation and not ideal for the anticoagulants, there also the dual antiplatelets use has been studied in various trials with very well outcomes. The choice of antiplatelets is again not a very fixed one, like the aspirin and dipyramide combination drug, Adrenox, has got a definite better outcome of the benefit ratio than that of the aspirin alone. But then it went out of the market because of the side effects and not a patient compliant drug. So,
yeah, and the equivalence with clopidogrel alone, that is the other thing. So one tricky situation that become is you have a stroke and there is some hemorrhagic conversion. So how do you handle that, Dr. Moin?
This is with respect to antiplatelets.
Antiplatelets, yes.
If there is a hemorrhagic transformation, we have 4 grades. If you have just some particular hemorrhages in some part of the infarct, I would not change my current treatment regimen. I'll just continue it. Even if it's grade 2 also, I'll not change it. Grade 2 is when you have more particular hemorrhages almost all over the infarct. If you have a frank parenchymal hematoma, which is less than 30% of the infarct size and causing some amount of mass effect, maybe I'll hold if it is patient is on dual antiplatelets, I'll make it single antiplatelet, wait for a couple of days, maybe repeat an imaging. And if it's stable or if it's reduced, maybe I'll restart dual antiplatelets or just continue a single antiplatelet. On the contrary, you have a grade 4 parenchymal hematoma, which is more than 30% of the infarct size with mass effect. I would wait for 1 week to 2 weeks, then maybe start on single antiplatelet if necessary.
Great. Now, another scenario when the patient has had ischemic stroke and is on antiplatelets, or we will come to anticoagulants later on. But anyway, just
if you want to cover both together. So antithrombotics, and now develops ICH. So how would you handle that?
That's a very, of course, a difficult scenario, sir. First of all, the site size and the clinical scenario have to be taken into account, and the need for antiplatelet at the immediate home. So the patient has got associated coronary artery disease, or there is a issue for the valvular or the non-valvular diseases, cardiac associated conditions or peripheral vascular disease, then there's a high risk for both of these things. And then the judiciously restarting antiplatelets, ideal time minimum is around 2 weeks, and then you can go to 6 weeks. 2 to 6 weeks afterwards, you can restart. This is for the anticoagulants as well as it holds good for the antiplatelets also. But antiplatelet addition, you can decide on the site and size of the hematoma. If the patient needs a decompression current with the size of big bleed, obviously you can't restart it. But the risk factors for the ischemic as well as hemorrhagic strokes are the same. So keeping that in mind, you can modify the other risk factors and wait if the size is big. If it is a small one, and then you can restart antiplatelet with a lower dose and titrate it depending on the patient's clinical scenario.
Yeah, or if the patient has a mechanical heart valve or something like that, in which case you would like to bring it earlier, and if not, push it a little later.
That's what I said. If the patient has got cardiac valvular issues,
yes,
then we can certainly.
Right. Yeah. So Dr. Moin, just so the current we'll slowly move into the anticoagulants. So I'm coming to the bridging part. So the COMPASS trial on low dose rivaroxaban and aspirin or clopidogrel. Are you using it? And if so, any situation that you have done?
So I've used this when there's a failure of a dual antiplatelet therapy, and we have done tests for resistance of clopidogrel, and that is still negative. But still patient has a stroke, and they are not tolerating ticagrelol because of issues like bradycardia or breathlessness. Then those are the conditions where I've given a combination of low dose 2.5 mg BD of rivaroxaban and aspirin.
Yeah, that's great. I think it's interesting is, if I'm not mistaken, and please correct anybody if I'm wrong, COMPASS trial was a trial primarily designed to look at coronary artery disease and peripheral artery disease. And in fact, they excluded patients who had strokes within 1 month of the disease. And eventually they found that, there's significant reduction in development of stroke. But that is kind of a fluid area. And that's why I asked whether we are starting to use that. I have used one patient, but that was because of a cardiovascular cause advised by the cardiologist. So that is why, but I don't know. I would really welcome comments on that at some point of time. Another practical question. So we have this 21-day and 90-day thing, which all the studies have shown of the chance and the point and the others. In real life, do you stop at 90 days or 21 days? Hand on your heart.
In real practice,
maybe no.
Maybe no. And well, these studies are scientifically made, and it says that increases risk of bleeding. But dual antiplatelet agents used in coronary artery disease for at least 6 months do not have that amount of bleeding cases. So also in cases of ischemic strokes. And maybe it depends on the study design or something, or that the not taking into account this minor and small bleeds. Most of these patients, they tolerate dual antiplatelet agents well. And of course, if I have to think about the practice and look at the scenario that dual antiplatelet is really going to be helpful for the patient in the long run. If they have peripheral vascular disease, coronary artery disease, or prior history of stroke, then dual antiplatelet agents to be continued for longer time is the benefit of the patient. That is as per the practice standards that people or many of us are following. Guideline wise, pretty different. That 90 days you should not go beyond that. It's not.
Yeah, because at least in one patient, I did follow the guidelines and the patient came back having another stroke. The other option, and would you consider that, is cilostazol, where the study says you can give up to 2 years. So rather than 21 and 90 days, and maybe that would be something to think about as we move forward.
Actually, cilostazol has not been used in acute ischemic stroke in the vast way that the other antiplatelets have been used. Number one. Number two, it has got one theoretical advantage of working as a vasodilator. And the long-term safety efficacy is pretty good. The hemorrhagic risks are not increased in such patients, what the trials show. And particularly patients those who have got microbleeds also and the CNS. There they say that cilostazol is probably going to be better off than the other drugs. I personally don't use it. I haven't used it. So I will keep my opinion reserved as far as my experience is concerned. But yes, theoretically or going through the guidelines, it says that it can.
Yeah, I have used it a few times, especially in patients with microbleeds, and I haven't seen a problem, touch wood, so far. But we'll see how it goes. Very small numbers. But yeah, so that is another issue. Right now, I think we are doing very quickly with time. So moving on to stroke in patients with AF. So we now move to anticoagulants, and you can relax and give longer answers because we have lots of time. So, so first of all, Dr. Moin, what anticoagulant would you use?
It's a non-valvular atrial fibrillation.
Non-valvular. So when I say AF, I meant non-valvular AF.
Non-valvular atrial fibrillation. All major studies have proved DOACs are better than vitamin K antagonists. So among DOACs, all three are equally effective with a direct thrombin inhibitor like product dabigatran or factor 10A inhibitors, apixaban and rivaroxaban. Based on patient preference, like they want once a day, we can give for rivaroxaban, or a patient is elderly, all has prior history of some maybe mild gastrointestinal bleed once, or mild end-stage renal disease. In those conditions, maybe apixaban is preferable. Once a daily dosage advantage with rivaroxaban is there. Advantage of dabigatran is we have a reversible agent in India easily available. So those are the advantages in which we can select one DOAC over the other. But there's no head-to-head trial to say that this drug is better than other with respect to atrial fibrillation and stroke.
Great. So as I said, because we have time, Dr. Mishra, would you like to comment additionally on that?
Yes, as Dr. Moin said, DOACs are now the drug of choice for such patients, but still warfarin, which was age-old and was given for such a long time, is time-tested and it is cost-effective. That's one point. Disadvantages of warfarin is, of course, dietary modification and repeated during the blood test for maintaining the INR between 2.5 to 2.5 to 3.5. So far as DOACs are concerned, dabigatran has got lesser GI bleed complications as far as I have seen the patients. And apixaban has got little more, but apixaban is tolerated. It has got less ICH than in comparison to dabigatran. There are studies to suggest that. But efficacy-wise, more or less, they all are the same. And no large trials have been made yet to suggest that one is better than the other. I still believe that amongst the DOACs, again, as he said, dabigatran and apixaban are the two preferred choices at present, as far as my practice is concerned.
And so what if a patient is on, Dr. Moin, already on warfarin? What do you do with them?
If a patient is well maintained on vitamin K antagonist, there's no point in changing the drug.
Yeah. I mean, the only problem with warfarin and real life in our country is that people don't come for regular follow-up, and ever so frequently they come with an INR of 1.5. And it doesn't work. You need a therapeutic range for at least 70% of the time, more or less, plus minus. And that's really hard to achieve unless you are regularly following up these patients. So that is a big disadvantage for warfarin and an advantage for DOACs. You have, Dr. Moy mentioned some of these situations where you choose the DOAC one over the other. That's great. Now, a question which frequently comes is that, so this person has come with an acute ischemic stroke. It typically looks like an embolic stroke. There is no AF, but on pushing and prodding, there is a history of AF around 3 years ago, which was paroxysmal noticed by the cardiologist, and they didn't do anything about that. So regarding AF and anticoagulation, the types of AF, your comments, please, Dr. Moin. So, there are different types of AF, right? Paroxysmal and, persistent and permanent. So here was a situation where the cardiologist has a paroxysmal AF 3 years ago, did not do any anticoagulation. The patient has come 3 years down the line with a stroke. There is no AF on ECG now. There's no AF on the monitor. There's no AF on Holter. What do you do?
So we have a good score in form of CHAD-VAS score. So based on that, you see what is the score. If the patient has a score of a male, a score of more than 2, a female, a score of more than 3, I think the patient deserves a chronic oral anticoagulation. We also look at if you are still having a doubt whether you don't, in a baseline ECG, you don't have atrial fibrillation, you can go for a prolonged Holter monitor, 72 hours or 1 week or even 28 days. Also look at a morphology of the ECG. You can do a transthoracic echo and see if there's a left atrial dilatation. You can do a transesophageal thing, see the left atrial appendage. And there is a new entity called left atrial cardiopathy or atrial cardiopathies, wherein the left atrium itself is thrombogenic. You may not require atrial fibrillation for a person to develop a stroke, embolic, what I'm saying. So these sort of things can help you to maybe decide whether a patient requires an anticoagulation or not. So the simple thing is a CHAD-VAS score. Then based on the other prolonged Holter monitoring, 8 days or 28 days, and the morphology of the left atrium, you can take a decision whether a patient requires an anticoagulation.
Yeah, would like to come.
I'd like to, sir, add one thing. Most of these patients, even if it is not having AF, if you look at it, most of these patients, those who have come with a history of AF and now has come with a stroke, the long-term monitoring, as Dr. Mohan was saying, is very helpful because it is not only AF, but non-sustained VT or paroxysmal VT can also cause this one. There's a very big, large trial by the Chinese population, around 10,000 people have been monitored. They have monitored the long-term ECG monitoring for more than 9 months. And they found out that more than 80 to 85% of patients do have some amount of cardiac arrhythmia, which might have triggered the stroke in such patients. And their using anticoagulant is definitely a great choice for us.
Yeah, I think both of you have made the important point that, I mean, it is not if you had an AF some time ago, any AF, paroxysmal, permanent or persistent or whatever, indeed, even thyrotoxic AF, which is sorted out, if you had AF ever, it's a good idea to strongly think about anticoagulation and then do your, CHAD-VAS and other things. As far as atrial cardiopathy, Dr. Moin, there has been some studies, but I think we're still fluid there with very strong evidence of whether which one to treat and which not to treat. And I think it's a very interesting area where we are
The pattern of the strokes is like embolic. You have multiple territorial infarcts.
Yes.
Cortical-based infarct. And you have a supportive evidence. I think preferable is to give an anticoagulation.
Yeah. No, what I was saying is we still don't know what is important. Is it the left atrial dilatation is important? What is left atrial dilatation? We were talking just a little while ago about Indian data. I strongly feel, and I've done some work on it with my PGT who is in this room, and I very, very strongly feel that the Western LA diameter sizes are nowhere near Indian or the other way around. Indian LA diameter sizes are nowhere near the West, and we have I think we should define atrial cardiopathy differently, but from there you go. It's a very interesting topic. So going back to that question of restarting, did we ask restarting DOAC after ICH? Did we cover that? So Dr. Mishra.
Sir, if a patient was on anticoagulant and has developed ICH, these studies suggest that you can restart anticoagulants depending on the patient's clinical scenario and the need for the DOACs between 2 to 6 weeks. So after 6 weeks, you can start most of the cases, but if the early warranted, then you can start 32 weeks also. And the data suggests that it's not going to cause much harm in the patient. And of course, in between monitoring is required if the patient's clinical condition is deteriorating after starting the drugs, go for repeat scan and then see if the split size is or anything. And if it is not so, figure out what are the other causes of the deterioration in the clinical condition rather than just to stop it without giving the medications to the patient.
So also, as Sir said, look at other causes, like if it's a deep basal ganglionic bleed and patient had high blood pressure at that time. So if the hematoma was predominantly due to hypertension and not due to maybe the oral anticoagulant he was taking. So maybe at that time, if it's well managed, the blood pressure is well managed and the hematoma size is stable, maybe you can start early. Because the culprit in that case was not the oral anticoagulant he was taking. Blood pressure was the culprit. So I think those things, as in these questions, I think individualizing treatment is the most important thing. There's no guideline as such.
Very true. Personalized.
Guidelines are to guide for majority of the patient. These are like you have to individualize treatment. No size fits all solution is not there. So we need to find out, is there a culprit for it other than the oral anticoagulant? If it's there, it might have been a trauma rather than this. So those sort of things we need to take a decision.
Lovely. So if the patient was on dabigatran and now you want to restart, would you change to apixaban or would you just carry on with the dabigatran?
There are no studies to suggest as such that one or the other DOACs is safer than the other one. Except that, as I said, apixaban has got lesser ICH than the GI bleed in such patients. So it is the individual's choice if he wants to restart the drug with dabigatran in a lesser dose or change over to apixaban. But I believe there are no such guidelines to suggest what we need to be done. For me, if I feel it is the patient is on dabigatran and now has got a bleed, I will reduce the dose and start it. And if it is the bleed is not, as he said, is not because of the drug itself, like a small thalamic or a small basal-ganglia bleed, it's probably hypertensive bleed. The patient is a known hypertensive for a long time. Then I would rather continue the same medicine and lesser dose. If it is 150 milligram, then I'll reduce to 110 milligram and then see wait and see. Similarly, if I see that patient has developed renal insufficiency leading on to requirement of the dialysis and other things, I would rather stop it and start with the antiplatelet rather than going for anticoagulant. Because that's what they say, that if a patient has got the other reasons to have this, then drugs might be contraindicated in such patients. Because as in our scenario, what you were saying, patient come after a long time, 6 months, 1 year, 1.5 years, they have gone to the nephrologist and shown it, and then they're following it there itself because they know that, okay, nothing beyond the medication changes are needed for the neurological breaches. And the nephrologist also might not have gone through these things so that to continue with the workshop.
So a patient comes with another difficult scenario, 120 odd kilo patient, or 130, morbidly obese. Patient has ischemic stroke and a non-cardioembolic, a cardioembolic stroke with atrial fibrillation. There is no data. But what do you do, real life? What would you do? Maybe you have or have not faced.
These are very individualistic, as you said, there are no such guidelines. I would prefer to continue the DOACs in the same 150 milligram of dabigatran or apixaban in appropriate dose of 5 milligram BD dose or something, and then wait for the changes that the patient is having, rather than calculating his body weight and giving the medications, because it's the maximum dose that has been advised to be taken by the patient. And if the patient has got a morbid obesity and with associated complications, I have right to modify his lifestyle and other risk factors. I'll give more importance of focus on those things rather than putting my mind into choosing which drugs and how much should I give to this patient. Because as such 120 milligram goes 120 kg patient with the requirement of a DOAX is definitely has got a very horrible life. So you must have got associated other more risk factors, and it is prudent to focus more on that. Like the people talk about antiplatelet resistance, ecospin resistance, or things. Most of them have found out to be non-compliant to the drugs rather than the drug to implement. Similarly, if the patient is on omeprazole and taking clopidogrel, it is the omeprazole which is the culprit, not the clopidogrel, because it has reduced its level. So rather change the omeprazole rather than changing the clopidogrel. That's what I would do.
Very true. Yeah, so would you like to comment, Dr. Moin?
Even for, not only for anticoagulant, even for antiplatelets, many times you may have a different stroke mechanism. We may be giving dual antiplatelet, patient may be having a cardioembolic stroke. So in that case, we need to be sure what is the stroke mechanism. So if the stroke mechanism is different and we simply feel that there's resistance to antiplatelets, that may be wrong. So always we need to be sure about the stroke mechanism. Once a patient comes with a stroke, visit because of an artery. Basically, you need to classify as per the TOAST criteria and find out whether it's because of an artery stenosis, or it's cardioembolic, or it's a small vessel disease. And small vessel disease, as you were discussing about an obese patient, if it's a small vessel disease in an obese patient, it might be more to do with obstructive sleep apnea, which is very common risk factors, very underplayed during evaluation, which nobody treats it. So I think those sort of modifications are more important before labeling that the treatment is failed. So the mechanism should be sure, we should be sure about the stroke mechanism and his other risk factors and drug compliance. Those things need to be checked.
Thank you, that's wonderful. We had spoken about microbleeds during the antiplatelet part of this discussion. So now DOACs in patients with microbleeds. So what do you do and how do you monitor that?
So far as microbleeds are concerned, sir, most of them, they do not require DOACs. Because the mechanism of having microbleed and
No, sorry, my question. So I didn't say DOAC for microbleed. You have a patient who has an atrial fibrillation, ischemic stroke, microbleed.
There actually, there is no standard guideline to suggest in this scenario what to be done. But I think if the AF is the predominant factor and has presented with a sizable stroke, then one has to consider about, say, dual antiplatelets like aspirin and silostazole, because the literature say that in microbleed cases, it's better to go for silostazole than that of anticoagulants. But if the anticoagulants can be given in a lower dose and then see that the response to the patient and how the best the patient is complying with it. Because the microbleed as such do not happen as the basic mechanism of microbleed is the atrial structural anomalies or say abnormalities, inflammation. So rather than stopping the anticoagulant in such patients, I think one can modify.
Yeah, so there's no justification for stopping anticoagulants. The monitoring, I think you have various monitors for risk of hemorrhage, like the Micon ICH, which has come, which seems to be the most effective one. You follow that up, you see if there's very high risk, then you kind of check blood pressure, stop the alcohol, and do the various other things. That's, I think, the way forward. But what about CSS, cortical superficial siderosis, Dr. Moin?
Cortical superficial siderosis is supposed to be a marker and which carries a higher risk of lobar hemorrhage. If the patient has atrial fibrillation and he requires a DOAC, maybe a low dose apixaban with close monitoring. So serial monitoring of imaging to see is the CSS or the microbleeds, are they significantly increasing in the interval scan? That may give us a clue to start or continue the anticoagulant.
I would agree to him. Only thing is the CSS patient.
One more, sir. Sorry. One more option is if you have an atrial fibrillation with a person who has a microbleed or even a CSS, one option is a left atrial appendage closure. I think that is one option where you don't need to give pharmacotherapy for it.
Well, yeah, as long as the risk of bleeding is not so high that you can't give the antiplatelets for the first 45 days, because left atrial appendage occlusion, you still have to give for the first 45 days covered with the antiplatelets. But yes, I mean, that was my last question. You've covered that all. Thank you very much. Would any of you use the Boston score to kind of rate the CSS and decide whether you would like to or not like to give anticoagulants?
As far as I have gone through literature, I didn't get it.
It's a severity, CSS severity score. Yeah, it's a severity score, and I think yeah, CSS is always tricky, and it's kind of best to hands off from that as much as possible as far as anticoagulants is concerned. So I think we have covered some essential topics. I hope it has helped the PGTs to some extent. Now we have 10 minutes to go. And it's open for comments and discussions. Any question you would like the panelists to answer, please go ahead.
The only sharing on tough situation we recently had, so 2 patients. Valvar AF came with stroke. Both of them were on warfarin, acetron. Therapeutic INR. One had a left PCA infarction, one had vernix aphasia. One of them, the carotids were clean on CT angio, another had some 40% stenosis, 45% stenosis. Acute stroke, they are admitted. How do you manage them? How do you transition? What anticoagulant to suggest? What should we do in this situation?
Who would like to answer that?
So that 40% stenosis, was extracranial.
Extracranial, yes, sir.
I think maybe the plaque characterization will help us to know whether there's a possible unstable plaque. And if that is the case, maybe a high dose statin, addition of a single antiplatelet might help you.
Yeah, the other one was completely clean, sir. Absolutely.
PCA.
We did, sir, every patient receives high dose statin for us. We did give that. We gave the option of antiplatelet. The other one was completely clean carotids. Vernix aphasia.
Basically, adding a single antiplatelet low dose is another option. Because in valvular, you can't give a DOAC. Already in therapeutic INR. So the only other option is to add on maybe a low dose of single antiplatelet.
That acute phase, you continue acetron as such, or you give for a short time?
We can, if we are sure about the INR was in therapeutic range, we can continue, or we can change over to low molecular weight heparin for the interim.
I have a question regarding the antiplatelet. There are a lot of resistance coming now, both for aspirin and clopidogrel. Do you have to do every patient this resistance testing for genomic, or you have a selective criteria where and when you will use it? And if that is so, which is the other antiplatelet like tigaglor? Do you use that?
So far as this polymorphism induced resistance is concerned, the commercial kits available have not yet been standardized. And the results are not very robust. They have not been tested. But in research purpose, people have done it and then found out that yes, if somebody has got the resistance for one particular type of polymorphism, they can change over to the another drug. Most of the times, what we call as resistance is because, as I said, a patient is a hyperthyroid or hypothyroid, then the clopidogrel level gets variable. The warfarin level gets variable. What are the drug-drug interactions that the other drugs patient is taking? Might be these are the things, and the lifestyle modification is the more focused thing for us. And wherever it is available, one can do it, like the metros or areas where it is easily available, one can go for it. And then they can choose about the other drug. Yeah, as you said, ticagrelor or parsugrel or anything. One can think about it. Ticagrelor has been used and right now has been come up with a big way about the role in acute strokes. One can choose over about it. But however, both aspirin and clopidogrel, both having a resistance is unusual for any particular patient. And then, as I said, the use of PPI, like those who have diabetes and high LDL level, they are more prone to have weaker aspirin level. Second is the entry-coated tablets are inferior to the non-entry coated tablets. So one can think about it if they feel that yes, this is the modification is the best for the patient, can go for it.
We did a study in our hospital of patients who come with a stroke who already had either another stroke or an MI, and we looked for clopidogrel resistance in them. 60% of patients had resistance. That is, instead of the 1-1, they had either they had 2-1, and 15% had 2-2. That is, the 2-2 variant means there is no enzyme at all. That is, they will not respond to clopidogrel. So 60% is a huge number. And even with in the general population, it is believed that 30% have partial resistance to clopidogrel. So I feel any patient who is put on long-term clopidogrel should have resistance tested. And probably if they are found to be partially resistant, preferable to use another drug.
Asking the question was the Indian data is very less, and whatever has been published has shown that it is very high. Is there ethnic differences? Is there a polymorphism which is different? These are the things which we need to work out. And then we have to have a study prospectively to do that. And that is very, very important. That's why I'm raising this issue.
Only thing is there's no guidelines, there's no empiric advice for doing clopidogrel testing.
That is not there because the data is not there. So since we need to generate the data, then only we'll be able to do that. The guidelines will come afterwards. And where will the guideline come from? It will come from the West. We have to have our own data, and we will have to have our own the guidelines. The reason for that is whatever the preliminary data has been published or presented shows that there is a higher resistance among the Indian ethnic population. Indian ethnic population, there is a problem. We cannot consider the whole India as one because there are a lot of ethnical differences are there. So we need to work from that angle also. For example, if the Northeast person is there, that is entirely different. So ethnicity itself is different. So we need to look from various angles. I think this calls for a study which is a prospective, multicentric, forward-taking study, which can only give the answer, because we are all seeing the patients who are coming with recurrent strokes. That is the worry. And younger people coming with a recurrent stroke at 40 years will lead to a major problem. That is what my worry is.
Antiplatelet resistance. I just add one more point, sir. Actually, the resistance in the West is 2%, whereas studies done in Karnataka and Tamil Nadu, it is 20% in the general population. Yeah. It's 10 times more than the West.
Yeah, most of the cardiovascular trials, they have proven antiplatelet resistance. But I don't think the demographics will change much if even stroke patients as well. The only thing what is lacking, as sir said, is the data. Unless we, have a multicentric data. We are doing one study now for our DNB student. We did 5. Out of 5, 4 have come as antiplatelet resistance. Already they have, it is too small number to comment on, but I'm just telling you the general trend. So definitely, and we have to do a pan-India kind of a study. As of now, only 2 studies are there. One from Dr. Rohit Bhatia and one from Patel and team. That is very small number. If you see 65 patients and 304 patients. So because there is no data, nobody is able to frame any guideline. It's high time.
Sir, actually, you should include all of the doctors because Apollo has got center for there. So you should spearhead this thing. Mr. Sir, you have so vast experience on this.
Mike.
Because we don't have any data from India in a consistent fashion. We have small pockets of information that doesn't really generalize for the whole population. And also, as Satish Chandra mentioned, we do have multiple ethnic groups within. We have tribals, people from Northeast. I'm sure they have different genetic patterns, both for preventive, even in terms of dual antiplatelet function resistance, how to even treat acute strokes, whether you start with high dose aspirin, low dose aspirin, when to change your regular to single monotherapy. I think all these, we need data on this from India. I would sort of really
I think we
Very
need to
true.
have that, the facilities having Apollo at all the places. Like I come from Bhubaneswar, people's eating habit or the other vices and other things are very different from the people who are from Himachal. So you can spearhead this research and you can circulate the proper one so that the data can be collected and compiled.
Other questions?
Northeast, we have a higher hemorrhages, very common. And this has come up for the study in ICMR. ICMR, number of studies have come out now, and that is due to the tea. They consume a lot of tea, the tea workers. Among the tea workers, it is very, and that is what is tea plantation workers, those who are plucking the tea with tea. So what is that difference is the question. So like that, we need to look at from various angles for this study of this nature. I think that's why I was raised this point, just to stimulate the brain.
Sir, what is the role of anticoagulation in posterior circulation stroke?
In
posterior circulation stroke, role of anticoagulants in posterior
posterior
circulation
circulation.
stroke.
Posterior circulation stroke of what etiology? Whether
Sir,
it's embolic or
thrombotic, sir.
the common thinking is posterior circulation stroke is very commonly due to embolic. That's the reason you have a higher chance of hemorrhagic transformation. So basically, if the vessels are clean, so then look for atrial fibrillation, do a prolonged Holter, and if you have an evidence, you can start an anticoagulation. Otherwise, give a single antiplatelet aspirin.
I think one thing we should always keep in mind is that none of our medicines are going to protect us 100%. Aspirin, clopidogrel, whatever it does, it brings down the rate of a recurrent stroke by 30-35% maybe. So it's not that every person who has to take aspirin should never have a stroke in life. All the studies tell us that it brings down the risk of stroke. It's a risk reduction. It is not an absolute treatment. So yes, it is very important to look for resistance because we are seeing that, but that will be just one of many things. And probably nobody has looked at resistance patterns when they looked at the role of aspirin at that time. So it is very important to look at what's happening in our country.
That is why treating the patient is an art within the science.
As far as the question of detecting atrial fibrillation is concerned, when you ask for a Holter, 24-hour Holter monitoring, then now that patch has come, web cardio, wherein you can do it for 72 hours. I would like to know how many neurologists in this gathering have resorted to closed loop monitoring for atrial fibrillation. And if at all they have done, what is the maximum duration for which they have done? Because it is said that longer the duration of monitoring, higher will be your pickup rate for atrial fibrillation.
In fact, there is some data that
I'm not
ILR
asking
is better than
recommendation.
ELR.
I'm asking the practice of the neurologists that have gathered here.
We actually, sir, take the cardiologists along with us, and sometimes they advise for 7 to 15 days, maximum to 15 days. Most commonly, it's 7 days. And if within the 7 days, nothing is picking up, then we leave it as such, and then we wait for the what next to be done.
I have another question. So we do an MRI for some reason. We find a lot of small vessel ischemic changes, vesica grade 2 or 3, small white matter lesion, should we start them on antiplatelets or not? They don't have any TA or stroke, but whatever reason MRI is done, you find a lot of small vessel disease.
See, if you have advised MRI, means there has to be something. And you need to correlate if that is coming handy to you or not. No one will advise just go and get the MRI and I love you. No one will say that. So there has to be some reason for which it comes. And if you feel that yes, this small vessel disease is alarming for him, you need to figure out why it has happened to him. And antiplatelet, starting an antiplatelet prophylactically, I believe is the common temptation for all of us. And I think everyone will start.
Oh, thank you.
Thank you very much. We enjoyed.
Thank you, madam.
We'll have a big photo.
Thank you very much. I thank all faculty, moderator, and the panelists for enlightening us on a very important aspect of antiplatelet and anticoagulation in stroke. So we'll move on to the next session.
Some general announcements to make. A humble request to all the faculty and delegates to check out by 1 p.m. latest. And there is an e-poster competition which is happening outside. The judges would be judging the event. They'll be around 1 p.m. The participation certificates for both the delegates and the speakers shall be available at the reception. So requesting all to collect your certificates from the reception. Thank you. We'll begin with the next session, the debate, which is called the structured argument. May I call upon the chairperson, I think Dr. Vinit Suri is not available. So we have Dr. S. Muthukani with us. So may I request him to join onto the dais. And Dr. Chinmay Nagesh also to co-chair the event. May I call upon the moderator, Dr. Bob Orke, to take over the session. Today's debate will explore more on large core mechanical thrombectomy. For we have Dr. Suresh Gardini, and against we have Dr. Anirudh Kulkarni.
Good afternoon, everybody. This has been a day and a half of wonderfully stimulating discussions. And now we move on to a very important debate on what to do about patients with acute strokes who come with large cores. Do we go on to mechanical thrombectomy or not? Since 2015, the major stroke trials have come out one after another, and the goalposts have been constantly shifting. First, they started with a time limit, then they started exploring patients with large, increasing the time limit. Finally, in the last 2 years, more than 4 or 5 trials have come out demonstrating the efficacy of mechanical thrombectomy, endovascular thrombectomy, even in large cores. But we know that reality does not always meet expectations, and especially in our setting in India, it's sometimes difficult because mechanical thrombectomy does cost a lot to the patient. and the expectations of the patients are very high. And if you go ahead with EVT in a patient with a large core and the patient is left disabled and with an MRS of 5, it does leave a bad taste in the mouth. So do we all blindly just follow guidelines, or among the large cores, are there still a population that will benefit? I have two speakers, one for Dr. Suresh Gangani from Hyderabad, whom I invite onto the stage, and Dr. Anirudh Kulkarni, who will be speaking against this motion. Dr. Suresh.
At the outset, I want to thank Dr. Sherath and the Apollo family for having me here. So as the moderator also already described, that there is an evidence which is coming from the Western population, and we have the reality in confined, like which is particularly sorry, this is coming. So we have evidence versus a reality, which one to choose. And if you're a beginner, beginner of neurointervention, how do you approach it? And if you're already a high volume center doing many thrombectomies, how do you approach it? So I was told to present for large core thrombectomy. So I will try to reveal my ideas and the literature and how I approach. It is not truly for it, but it is more of a thought process that I'll try to reveal it to you. And as an MBBS final year student, as well as when I'm passing out my neurointervention, starting my neurointervention practice, it is utmost of importance that we were told that we should not do any harm to the patient, and you should have a good clinical judgment before touching upon the patient, which is most relevant than any other procedure in case of stroke thrombectomies. So this problem of this conundrum happens especially for the stroke thrombectomies, as I said. There is mounting evidence in the form of guidelines, RCTs, meta-analysis, and systemic reviews. But in real world practice, we have our own issues of skills and expertise, infrastructures, costs, payment mechanisms, acceptance by the physicians, our own physicians, and the patients. So these are all the issues that we face. So how we reach out to each particular patient, we will come to discuss in the next few slides. So what is large core? Large core in the conventional sense, it is aspects less than 6, whereas in diffusion dawn trials, it is defined as volumes in the form of a 70 ml or 50 ml or so. So as you all know, large core trials have come up, and in which the volumes, most of the trials have taken volumes in the form of aspect scoring. So only one study, probably select 2 studies just taken the volume as a consideration, but most of other studies have taken aspects into consideration. 3 to 5 has been taken as the denominator. In last year trial, they have taken 0 to 5 also. So that is about the definition. Now coming to rational, so this is very insightful article by Dr. Mayank Goel. So why it is important to treat even large cores. So if you have a hyperintensity, which is very large, or if you have a hypodensity, which is very large and CT, so whatever you are seeing on the macroscopic image, there may be a few VOX cells which are kind of having oligomia, not completely decreased perfusion. And if you save them in time, probably they may rejuvenate, and they may help in further functional recovery of the patient. So this is the basic understanding about the large cores. And apart from that, so there is this important article which they quoted, in which a box plot analysis was done between the core volumes and outcomes. They are always not corroborative. Sometimes you have small core volumes and patient will be having a poor functional outcome. And you have a large core volume, but patient will be having good outcome. So these green and red areas can show that. And they defined that after certain core volumes, the treatment effect is nullified after 120 ml, you can say. So that is what the relation between these two. This is my observation that no two aspects are same functionally. Like number was they may be equal. You take the first patient, patient one, the aspects is like you have in the M areas, 3 areas involvement is there, and in the basal ganglia region, you have 4 years involvement is there, and aspects comes around 7, and similar number is there in the second patient, and which is going to do well. So this I see because in the first patient you have the frontal cortex, precentral area is preserved, postcentral area is preserved. Probably that patient will do better for a given if both the patients are having M1 occlusions. The first patient will do better as compared to the second patient for the same aspects. So this is very important to assess for the functional areas which are already kind of yet to be infarcted, but oligemic, and if you try to preserve them by reperfusion, they may do good. So trials and results, as I said, Hermes showed good, the aspects 3 to 5 groups of analysis showed 30% good outcomes. And few studies showed the core volumes, what are the core volume threshold. So they showed that up to 120 ml you can have good outcomes. And beyond 150 ml, the outcomes are very poor. So that's what they showed in the studies. And coming to a few case examples, my own experience, and this is an elderly lady having the aspects, as you can see that almost hemispheric involvement is there on the left side. But she has come in a early window period of 4 hours, and she was already in anticoagulants for heart disease. And so we took the patient for the thrombectomy for the left M1 occlusion. The flare is yet to show the lesion, and we did the thrombectomy. And the POD1 CT, you can see that the final aspects, initially it was around 2 or 3. Now in the POD1, it may not be less than 8 or so. So patient is also doing good. Another case, almost hemispheric, this time basal ganglia is the not involved aspects is 4, and M1 is occluded. Flare is yet to show the lesion. And he's a younger guy, and NHS is lower side. So whenever the patient does good, we try to demarcate the points which were favoring the good outcome probably. So I am showing those cases, and I have few negative cases also that also we'll discuss. And here we try to chase the occlusion. M1 occlusion was there, but some anti-grade flow was there, and that was delayed, and we did thrombectomy. You can see the post thrombectomy POD1 MR. The last image, if you see that the precentral gyrus is still spared among these patchy infarcts. So this is very important. You have to have seeing the functional areas also into consideration, not only just the number of aspects. Whenever you are taking the patient into this particular ruling out the patients of the low aspects. So another case, hemispheric infarct and some patchiness in between, not completely homogeneous. Right ace is occluded and diffusion yet to show. And right ace here, so we chased the thrombus and thrombectomy was done. And you see that the final aspects is not less than 7. So in this case, so a patient did well. So another case, this is an interesting case, young guy, 27 male, he was having a free floating thrombus. And the aspects is, as you can see, diffusion aspects is 2. And the prefrontal cortex, the precentral cortex in the prefrontal area is spared a bit. Rest of all others are infarcted. And there are, on the CT angio image, in third image, you can see that there are some good collateral seen. Although the infarct is a big one, there are some good collateral seen on the CT angio image. So because the patient was young and we explained the patient about everything, including decompression because of the large infarct, and we did thrombectomy for the M1 occlusion, and these are the clots. And we did decompression electively on the day 2, and a little bit of mass effect was progressing. And as expected, some edema was there and decompression was done. And as you can see that the spared the frontal cortex here, probably the reason why the patient did well, he was walking on day 10 after the procedure. So these are the trials. The trials have shown that the outcomes, maximum outcomes, few trials have shown this new terminology, MRS3, which is called as independent ambulation, which is achieved up to 30% of cases. And the stats showed that better outcome in terms of independent ambulation, functional outcome, mortality, the overall neurological improvement. Everything they were favoring the particular the EVT study groups. So, but the mortality is very high that you need to consider it. So patients, it's in the range of 40%. So is there any criteria of selecting those patients? They have taken almost every group of the bad clinical predictors like NHS on the higher side also they have selected in all the 6 studies. Window periods, although they mentioned as 24 hours, but because of probably their logistical mechanisms, it came, actual randomization came at 6 to 8 hours, which is a very important point. So in our case scenarios, it may not be true. So we get most of our cases around 12 hours or 18 hours with large course and all. So we need to consider this point as an important predictor also. And the symptomatic hemorrhages were higher in EVT group, but surprisingly the mortality is on the lower side. So, so based on this, in the recently last month, the SNIs, the Sustainable Interventional Surgery, has given recommendations as of class 1 and level A, saying that you can take infarct course of 70 to 150 ml and aspects between 3 to 5. 3 to 5 they have mentioned for the favoring thrombectomy. And consideration for NHS given between 6 to 30 and the time period is 0 to 24 hours. So, but as I said, the evidence is there on one side, and we have to apply it to our own logistics, our own patient population, clinicians. So what are the issues? Here you see the outcome means you treat 10 patients, out of them, only 3 will get good outcome. And to get one good outcome, you need to treat 5 patients, number not treated. And mortality is around 40%, close to 40%. And most of the RCT showed the randomization happening at 4 to 8 hours as compared to what we see realistically in our own practice. And the most important thing, the standard of post-stroke or post-thrombectomy rehabilitation and care, we don't know how good it is in the Western population as compared to Indian setup. So these are all the limitations we need to consider. And the predictors of outcome, I'll show twin cases for each core volume of my own experience, and we'll try to see what were the negative predictors and positive predictors. It's a case one of a twin case and a young female, known case of Takayasu, and large core infarct, aspects is 4. And there was an IC occlusion, a large class setting at the IC terminus extending into the M1, and flare is there to show the lesions. And the MR angio showed the occlusion on the left side. So we chase the clot on the left, because Takayasu is there. We have the diffuse narrowing of the common carotid artery. So that we, through that narrowed common carotid artery, we try to go, and these are the collaterals not adequate from the posterior circulation. And thrombectomy was done. So these were the perfusion post-thrombectomy, recanalization perfusion. And while coming out, we did some balloon angioplasty, put the patient on anticoagulation as well, because of the floating kind of the inflamed vessel as well as the thrombus, residual thrombus. So this was the follow-up MR on POD1. So you can see that patchiness of the infarct still come to not homogeneous kind of infarct that has evolved. And you can see that the dominant left ICA we have opened up. The right ICA is small, and it is supplying both the A2s. So this probably helped the patient, and this was the CT. And you can see that not much of mass effect, although the initial infarct was very high volume. And this was the patient on follow-up. So she was doing well. Similar, maybe you can say mirror image on the left side again a Takayasu patient, and 26 years of female, and the aspects is probably you can say around 4-ish or 5-ish. And again, IC occlusion, and we took the patient for thrombectomy, and with remote aspiration, the clot came out. And this time again, we did balloon angioplasty, and you can see mass effect developing post-op on day 1 and some hemorrhagic conversion. And you can see that right side is nothing is there, but right ICA probably due to slow flow, it is not seen. Initially, it was seen. We checked with CT angio was showing good flow in all the 4 vessels. So decompression had to be done. You can see new lesions coming up on the right side. But the ICA was patent, MCA was patent, probably she was having some vasculitis kind of active inflammation. She's newly diagnosed Takayasu. and the surgeon was insisting for bilateral decompression. Ultimately, patient couldn't make it. So this is a kind of similar infarct, similar kind of pathology, similar kind of volumes, and similar kind of the vessel occlusions, and we did good reconstruction both the cases, but the outcomes are contrastingly different. The reason is first case, probably two reasons were in favor of again is the second patient. One is that it's an actively inflamed vessels are there, the newly diagnosed trachea, so we put the patient on steroids. The second thing is that triage time, when we did the imaging initially, and by the time patient took the decision, we took the patient onto table. There was a gap of around 6 hours first there. So probably the infarct must have progressed, and whatever the decision we have taken initially may not be corresponding to actual aspects. We took the patient for a thrombectomy. Another case, twin case, right side diffusion aspects may be Kinse 5, right M1 occlusion. Flare is there to show the lesion. We try to chase the lesion. So not much of mass effect, little bit of hemorrhage is there, maybe PH1 type. And but the patient was doing well at the end of 3 months. Another case, this time on the left side, similar ICA got occluded and recanalized. So here the problem was the postoperative BP was, perioperative BP was very high. We couldn't monitor it properly. We couldn't regulate it properly. The patient didn't survive. Massive hemorrhagic transformation happened. One is on the previous patient was on the right side, this is on the left side. So again, right ICA occlusion, one more patient, almost hemispheric infarct is developing there. Very early ADC changes. But the window period is very less, like 3 hours. He is a post-op case of TURP, and we did thrombectomy, and all ADC got reversed, and kind of he got discharged on day 3. If you say this is almost similar case on the left side, huge hemispheric infarct, ICA got occluded, and we try to chase and we try to recanalize. So one thing you can notice is that the ACA distal branches got occluded. Maybe 2 minutes, 2-3 minutes more can I take? So the negative predictor in this case was probably that the ACA is also occluded preoperatively. It is an embolic shower that was going to MC as ACA. So ACA got occluded. The pile collaterals which are supposed to come and support the oligament perimeric tissue, they are already gone. So even if you perfuse, the chance of good outcome will be less. So this is the postoperative CT, and so this was retrospectively, we could make it on TOF images, preoperative TOF images. The left AC is occluded, AC is occluded preoperatively only. So we need to have good collaterals to have a good outcome. So if you are chasing the MCA occlusion, you need to have a good AC. AC is also occluded. That it may not have a very good outcome because of the loss of pile collaterals, which are supplying the penumbral tissue. So predictive outcomes, which is said like younger age, prevalence of collaterals, and the factors negatively favoring are aspects much lesser, aspects 0 to 2, older age group patients, very high core volumes, and delayed triage. Delayed triage is one of the most important predictor. Favoring good outcome are shorter triage and good collaterals from PCR, AC, faster recanalization, lesser number of passes, and post-op BP under control. So this is one study which showed that the more number of passes you do, the outcome is going to be the worst, especially for the large core. So we need to aim for first pass thrombectomy, at the most for first or second pass thrombectomy to get a reasonable good outcome, and try to give GA for a good post-operative BP control. So we have our own experience. So I try to analyze my own cases in which low aspects, most of my cases are 4 to 5 aspects. So in that, the MRS 0 to 3 was seen at the end of 3 months, say in 40 patients, that is close to 47%, not 0 to 2, but I've taken into the independent ambulation as a criteria. So the important predictors for the average aspects is a bit towards the 5-ish side, and number of passes were low, and needle to revascularization time was less in these particular group of good outcomes. So what about futile recanalization? The futile recanalizations are 20% in the conventional course only. So we were not getting acceptance for that 20% only. We are getting recanalizations of 70%, but the clinical outcomes are only like 50% or 40%. So what about large course? The gap is 60%. We are doing a good recanalization of 80-90% of cases, but the good outcome is only 30%. The gap is 60%. So you need to understand the implications of that, the gap of huge gap of this fetal recanalization, because the costs involved, acceptance will be out, clinicians are the colleagues and social burden on the healthcare, all these things to be considered into before case selection. So again, the same question comes, what about the evidence is there on one hand, and you have real world issues are there. So how to select those patients? So first I'll select those patients. I won't choose aspect 0 to 1 or 2. I'll choose 3 to 5 younger patients, probably early window 6 or 8 hours and good collaterals and moderate NHS. And I will communicate. This is very important in our setup because patients are paying from their pockets. And you have to communicate, you have to give a clear understanding that only 3 out of 10 will do good. And if the patient is going on the negative side, he requires decompression, prolonged ICU stay, lot of cost burden will be added to the patient that need the costs as well as the overall social burden, emotional burden, everything you need to give a realistic understanding to the patient attendant. Then if they're okay, if that financially for everything they are okay, then you need to take the patient and pursue for lesser, shorter triage time and good recanalization, first pass effect, and try to do the procedure under GA. So to conclude that the incidence they quoted in the visitor population is 20%. In our population, probably higher side because all the good cores are usually kept for conservative management by the referring physicians in the periphery. Only the large cores we get are, so the large core incidence in our population may be, in my experience, maybe 40 to 50%. And the outcomes are not always correlated with the core volumes. There are certain other things beyond the core volumes per se, like NHS, patient's comorbidities, age of the patient, the functionality of the infarcted tissue. All of them come into picture. And good outcomes are seen around 30%. We need to have our own analysis of our own set of patients to have our own realistic data, and number needed to treat is 5. Thank you.
For lack of time, we'll have the discussions after the second motion. So I invite Dr. Anirudh Kulkarni to speak against large core mechanical thrombectomy.
Okay. Good afternoon, everybody. I think Sir has given an excellent talk about the overview of what to do with large cores, whether it is beneficial or not. I think he has covered most of the topics that I wanted to cover in the first place, but I think I can add a little bit of more insight into what we're dealing with. So one is, what are large core infarcts? As Sir said, the large cores are large volume or low aspects. So as Sir said, low aspects less than 5 are all large cores. There's a lot of trial variability in what they select. Some trials select 0 to 5. Some trials have selected 3 to 5, excluding the very large core infarcts. There's also a debate on the core volume. Some trials have looked at core volume of more than 50, some more than 70. Some have kept it up to 120, and very few trials have looked at anything beyond that. So presentation within 24 hours in most of these cases, because those are the only people which would be considered for endovascular therapy. So what causes a large core infarct? One would be, if the patient is presenting early, it is most likely a lack of collaterals in the patient, which results in a large core of a large part of the tissue being infarcted, causing a large core infarct, or it could be a delay in presentation. So there's one study from Saudi which has looked at how many patients present to the emergency within the window and how many are delayed. What they found is that more than 50% of the stroke. There's one study in Saudi that said around 55% present in a delayed window. And there was one from UK which said close to 60% will present in the delayed window and only about 40% present within the early window. All these delays have also been worsened post the COVID pandemic, where there are a lot of protocol changes have taken place. There are a lot of other things that need to be done once the patient presents. So there is definitely an increase in the delay of strokes presenting to the emergency. So with these large cores, what do we do? There is widespread interest in the options that are available for large core infarct, as they cause multiple issues. One, is medical issue. They have a poor outcome. Mortality is more, morbidity is more. Second, especially when it comes to a country like India, you have one person who is earning the bread for the family and then rest of them are dependent. So then apart from a medical issue for the patient, it also becomes a social issue for the patient because the non-working members who are dependent will have to take care of the person or the sole breadwinner, and it also becomes a financial issue because they don't have access to finances that would sustain all of these long-term care. So this will result in an increase in the disability adjusted life years, which can be devastating, especially for the lower middle class or lower class families that are present in India. So current options are limited to either only conservative management with, secondary prevention and supportive care, or large core thrombectomy, endovascular therapy. So what are the risks and benefits of this? So there are 4 large core thrombectomy trials whose results are actually out in the, or they're published. One is Angel Aspects, Rescue Japan, Select 2, and the Tesla trial. Tesla trial, the preliminary results are out. The complete results have not yet been published. So why I'm putting this here is that there are 2 or 3 things that we need to concentrate on. One is the heterogeneity of the population that has been studied. Except for the Select 2 trial, which was a worldwide trial, rest of them are in geographically limited locations, which have a certain peculiar characteristics of a patient population that usually will not be able to be generalized. In China and Japan, there is a very high incidence of intracranial atherosclerosis that will limit the generalizability of trials results for these population to a general population. The second thing is the inclusion criteria. So in most of these, there is a difference. In one trial, it was in 2 or 3 of the trials, it was only aspects. In one trial or in 2 trials, there were also the core ischemic volume that also was not consistent. So in Select 2, it was 50 ml. In Angel Aspect, it was 70 ml. And then the imaging selection modality. One trial included diffusion, the other trials relied just on non-contrast CT. And also the fact that the number of patients that were included probably was not powered to a high enough degree to actually predict a firm recommendation. So what are the risks that we take when we do endovascular therapy for large cores? One is the risk of hemorrhagic transformation or symptomatic ICH. Second would be reperfusion injuries resulting in worsening neurological outcomes. The third would be risk of hemicraniectomies or decompressive surgeries. And fourth, we are exposing a set of population to a procedure-related complication, which they would not have risk if they were managed with best medical management. So what are the safety outcomes? Since sir has extensively delved into the benefits part of it, I will concentrate mainly on the risks and the safety outcomes. Angel Aspects, the risk of symptomatic intracranial hemorrhage, SICH, which was, I think, defined by SITMOS criteria, that is either a parenchymal hematoma or drop in NIHs of greater than 4 would be considered as significant. So about there was a trend towards a higher symptomatic intracranial hemorrhage in patients who underwent endovascular therapies. The risk of any intracranial hemorrhage occurring within 48 hours was also higher in patients, and this was quite significant, statistically significant increased risk. There was also a risk of, trend towards an increased risk, but not statistically significant cause of deaths. And the risk of decompressive craniectomy was higher in patients who underwent endovascular therapy. Now, if you compare this to rescue limit, the difference is that the risk of decompressive craniectomy was actually less in patients who underwent decompression. Although not statistically significant, the risk of death was also more in patients who were managed medically, not statistically significant. But again, the risk of any intracranial hemorrhage occurring within 48 hours was statistically significantly more in patients who underwent endovascular procedures. So there's one more thing that they looked at, which the other trials did not look at, and that was the risk of cardiovascular morbidity and mortality after endovascular therapy. There was a trend towards a higher cardiovascular morbidity in patients who underwent endovascular procedures, but How significant is that? We do not know. SELECT-2 trial, this was one of the trials which actually reported a less incidence of intracranial hemorrhage after, or symptomatic SIH after endovascular procedures. Now, this could also be, in part attributable to how the reporting for symptomatic intracranial hemorrhage was done. What the other trials we looked at was mainly symptomatic intracranial hemorrhage within 48 hours after onset. But SELECT-2 limited the period of reporting for symptomatic intracranial hemorrhage to 24 hours. So half of the patients probably which developed a later intracranial hemorrhage were not reported. So that probably is the reason, one, why probably the hemorrhagic complications were less in endovascular group in this particular trial. This particular trial also is one trial that reported on the procedural complications that occurred when endovascular procedures were done. So usual procedural complication risks that we explain when we are doing mechanical thrombectomy in normal core thrombectomies is about 5%. 3 to 5% is the accepted risk profile. But in these patients, the risk of procedural complication was close to 18 to 20%. So are we exposing the patient population to a procedure with a higher risk that would not be incurred if it was a normal core thrombectomy? That is one thing. And second thing, in this particular trial, the risk of hemicraniectomy or decompression was not assessed. So if you look at the meta-analysis, so this is probably the one outcome which was the primary outcome in all of the trials, risk of excellent functional outcome at the end. So all of them show a better functional outcome or a trend towards a better functional outcome in most of the trials that were conducted with endovascular therapy. But none of them are statistically significant. If you look at the forest plot, the Z-score is not very great. So the risk of symptomatic intracranial ICH, again, excepting for SELECT-2, because of the aforementioned selection criteria, rest of the trials do show a significant, or not a significant risk, but an increased trend towards intracranial, symptomatic intracranial hemorrhage that happens with endovascular procedures. So risk of any ICH definitely again is higher with the group that underwent endovascular therapies as compared to patients who did not or were medically managed. So what are the limitations of these trials that we have? One is that two of these trials, Angel Aspects and Rescue Limit, were halted early because of efficacy. Now, in trials that are halted early, there is always the risk that there might be an overestimation of the treatment effect because of a smaller sample size that comes into the picture. Second, these trials, some of these trials were limited only to a particular geographic location. So how can they be generalized when the basic patient population may not be the same? The incidence of intracranial atherosclerosis in China and Japan is much, much higher than what it is in India. Even though Indians have a higher risk of intracranial atherosclerosis as compared to the Western population, they're nowhere near as high as those in China. So will they be a factor which will decide the outcome or change the outcome when it comes to Indian population is yet to be seen. The third thing, the choice of tool for assessment of symptomatic intracranial hemorrhage sits most in three of the trials. Only one, I think Angel Aspects was the one that used the Heidelberg criteria. Heidelberg criteria is more recent. It is more inclusive of what can be an asymptomatic intracranial hemorrhage, but sits most basically is just either a parenchymal hematoma or drop in NIHs. It does not, it was quantified or qualified much earlier than most of these endovascular trials that happened, even the earlier ones. So how well equipped is it to capture all the nuances of intracranial hemorrhage is yet to be seen. If there's a hemorrhage, like I think a couple of cases that that Sir showed, the hemorrhage was limited to a particular area. If there is a hemorrhagic complication that is principally affecting an eloquent area, like the speech area, then the drop in NIHs might not be very significant, but then functional outcome will take a strong hit because it involves a very eloquent cortex. So what to expect? There are two questions that we need to answer. One, will endovascular therapy benefit a patient with a large core infarct? Number two, will it cause a significantly increased symptomatic intracranial ICH and therefore may be actually harmful to the patient? So the current RCTs that have come out, they do not show a statistically significant change in either of the above. But there are shifts towards better outcome with increased risk of symptomatic intracranial hemorrhage. The outcomes that have improved are mostly in some of the surrogate markers, like there are two primary outcome being, improvement in excellent functional outcome versus a trend towards a better outcome where they look at MRS between 3 to 5, getting him back from, either death or a completely bedridden state, MRS 5 to an MRF 3 or 4, where there might be supportive ambulation or independent ambulation in MRS 3. So those are the ones that have shown a better outcome. And the third thing, the sample sizes in most of the trials are low. So they do not, form a basis for firm recommendations for these to be done. So the other thing that we should consider especially in our scenario, is the costs. Even though the cost of mechanical thrombectomy, if you look at the Western society, the Indian scenario, the cost is much less when we compare it to the Western society. But the per capita income of the Indian is even more less as compared to the Western society. So even the reduced cost is a significant burden on many of our patients. So most of the RCTs show that the better outcomes are seen in about 20 to 30% of the patients. So if we do the procedure, say in about 10 people, 2 to 3 will show a better outcome. But in a situation like ours, is it actually a wise decision to submit all the 10 patients? So even the rest of the 7 to 8 patients who are probably not going to have a better outcome, are we actually subjecting them to a higher upfront cost of mechanical thrombectomy, thereby even cutting out the money they may have preserved for rehabilitation, nursing care, further institutional care if that is required? So I've seen patients, I've had personal experiences where we go in, we do a mechanical thrombectomy, it's a failure. I mean, either the vessel does not open or it does not open, and then they suddenly say that I don't have money for rehab. I don't have money to buy the medications. So what are we achieving when we do that? Are we actually doing justice to the patient? That is one question. The second thing, are we pushing more patients to full-time nursing care? Like probably there might have been patients who, without endovascular therapy or with medical management, could have improved to a NHS of MRS of say 3, where they achieve at least independent ambulation. And we do the procedure, we cause an SICH, and then they're pushed to an MRS of 4 or 5, where they become dependent with increased costs, increased social burden, all of these things. So are we actually pushing more people to that is another question that needs to be answered. So some of these hopefully can be answered when we do further trials. Some of the additional trial results that are pending actually are the last trial, tension trial, and Tesla. Tesla preliminary results are out, which probably mimic the results seen in SELECT and Angel Aspects. So whether these will conclusively address the debate is yet to be seen. So take home would be current evidence is insufficient to decide either benefit or futility for that matter. There is a trend towards better outcome with a slightly increased risk of symptomatic intracranial hemorrhage. So probably we need to do this on a case-by-case basis. So some patients, if you have a better financial situation, they have people who can take care without jeopardizing their livelihood, probably we can offer, providing that they're willing to take the risk of increased hemorrhage or mortality. Patients who don't have money, we can explain and leave it out. So the other change in approach that probably would help would be approaching this, our primary outcomes, instead of concentrating on a primary outcome of an MRS of 0 to 2, where it's an excellent functional outcome. Maybe probably we should concentrate on achieving an MRS of, or reducing the MRS from 6 or 5 to maybe 3, where the patient at least is functionally independent with independent ambulation. That would probably be a better marker for outcomes of these trials than just concentrating only on excellent functional outcomes. So if there's, thank you.
I invite Dr. Suresh and Dr. Anirudh to take a seat. Both the speakers have given an excellent exposition of the current controversies and the ongoing debate within the clinical society regarding large core mechanical thrombectomy. Of course, on one hand, you have to balance the 20 to 30% chance of a good outcome On the other hand, because most of our patients pay out-of-pocket expenses, you have to think about financial immiserification on the other hand. So you have to, as clinicians, we have to take some sort of informed decision for the patients, because most of the time when they come to the hospital, they are in a panicky state and they rely most or more on what we tell them and how we present it. Especially in the South and in Kerala where I practice, the level of awareness as well as the society is more litigious. So we do offer them thrombectomy irrespective of the large core. However, I now present the topic is now open for further questions. Yeah, if you would like to have a rebuttal or.
Yeah, that was nice. Against large core thrombectomy, Dr. Anvil. So there are two basic questions that we have, doctor has put up. One is the validity or the completeness of the evidence as of now in terms of large core trials. The second question is applicability to our own set of population. So these are the two very valid points. So as I've shown in one of the slides, so the Society of Neurointerventional Surgery, they have come up with the complete review of although two of those trials are only presented in the Stroke Congress or European Stroke Congress. I think 4 have got published. Almost 4 have got published. And the results of the rest of the 2 also was presented in international conferences. One in the IAC, the other one is European Stroke Congress. So generalizability to the rest of the Caucasian population or Asian populations, if we talk about, the latest 4 trials, probably they covered the North Americas, Europe also. And regarding the inference of those trials also, they are favoring the thrombectomy. Although they are almost kind of the percentage of outcomes as well as mortality is almost comparable. And the one important point I want to mention is that this we have observed in our own set of population also. The patients who underwent thrombectomy, especially the aspects 3 or 4-ish population, they may seem like they may be having more edema, more symptomatic hemorrhage. But the overall decompression rate is also a bit lesser. If the recanalization is complete, this is very important. If the recanalization is kind of 2C, and if you're doing it in 1 or 2 passes, the decompression rate as well as the outcomes we have seen are much better than conservative the population. That is number 2 point. Number 3 is a very valid point regarding the applicability to our own set of patients. So there are so we have our own strata of social status in our society. So there are we have the most number of billionaires in India. Like not most of them, the maximum rise of billionaires are high net worth of individuals in India. At the same time, we have patients who can't, whose per capita income is very less. So we are catering to both set of the patients, not a uniform patient population. So when the patient comes to emergency, when we interact with them, so we need to give a realistic understanding of the financial costs as well as the outcomes. There are certain patient populations that probably they may be willing to go for it, and we have to be open for it. And as doctor also already said, I have also experienced the same thing. So if they're ready for decompression only, for all large cores, I made it a point that if they're ready for decompression, not only from point of verbal consent, but financially also, then only we'll go for thrombectomy in large core trials. That I made it a point that all patients going for thrombectomy, they have to be ready for financially also on the immediate day, or probably POD 1 for decompression if required. So if they're ready for that, probably we'll go for it. Otherwise, I'll just go for direct decompression followed by rehab. That's a better option.
Yeah, I agree with sir about whatever he has put forward. Most of the newer trials that have come up, the preliminary results do mirror the findings that are already seen. But as generalizability being the question, I think what we would benefit our doctor population as a whole, and also the patient population, would be we design and do some large core trials of our own. I think sir has a significant data. I think if we can pool the data and actually publish, we can have a pretty good comparative study between what would be generalizable, what aspects would be generalizable, and what would be not. There are also certain other challenges. Even the large cores that present, the later window that the Western world looks at is a completely different scenario from the later window that we look at. We look at, when we say later window, is 12 hours, 18 hours, 24, 48 hours even. For the Western world, I don't think they look at anything more than 10, 12 hours. For them, 16 hours, 18 hours is a very late presentation, and I don't think they're much bothered about that. So that is something that we need to concentrate on. That is the second thing. And third thing, yes, financial issues, as sir rightly said, we need to counsel before we take up that, these are the additional costs that will be involved. If you can't handle it, then better not to risk it, is one approach that would be ideal for our society as of now.
Hello. I would like to stress upon few things. The first, regarding the outcome assessment, we are discussing about stroke with a very large core, isn't it? So in that case, looking for a great functional outcome of like MRS of 0 to 2, as you rightly said in your talk, may not be ideal. I think anything below 5 should be very much acceptable in those patients who are presenting with stroke with a large core. I think that should be the criteria in maybe in the future trials. I think whatever studies we already have, if you look at that carefully, MRS of below 5, it is almost a 50% reduction in the number of patients who are in the MRS of below 5, in those patients who are undergoing this mechanical thrombectomy. I think that is very much significant if you look at that aspect. The another aspect I would like to say, how do we select these patients for mechanical thrombectomy? We know that it has been discussed also that the aspect score and even the core volume, they are not actually exactly correlating with the final outcome. So in that case, I think we would need more robust markers to select patients for mechanical thrombectomy, something like a kind of a tissue window or something, where they would be correlating well with the final outcome. I think those things they need to, like, we need to concentrate on in the future trials. Thank you.
Yeah. Okay. So I think almost I would say both of you have reached the same midpoint. Sort of midpoint of for and against, rather than being for and against. I think both of you have sort of reached a midpoint of where it would be appropriate. So I think we are sort of in a similar kind of point in time where we were at one point of trying to do indiscriminately do thrombectomies for everyone. And then we realized after the 2015 RCTs that there is a certain specific subset where it makes a difference. Again, I think as sir has rightly pointed out in his own case series as well as the RCTs, it's only about 20 to 30% that are there. So I think our next job would be to figure out which are those 20 to 30%. And with regards to that, I think a couple of points in addition that I have. So one is the MRS is too broad a spectrum of neurological deficits to look at. I wonder whether motor recovery is just one thing that we can look at, particularly in the large core thrombectomy trials. How many people reach an M6 or an M4, things like that. The second thing is, I think, a weighted aspect score, something that involves the internal capsule coronary data, motor cortex, rather than just a pure diffusion volume or a pure aspects would be a better option. So I think in order to figure out that this 20 to 30%, we need to change the very metrics by which we are currently selecting patients, as well as what the outcome measures are. So I think these are 2-3 things that we need to completely change the paradigm with which we are doing it. So clearly we are there is a fog of war that is there going on with large thrombectomy. I think these are the things that we need to work on. And another thing is, of course, the right hemisphere is not the same as the left hemisphere. You would have a lower aspects threshold for right hemisphere because you're not expecting language to recover, higher maybe aspects with the left, this one. Again, the left, the speech is a part of the MRS. Again, all these things that need to be fine-tuned in order to figure out what is a large thrombectomy candidate, a large core thrombectomy. Thank you.
Questions from the floor?
Hello, sir. If the patient comes with a stroke with large vessel occlusion, the patient is not affordable for mechanical thrombectomy. Can we thrombolize that patient? The patient is not affordable mechanical thrombectomy, 4-5 lakhs they cannot afford. Can we do thrombolysis for that patient?
Definitely depends on the window period. So there is one trial that has looked at thrombolysis. If it's a large core, one of the contraindications if is more than 1/3 of the hemisphere is involved, that has a higher risk of hemorrhagic transformation. And window period. Many of these large cores that we see, they don't present within the early window anyway. So yes, if it's less than 1/3 of the hemisphere involved, poor aspects also you can thrombolize. I think aspects comes into consideration only when we are doing mechanical thrombectomy. For thrombolysis, you don't have to look at the aspects in the first place. And I think even an MRI actually is not required when you're thrombolizing. Thrombolysis is always a clinical decision. It is not an imaging-based decision.
So in your experience, what is the success rate of thrombolysis in a case of large vessel occlusion? Success rate?
Success rate, what I've seen was with alteplase, not very great earlier. With tenecteplase, definitely more vessels are getting opened. But also we'll have to weigh with some of these other risks. Like the other day, I had a patient, 90-year-old, very early window, large core, looked like we thrombolized, the vessel opened up completely. But then when we went in and did an angio immediately after, we found that all the clots were actually broken and sitting in some of these M3, M4 segments. So that is there, that you will have to weigh against.
Suppose if the thrombolysis fails, how much time you should wait for 1 or 2 hours to, and then go for mechanical thrombectomy?
Current, if you look at the AHS stroke guidelines, waiting after thrombolysis for improvement before considering endovascular therapy is a class 3 harm recommendation. If you actually wait after doing thrombolysis to decide upon thrombectomy, you will harm the patient. That is not recommended. So if the patient is a candidate for both endovascular therapy and IV thrombolysis, you start the lysis and then take him up for thrombectomy. So I can understand your predicament, because in our population, what I have noticed is that when we start IV thrombolysis, say with alteplase, and I tell them, no, I have to go in and do the mechanical thrombectomy, I've had patients come and tell me that, let the injection get over, let us see, let us wait. It comes from the patient, not from the doctor. So it's very difficult for us to convince them. So what we are doing usually is, if we know it's a large vessel occlusion, we use tenecteplase because it's just a bolus. We tell them it is done. We have to see whether it is open or not. So definitely, as medical
session now.
There is definitely no indication for waiting after thrombolysis for considering mechanical thrombectomy.
So you
Thank you.
do,
I think
once
we have
again,
to
we do
close the
CT
session.
angio to look
We have
for
posters, e-posters going on. So I think we'll have to close the session now. Thank you.
Something for
Thank you, sir.
Before we break for lunch, I would like to make some important announcements.
May I request all the chairpersons and faculty to come over stage for a group photo?
The photo session as well. Yes.
Yeah.
Yes. So before we break for lunch, I would like to make some important announcements. Firstly, the participation certificates can be collected from the registration counter, and there is ongoing e-poster competition which is going on. All the e-poster judges are judging the event, requesting the students to be present around at the venue. And at 4 p.m., we shall be having a valedictory ceremony wherein the winners will be announced. I repeat, the participation certificates can be collected from the registration counter. At 4 p.m., we shall be having a valedictory ceremony where the winner shall be announced. We shall now break for lunch. We shall meet another 1 hour for the next session by Dr. Surya Narayan Sharma. We shall start the next event by 1:50 p.m.
Hi.
The chairperson for the session, Dr. Anirudh Kulkarni. Dr. Alpana will be helping with the session too. May I request Dr. Amir Moir to co-chair the session. Thank you. We have a session now by Dr. Surya Narayan Sharma on demonstration of Neurosonology TCD machine technique.
Let chairperson.
Chair the session, we have Dr. Amir Moir with us.
Okay. Okay.
Dr. Suryanara Sharma is known to me from a long time, academically excellent. He is now very much interested in this neurosurgery, which is a emerging modality, especially for stroke-related work, and also in other fields of neurology. Dr. Sharma, kindly start.
Yes. Thank you. Dr. Amir Moin was my senior. I know him for last 22 years, so thank you for your kind words. So without wasting much time, as we are going into the last session of the day, what I'll do is next 15 minutes, I'll just give you a brief introduction about the Neurosonology technique, and then another 15 minutes about the live demonstration. We have a subject here so that you will know, what is the, how to do the test. Subsequently, after that, if someone wants to learn, you can actually learn it after 4 o'clock. So let me start about the transcranial Doppler. Basically, transcranial Doppler is a doctor's stethoscope to the brain. It is actually considered as an extension of the neurological examination. It's more of a physiological imaging. See, the problem with TCD or TCCD is in a transcranial Doppler machine, you will not have a tissue imaging. Unlike many other, scans, you have a tissue imaging. Here, what we have is a real-time blood flow in the intracranial or extracranial vessels, what you are going to look at. So basically, this is called a doctor's stethoscope to the brain. Rune Aslit described in 1982 for the demonstration of flow in the intracerebral arteries. And Mark Moring in 2002 invented the TCD power mode Doppler. I think this is the game changer in the transcranial Doppler technology. First 20 years, it was largely used only for subarachnoid hemorrhage monitoring, but of late now it's an integral part of stroke work in most of the centers. Initially, it was largely described for vasospasm in a subarachnoid hemorrhage. Now, whenever we do any procedure will have its own advantages, its own drawbacks. The major drawback in a transcranial Doppler, what I can say is, number one, the technique. It is operator dependent. It depends on the angle of the probe, how you are holding, and the depth at which you are insonating. These two will decide the outcome. And you need to, undergo training and be little skillful, because you don't have a structural imaging to match. If you have a circle of Willis, sitting right in front of you, then it's quite easy for you to do the, further analysis or discussion. But you are now in front of a patient, you are just imagining his circle of Willis, and you are going to insonate in different angles and different windows. So now I'll skip some of the physics slide for the want of time. What I can say is it's a simple, inexpensive bedside tool, non-ionizing, repeatable, and allows continuous continuous monitoring. In acute stroke patients or in patients who undergo carotid stenting or carotid endarterectomy, we have put it for 40 minutes. We have done the microemboli monitoring in many patients. So it allows a real-time monitoring. And this is a 2 megahertz probe. I'll show you this one. There are three major windows what we look at. The transtemporal window, just in front of the tragus, you can feel the bony defect. So unfortunately, ultrasound waves cannot, traverse the skull bone properly. So you put a ultrasound probe here and send the signals. It has to cross the skull bone twice. It has to go in and it has to come out. So by the time it comes back, the signals are so weak that the spectral waveform won't be formed. So to avoid that, so what is a piezoelectric crystal? Basically, this is the probe what we are going to show. This has a piezoelectric crystal. So it fires for 1% of the time. It fires for 1% and 99% of the time it receives the frequency. Suppose you say 2 megahertz probe, it fires 2 million times per second. In 2 million times per second, it's going to fire only for 1% of that, whatever nanoseconds, and it hears, it gets the inputs from the returning waves, and then it forms a waveform. Then, so based on the frequency shifts, the RBCs keep moving. So basically blood flow is continuous and constant. So anything in red in TCD, the transcranial Doppler, is the waveform which is coming towards the probe. Anything blue is the waveform which is going away from the probe. This is, quite simple and straightforward. So these are all acoustic windows which we use. You can see, you can imagine this is a circle of Willis. You are going to keep the TCD probe here. So the temporal window is just in front of the tragus. The second is the orbital window. Orbital window is just above the eyeball, on the top, just on the eyeball. And the suboccipital window or even foraminal window. So these three things we commonly, use it for our day-to-day clinical work. Temporal and submandibular window, we use it for subarachnoid hemorrhage monitoring. Basically to calculate the Lindegaard's ratio. Lindegaard's ratio is between the MCA, intracranial MCA divided by extracranial. Suppose if that is less than 3, it is normal. 3 to 6 is hyperemic. Above 6 is vasospasm. So that's how we calculate the Lindegaard's ratio based on this transcranial Doppler technique. So based on the spectral pattern in the various arteries, we identify various disease patterns. The common disease pattern what we identify is the intracranial stenosis. If there are, certain cutoffs and values, which suppose if that crosses, we can confidently say that this patient has intracranial stenosis. In some patient, we can even have a intracranial vessel occlusion as well. So basically it is performed with a 2 megahertz probe, and we keep Doppler gate. I'll show, I think all this can be shown when we are doing the procedure. And TCD windows, commonly, this is a normal spectral waveform what we see. So this is the systole, peak systolic velocity, PSV. This is the end diastolic velocity. Basically, it's like a pulse waveform pattern what we see. And the transtemporal insonation, usually whenever you do a insonation, there are three things which you have to keep in mind before identifying a vessel. Number one, which window you are insonating. If it is transtemporal window, you are going to identify MCA, you are going to identify ACA, you are going to identify PCA, and ACOM or PCOM if it is abnormal. And that depends on the direction of the probe. If the probe is directed towards the nasion, then you are either hitting MCA or ACA. Second is the depth at which we are trying to insonate. So this is the arterial segment. I'm just showing this to compare. You can see the circle of Willis, bilateral MCA, right? So here the interpretation of this vessel is you are seeing 40 to 70, 40 millimeter to 70 millimeter. That means you are insonating this 3 centimeter of the vessel, which means this is the, you can roughly say, this is the 3 centimeter of the middle cerebral artery, which you are going to insonate. Suppose if there is a stenosis, they will show some specific wave patterns. So the transtemporal, I think all this I'll skip for the want of time. I want to spend some time on insonation. Suboccipital usually for vertebral, basilar. In vertebral, you can also see the pica, posterior inferior cerebellar artery, ICA, superior cerebellar artery, and also the basilar artery. Vertebral and basilar system can be insonated in a matter of, I can say, few seconds. So it's very useful for a stroke work. You are all stroke neurologists. You have a stroke. In fact, in emergency department, whenever we get a stroke patient, after MRI is done or even before, if patient is about to shift it for MRI, sometimes we do. In fact, time we had one patient who came in window period. He was waiting in the, waiting for the MRI for 5 minutes. So we did it. Actually, we identified there is a right PCA occlusion. In fact, he had a right suboccipital infarct and there was a right PCA occlusion. So it needs some skill and training, but definitely it's rewarding for you because if you are doing a stroke prevention clinic, you can definitely do this in a span of few minutes and you can give your inference to the patient. So these are all the various depths. As I said, this is important. This is the window in which you are identifying MCA, ACA, ICA, PCA. Suboccipital window, you see basilar, vertebral, and transorbital window for ophthalmic artery. Usually we don't do on a screening TCD, we don't do transorbital because it may be a little uncomfortable for the patient. But suppose in a patient is too sick, patient is in ICU, you can actually do this procedure. Another important thing I would like to highlight. See, you have a patient who had a septic encephalopathy or a hypoxic brain injury. He had a cardiac arrest. Your cardiologist calls you for an opinion. He is on 4 inotropes. He is not, he is not even be in a position to shift for a CT scan. So what are you going to do as a neurologist? Number one, you can do a EEG for a physiological, functional assessment, and you can do a TCD and you can confidently say how is the blood flow pattern in the brain. So these are all the advantages what one can have with a TCD machine. Can I have the volunteers to, Dr. Alpana is my neurointensivist. She's going to demonstrate some of the techniques when I'm giving the lecture. So this is a normal TCD waveform spectrum what you can see. So it shows, that means from 45 to 95 means this is a 6 centimeter gate. 6 centimeter gate means what? This window is going to identify the blood flow pattern in a 6 centimeter length of the blood vessel. So that's how you are going to interpret a patient with, whenever you are going to do a transcranial Doppler. The vessels, we will come to the individual vessels based on the, flow towards, away, and the angle in which we are keeping the probe and all that. So this is the vessel identification criteria. But the most important is the lower one. As you can see, MCA flow velocities is the maximum. Suppose the rule of thumb is, if you identify any other vessel which is more than MCA, then probably you are dealing with a intracranial stenosis. That is the usual rule of thumb. And second rule of thumb, whenever you are comparing from right to left, you need to identify right to left whenever you are comparing right to left. Suppose if right is abnormal, always compare with the normal end. And in case of doubt, always match with the structural imaging. You would have done structural imaging in most of your patients. It shows. So you can always correlate whenever you are as a beginner, you can correlate. Now I will show some of the, you can change the screen to the real time. So basically this is a transcranial Doppler machine. So it is a 2 megahertz probe machine. So there is no tissue imaging available. It is not, you can't do, it is not a TCCD. TCCD means there is a duplay available. So here there is no duplay available. So what we are going to do is, this is a 2 megahertz probe. You stand in the, behind the patient. You are imagining the circle of Willis, basically. And you are going to insonate. Always, hold it like a pencil. Keep, take the support of the patient's cheek or patient's forehead or temple. Just try to gently identify the vessel. Now, as she is doing, probably, as I was talking, you would have heard the sounds. Within 30 seconds, you are able to identify. Can you freeze it? Can you freeze? Yeah, 1 minute. So here, what does it look? So here we are doing a transtemporal TCD insonation. Number 1. Number 2, the angulation is always from towards the nasion, that is anteriorly angulated. So the only 2 vessels which can come here are, one is a middle cerebral artery, second is an anterior cerebral artery. Okay. So middle cerebral artery, it starts from actually 40. You're seeing some waves here, but it starts from 40, distal one, till almost 75. It's almost a 3.5 to 4 centimeter long vessel, which we are going to insonate. Here, can you see the power mode spectrum? What it is showing? It is showing a uniform red in color. Uniform red in color is very clear. It is almost like the vessel is totally open. You totally open the vessel before giving any interpretation about the TCD. So the vessel is completely open. We are almost insonating 1.5 centimeters of the vessel. And you go back to the waveform. What you can see there, number 1, it's a sharp upstroke. Sharp upstroke is the peak systolic velocity. Then it is dying down. There is a diacrotic notch. Then there is systolic velocity. And then it is taking up again with the next cycle. So one complete cycle you can see. And there are 2-3 interpretations what you can make out in this TCD machine. Number 1, the heart rate is normal. There is no sinus tachycardia. There is no sinus bradycardia. There is no arrhythmia. Atrial fibrillation, very easy to identify. The moment you put the probe, you see variation in the variation in the rate, variation in the rhythm, and the velocity, the peak systolic velocity also drops as the blood flow changes. So what we can say is, number 1, and he is most likely to be a normotensive guy. If there is a systolic decapitation, what you see in the pulse waveform, there is a delayed acceleration of the peak systolic velocity. It will be rounded. It will not be a sharp velocity. It will be a rounded velocity. So in this, at least we can say that it's a normal. And what is the peak systolic velocity? It is 73. What is the mean? 42. What is the diastolic velocity? 28. So middle cerebral artery, 72 is the PSV, and it is less than 50%. Diastole is less than 50%. So this shows that we are dealing with a normal MCA spectral waveform. This is how we are going to interpret. Now, you are seeing a blue vessel here. This is a blue vessel. What is this? This is anterior cerebral artery. Up to 75, you see ACA, MCA bifurcation happens somewhere between 70 and 75. You can continue. So 70 and 75 ACA bifurcation happens. So you are seeing a anterior cerebral artery, and which I am going to show, in real time, and I am going to explain to you. Whenever you are doing a procedure, always remember, as a beginner, whenever you are doing, you will get the waveform. If the window is good, you will get the waveform hardly in 1 or 2 minutes. The problem is in with elderly women and in Asians. And Asians mean not us, the Chinese population. When I did my fellowship in Singapore, every alternative patient, we never used to get the vessel. This is PC. Can you put it more anteriorly? Yeah. Yeah, hold it here. Yeah, it is coming. Just, yeah. Can you see that? So this is now you can see almost 2.5 centimeters of vessel is open. You are seeing both ACA and MCA spectrum together. If you are lucky, actually, you are seeing some waveforms on the opposite side also. So I don't think there is any other investigation which does a non-invasive measurement of the intracranial vessels and gives you results in hardly few minutes time, real time. This can be done in emergency, this can be done in ICU, this can be done in OPD, or if you are running a camp somewhere in your tertiary center or a tier 3 center, you take the vessel, because it's a very good tool to say that the stroke prevention clinic, whenever you are running, definitely you can make out better. Hold, freeze it. So as you can see here, this is ipsilateral MCA, this is ipsilateral ACA. The red one, what you are seeing is a contralateral ACA, because contralateral ACA is coming towards you. It's like a mirror. Once you cross 80, the switch will, it will reverse. Basically, the skull diameter, the temporal interskull diameter is 16 centimeter. That is 160 millimeters. You split it to half, it is 80, adult skull. So anything you are insonating in temporal window more than 80 is probably you are insonating the opposite side vessel. So if you apply the same rule, I can say this is ipsilateral MCA, ipsilateral ACA. The red signal what you are getting is a contralateral ACA, and the blue one, which is in the topmost, it is like almost 100. This is a contralateral MCA. So in one window, I am showing you the 85% of intracranial circulation, and I can say that this is normal. So this is the advantage of learning the transcranial Doppler technique. In fact, many people, I am the secretary of Society of Neurosonology India, which actually works on spreading awareness and knowledge of transcranial Doppler technology in South Asia. So whenever a neurologist asks me why this technique is needed, I say, one, yes, it's a mistake that it is not in your DTM curriculum. Otherwise, you would have learned it. It is much easier than EEG, let me tell you. You learn it in 2 weeks. You are going to, in fact, in my lab, my technician does it. It's as simple as that. It's only you have to spend few weeks with the expert, and you can read on the content. We have brought out a book on the Neurosonology techniques. Dr. Vijay Sharma, my mentor in Singapore, National University Hospital, Singapore, under his editorship, we have done a guide on manual of Neurosonology. So I think another 5 minutes I have, I'll close. So here you are seeing a real time. This is a normal patient. So you don't have to worry much about a finding here. But I'll show you some of the videos on how the abnormality is. Can you do the vertebral artery? So posterior circulation is very important because MCA sometimes, especially when patient is unconscious,
patient is admitted for a non-neurological indication, many times if you establish, suppose you do a basilar artery stenting or you do a mechanical thrombectomy of basilar artery. Now, how to say that this patient basilar artery is patent? He is still unconscious. Just because you do a mechanical thrombectomy doesn't mean that he may be up and awake in next few hours. But again, you will also have a dilemma, whether it's open or is there a vessel thrombosed. But in that situation, you can just put the TCD, this one probe there, and you can say for sure that there is a good flow in the basilar artery. It is patent, it is functional. You don't have to do anything. That will give you that much confidence. In fact, in my hospital, when Savit does a procedure, he will only take the machine and we will do the procedure. Can you freeze it? Yeah. Now, this is the basilar artery waveform. In the posterior window, what Dr. Alpana did, suboccipital window, we are doing the basilar artery. Up to 70, what we are seeing, 40 to 70 is the vertebral artery. So vertebral artery comes from both sides, it merges and it forms a basilar artery, right? Anatomy is clear. So from 75 onwards, you are insonating the basilar artery. Okay. So this is the basilar artery, what you are seeing. You are seeing good 3 centimeter of basilar artery in this subject. 80 to 90 is a proximal basilar, 90 to 100 is mid basilar, above 100 is distal basilar, and after that it bifurcates. So in how much time we took? 45 seconds, right? In 45 seconds, you are going to identify the basilar artery and you are going to say that it is a normal basilar flow. That is the beauty of a transcranial Doppler technology, what we are going to do. In fact, at least I'm happy now. Last 4 or 5 years, lot of neurologists who have passed out recently, they have taken up this branch, and definitely there are more than 130 neurologists who have their own TCD machines across India. I think if someone wants to learn, you can upgrade yourself, you can contact one of us and you can do it. I'll show some of the abnormal patterns. Probably you can connect it to the second video, because whatever I have shown is normal. So now probably I will show you 1 or 2, findings so that you will know the importance, like applied aspects. The machine will be outside in that area. So probably if someone wants to experience or have a feel of it, definitely they can, one more video. Adu. One video was there, no? 28 MB. Day 2. Day 2. Any doubts anyone has as of now? So another 2-3 minutes are left. So any doubts or any clarifications on the technology? I'll show 1 or 2 videos so that at least you will get a real-time information. Yeah. Which one? PI? Yeah, usually by the time PI crosses 2, the patient is having features of raised ICP. So by the time it crosses 3, it's almost incompatible to the life. Suppose if you are getting PI of 3, it is technically wrong actually. That means either your technique is inappropriate or the spectral waveforms are not formed yet. Whenever you are interpreting pulsatility index or any other indices, the biggest thing you need, the most important thing what you need to know is your spectral waveform should be correct. Now everything, this is artificial intelligence based software. In fact, when we started learning this in 2015, we used to do it manually. One TCD technique used to take, I can say, 40 minutes. Because everything, even PSV, EDV, everything we need to monitor, you need to do it step by step. But now it is saving a lot of time. That's why a lot of neurologists have shown interest and using, because it's a very handheld tool. You have a OPD in your cabin, you can keep it in your cabin actually. If you have a patient in the same, you don't need any other infrastructure. You can just, play it in your room, and within few minutes, you are confident about your patient. Okay. So I will just show you some of the, one or two videos. I'm sorry for wasting
Just
your
one
time.
more question. Do you use PIs to serially monitor rising ICP? Because there's a rough equation.
Which one?
With the serial increase in PI,
Uh-huh.
you can monitor the rising ICP.
Yeah, that's the point in patients when we do a subarachnoid hemorrhage monitoring. Suppose you have your neurosurgeon who has clipped aneurysm. Your interventionist has coiled aneurysm. The vasospasm happens maximum from 3 to 5 days, and it may last for 7 days. Every day you cannot you cannot shift the patient to a cath lab or a CT angio to do this. Every day, in fact, there are softwares. For the want of time, I am missing all that. There are softwares wherein it will show a trend. You do TCD every day for the same patient using that study. It will give you a graph on how the monitoring is. Suppose if it is increasing, I say Lindegaard's ratio. Day 1 procedure done, Lindegaard's ratio is 2.4. Day 2, it remains the same. Day 3, it goes up 3.2. Then you can ask your colleague. You have to either give intraarterial nimodipine, or you have to do a check angio. And if it goes more than 6, probably you know what to do. So it will give a real bedside assessment. Whenever you are doing rounds for the patient, you can actually do. If you think you are wasting your precious time, you can actually take this machine. You can ask your assistant to keep the machine when you are doing rounds. You can just do one few minutes extra investigation and you are confident. As I said, any mechanical thrombectomy we do in our hospital, we do every day TCD, just to make sure that we are not getting any surprises after 3 days. Okay, so this is a MCA stenosis. Sound is there? Sound? Yeah. Will sound ilvaida. This is a patient. Yeah, can you play that? Yeah. This is a patient with brain death. Somebody asked me, this is a 5 years back video. My ICU team asked me to declare brain death for this patient. Okay. So what you are seeing, this is a basilar artery waveform. You saw the normal basilar artery in the previous patient. So now there is no blood flow to the brain in diastole. It is 0. There is a sharp systole, which shows that it is going and hitting, and it cannot enter the intracranial circulation for whatever reason, and it is coming back. So this is almost sine qua non of brain death. So in few minutes, this is actually, as of now, it's an ancillary test for diagnosing brain death. It is not standardized, but definitely if you are doing TCD in your center, you can. Yeah, I think I'll stop here because we are getting late for next session. Any question, I'll be happy to take in the end. So thank you very much.
We'd like to thank Dr. Sharma for the wonderful talk, very informative. And I think it's a great tool for us nowadays because we were completely unaware that TCD can have so many utilities in our clinical practice every day, especially for the intervention guys or monitoring of subarachnoid hemorrhage and post thrombectomy. I think it can have a lot of utility. Thank you, sir.
Should we join to the photo section? We'll go ahead with the next session, the Neuro Intervention Symposium. May I call upon stage the chairpersons, Dr. Yatesh Govindaya and Dr. Suresh Girgani. The first talk is by Dr. Sharad Kumar on updates in spontaneous SIH.
So we are starting this session like, Sharath, all of you know, I don't need to introduce much about himself, after his training from NIMANS, he went around and talking about his work on interventional neuroradiology. Thing is, he is one of the early movers who got hold of the subject as well as skills. I think it's over to Sharath, please.
Thank you, sir. Good afternoon, everyone. Welcome to postprandial session. So I will not take much time. This is a very important topic. Thanks to the organizers for giving me this topic. This is an overview and update because this topic itself, there is a lot of information to share, which may take more than 1 hour if I keep on talking. So I'll try to keep it as short as possible. And as we all know, this CSF hydrodynamic disorders is a new emerging entity. It's a group of disease which we are learning every day, and especially spontaneous intracranial hypotension. It is an important differential in new daily orthostatic headaches, an underdiagnosed cause of chronic neurodisability. And this is very important. Even when diagnosed, investigations are suboptimal, leading to a reduced chance of curative treatment. This we often see in our day-to-day practice. If you see the incidence, this incidence is not less than aneurysm incidence. The only thing about we see only the tip of the iceberg because most of the diagnoses are missed. If you see these statistics, according to the literature, it affects 5 per 100,000 population per annum, with the females affecting twice more common than the males. If you take a population of the Bangalore city itself, every year we have to treat at least 650 to 700 cases, but hardly we are seeing 5 to 10 cases, even with the trained eyes. So that means we are missing a lot of diseases. So to continue the facts about the SIH, the understanding is still in evolution. Leak is spinal, but the manifestations are in the brain. This is a unique entity. And the term spontaneous spinal CSF leak is a preferred term over the spontaneous intracranial hypotension because most of these patients, if you do a LP, you may not get a hypotension as in so many cases, especially those long-standing chronic neglected cases. And always ask the history of remote lumbar puncture or the lumbar drains or the epidurals or the previous cranectomies as well, because this may give us a clue like what we are dealing with. So never ignore this history. And always, when we are, this is a request to most of the people who does LP regularly, always try to avoid these cutting needles like Winkes needles. Instead of that, try to use the pencil tip point or a tapered type of needle like a Whitaker or a Geltai Max needle, which is less traumatic to the dura. And there are a lot of publications on this needle, what type of needle we should use to prevent PDPH, that is post-dural puncture headache. And this has the awareness about this is increasing. As I told you, SIH is a very elusive disease. Orthostatic headache is one of the most common symptoms. 80 to 85% of the patients to begin with, we should always ask, how was your headache to begin with? Later on, because these are characteristic orthostatic headache, the postural headache may be lost. In some patients, if you ask, go and dig the history further, they may say, I will be better in the first half of the day, but during the second half of the day, if I feel like sleeping, I should lie down to get this headache relieved. This is typical history which is given in a slow leakers. And in 5% of the patients, there will be a paradoxical headache as well, especially the chronic cases. They say, I feel better when I stand up or I sit up rather than orthostatic. This may be completely misleading. Most common symptom apart from orthostatic headache is nape of the neck pain, multiple cranial nerve palsy, muffled hearing, and long-standing cases, especially they present with brain sagging dementia, mimicking a frontotemporal dementia, Parkinson's disease. So many patients come to us after complications, having CVT, chronic bilateral subdural hematomas, patients coning, going for coma, lethargy. So variable manifestation, and one of the manifestation commonly we miss is ALS-like symptoms because of the chronic leaks, which I will be showing you. There is a classification that we can identify and label them what type of leak it is. It is one of the commonly used type of classification, type 1, type 2, type 3, and type 4. And type 1 is the most common type, which especially in our part of the world, elsewhere as well, accounts for 45% of the cases. This is due to a dural tear. These type of leaks are very high volume leaks. In these cases, generally the tear is found either anteriorly, that is ventral, sometimes in the dorsolateral aspect. And invariably, these cases have spinal epidural collection all around the dura. That's why they are known as SLEC positive. SLEC stands for spinal longitudinal extradural collection. Type 2 is due to a ruptured meningeal diverticulum. Around 15 to 20% of the cases are due to that. Even in these cases, if they are proximal, you may get SLEC positive. Sometimes distal nerve root rupture can cause paraspinal collection as well. The type 3, the newly diagnosed entity, the first time that it was described in 2014 by Dr. Shevanik, who is known as the father of spinal CSF leak, is a neurosurgeon. And this is known as CSF venous fistula. This accounts for up to 25% of the cases. The incidence is keep on increasing because of newer modalities which are used to diagnose such entity. When we can't diagnose where is the exact site of leak, we just dump under type 4. And this is known as SLEC positive and SLEC negative. So if you see a axial section and the sagittal heavily titulated images, preferably 3D sequence, if you do, you can see a CSF collection all around the dura. This is the dural tube, black line inside that the spinal cord. You can see that collection. These are typical SLEC positive cases. And the other one, you can see hardly any dural displacement. There's no fluid collection along the dura. Dura is attached to the bone all around. So you don't see dural displacement and collection. These are SLEC negative cases. Invariably, these will be CSF venous fistulas. And these are probably type 1 or type 2 leaks. So this is a typical depictive picture. You can see the dural rent due to a discogenic spur. The fluid is extravasating out CSF and collecting all around the dural tube, especially anteriorly. And the ruptured nerve root diverticula causing a SLEC positive or a far lateral giving a paraspinal collection. And CSF venous fistula, a unique entity. Nobody knows what is the exact cause of this. This exactly happens in the neural phenomena. There will be a small meningeal diverticular like outpoaching. From there, the vein comes out, which may drain anteriorly going into the azygos or hemiazygos, or may drain centrally into the basivertebral veins. So this is known as CSF venous fistula. So how do we remember the imaging findings? If you know the Monro-Kelly hypothesis, it will be easy to you to remember the imaging signs. But remember that up to 20% of the MRIs may be completely negative with a classical image, clinical picture of SIH. So you should never dismiss a patient because of negative MRIs. So the typical MRI finding stands for SEEPS, is for subdural collection. These are all compensatory mechanism for the last CSF. Enhancement of the pachymeninges, thickening and enhancement, engorgement of the venous system, one of the earliest finding and one of the sensitive marker in the early stages. Pituitary hyperemia because of hypophyseal veins getting congested and pituitary becoming bulky. Sagging of the brain, which takes some time, but eventually it appears with superficial cirrhosis in long-standing cases. But you remember that all these imaging findings do not present simultaneously. They take some time and it evolve over a period of weeks. The initial imaging finding may be collapsed perioptic CSF sheath, distension of the veins, because these are the more compliant structures. So that's why they distend and try to compensate. You will see the prominent veins, especially the transverse sinus, rather than typical triangular appearance, they appear rounded in the mid-sagittal plane. And pachymeningeal thickening and enhancement, subdural collection. Then finally, over a period of 3 to 4 weeks, you will start seeing the sagging of the brain as well. Whether we can quantify them? Yes, we can quantify them. And the popular scoring system is known as Bern score because it was described in Bern, also known as SIH score. And there are two criteria, major and minor. Major criteria, 2 points are allotted, and for minor 1 point, its total score is 9. So we have to add the summation of these points and give the final score. So pachymeningeal enhancement, engorgement of the venous system, and effacement of the suprasellar system. So these are the very sensitive markers. They have been given 2 points, and minor criteria like subdural collection, effacement of the perioptic CSF prepontine cistern, and mammapontine distance reduction is given 1 point each. And we have to summarize them and add them and give the final score. What is the significance of this scoring system? This is known as probability score, because if the score is high, then the probability of detecting the exact site of CSF leak in a CT myelogram is very high. So if the score is very low, the probability of picking up the exact site of CSF leak is low, very, very low. So when the score is more than 5, we try to push the patient for CT myelogram, dedicated CT myelogram, rather than having a low score system. When we call it as low score when the points are 2 or less, intermediate score when it is 3 to 4, and when it is 5 or more, we label them as a high burn score, and they should have a appropriate protocol of imaging. Always insist on a standard reporting format. You should have this format in all the radiology when you are suspecting intracranial hypertension or any headache format, because the picking up of these subtle imaging findings will be very high, less false negative and no false positive if you follow this. And this is a well-published article. You can have this normal format and always see that you should not miss any of these subtle things, especially effacement of the basal systems, especially suprasellar systems, prepontine and mammapontine distances. And most often, as we see, these cases often get missed and they present very late. Then there are certain imaging markers for chronic SIH, neglected cases, such as superficial siderosis, especially they are seen typically in the superior cerebellar surface. Because of this dural rent, the chronic micro bleeds which keep on happening during a reparative process at the level of rent, they keep on bleeding, microhemorrhages, and they get deposited in the posterior fossa. We never get this deposition in the superior supratentorial compartment. We often see in the superior cerebellar area. Layered cake skull, a chronic long-standing cases, we get one more layer of skull, calvarial, smooth calvarial thickening inside the inner table known as layered cake skull. Then this collection, which are in the epidural space, they become like a rounded margins, like a pseudomeningocele sealed off. And this is one of the marker of chronic cases. And bibrachial amyotrophy, because of this sealed off collection, and they keep on dynamic compression on the anterospinal artery, cause changes in the anter-horn cells resulting in bibrachial amyotrophy, treatable cause. So when you see these things, the importance of clinical significance is that your simple blood patch may not cure them. You have to go aggressively and you have to treat them with a surgical approach, because they are long-standing and the recurrence rate is very high with your conservative or a simple blood patch. This is a layer cake skull, typical appearance. There are the few pictures of bibrachial amyotrophy. And what is the imaging pathway? When you suspect a case in your day clinic, how should these patients be evaluated? You should always ask these patients to have a complete study that is with the contrast brain MRI, and always do a whole spine screening in this, because the leak is in the spine. You cannot miss that. We have to classify them as SLEC positive and SLEC negative. Accordingly, the protocol of evaluation starts. So always do whole spine 3D sequences, especially T2-weighted sagittal, which we can recon in any plane and then evaluate them in the workstation. Then if the patient has SLEC positive, this patient will directly go to the ultra-fast dynamic CT myelogram. This is a special type of CT myelogram, not your conventional myelogram. That means when we are giving a dye, we are acquiring the images simultaneously, because these are the fast leakers. In a conventional myelogram, what we do is we, outside the CT gantry, we give a dye, do a lumbar puncture, give a dye, and then shift the patient into the gantry. By the time the contrast would have come out of the rent, and we don't know from where it has come out. So not to miss the exact site of rent, we have to do a study when patient is getting injected by the dye. Simultaneously, we have to acquire the CT scan to and fro. And when there is a SLEC negative case, we always do a decubitus lateral digital subtraction myelogram. Nowadays, decubitus CT myelogram is becoming very, very popular. And there are certain complications which we should remember when they present late. They may be having, due to the sagging and kinking of the cortical veins, they may have present with CVT, long-standing frontotemporal dementia like picture brain sagging dementia. Pituitary apoplexy is also described because of congested hypophyseal veins, Pott syndrome, and superficial siderosis. This is a chart which one should take a printout and keep it in the reporting room or a working format, where how do we approach? If the imaging is showing a signs of SIH, and if it is SLEC positive, then you should do ultra-fast dynamic CT myelogram, localize the leak, site of leak, give epidural patch simultaneously. If imaging is completely negative, you don't know what is going on, but if patient has clinically SIH, please go for 2-level blind epidural blood patch. Never dismiss this patient saying that you don't have anything. You see very, very commonly, we see good clinical improvement in these patients, and never dismiss because they are imaging negative. And when there is no SLEC in the imaging, then the patient undergoes either digital subtraction in a lateral decubitus or a CT myelogram in a lateral decubitus, then see whether it is a leaking cyst or a venous fistula, then treat them accordingly. Generally, for a localized ventral type 1 leak, we give a targeted epidural blood patch. Sometimes we give glue, or mostly epidural patch, or combination of both. In a leaking cyst, we can CT-guided fibrin glue patch can be given, or surgically they can be clipped or ligated. Similarly, CVF, we have a lot of interesting treatment modalities available. I will show in the next case. This is a case example, 45-year-old lady. I will take for 5 minutes, we'll finish it. 45-year-old lady with a postural headache past 3 weeks. You can see that subdural collection, collapsed perioptic CSF sheath, rounding of the venous sinuses, venous congestion is there, some hemorrhage is also seen. All the measurements are done, and the burn score is 9 out of 9. So, and the imaging of the spine was done, SLEC positive. So the patient underwent a prone decubitus, prone ultrafast CT myelogram. You can see this positioning is very, very important. The contrast is being injected while the patient is being acquired, the imaging is acquired. And we do 3 to 4 runs to and fro from the cervical area to sacrum. And we could find a discogenic spur there, which was causing the leak. And this, you can see that transdural osteophyte, which is going into the dura and almost touching the card. And this was the site of the leak. And once the site of the leak was found, we never send this patient back to the ward. We treat them on table simultaneously. You can change this table as well. It's a customization of the table by Dr. Andrew Kellen in US. We can, because the positioning sometimes it becomes very challenging. If you customize such table mounted to the CT, we can remove that and mount whenever you want. The procedure will be very easy and very simple. And when you do CT myelograms or a DSM, sometimes physiologically there will be extravasation in the C1, C2 level. So we should never consider this as a site of leak, never treat them. This is called as false localizing sign. So once we have treated the patients, you can see a follow-up MRI always do at 1 month. You get that perioptic CSF sheath is come back, venous congestion has gone down, pituitary has come back to the normal size. This is a follow-up. And this is how the CSF venous fistula looks, paraspinal vein sign, hyperdense paraspinal vein sign. And you can see that vein draining into basivertebral area, giving hyperdense vein sign. When they are doing a lateral decubitus, we encourage the patient to have a restrictive breathing. Chances of picking up is very high. Give a 1 cc syringe, remove the plunger, and ask the patient to breathe through that syringe. It increases the conspicuity of picking up the lesions very easily. This is a digital subtraction myelogram, 2-day procedure. Once on the first day on the right side, second day on the left side. Under GA, because we have to give apnea for 60 to 80 seconds. And maximum upper limit for intrathecal contrast is 11 ml. That's why we have to split them into 2 different days. Under GA, there's a cumbersome, but it's the investigation of JOIS for detecting CSF venous fistula. This is how the picture you get. If there is any CSF venous fistula, you see a pouch and a runoff of the vein there, and then you have to trace it. And then we have a different treatment modality for them. This is the type 1 leak. Generally, we give epidural blood patch, ruptured diverticular percutaneous CT-guided glue injection or a surgical procedure. And for venous fistula, either foraminal vein, onyx embolization, liquid embolic angioid embolization, or a surgical repair or a ligation is the treatment of choice. This is, you can see, we are doing under the CT guidance epidural puncture. Once we reach the epidural space, lack of resistance, inject the air, confirm you are in the epidural space, inject the blood targeted, and give them absolute bed rest for 24 hours, and then discharge the patient. So one of the cases of a recurrence, we are injecting glue as well. And these are the different imaging intervention modalities. So to conclude, SIH is a CSF hydrodynamic disorder which is often underdiagnosed. Having right imaging protocol, including MRI and dynamic CT myelogram and structured reporting protocol is a key to diagnose initially. If we miss, everything will be missed. As a radiologist, we are the first to suggest, localize, and possess a skill to treat the same. And having a multi-specialty CSF clinic in every hospital is a key. We can help so many patients, not only in diagnosis and localize, also in the treatment. Surgical help, And a good neurology colleague is must for to have a multidisciplinary approach. Otherwise, we cannot treat all these patients. All failed cases keep on coming back without surgical help. We will never be helping them. So it's a high time to start a CSF clinic in every hospital because we can treat many more patients like this. Thank you so much.
Thank you, Sharath. We'll take the question at the end. Savit, please. So I'll introduce Dr. Savit. Savit is a neurointerventional radiologist, passed out from Chitra, and for the last 6 years is working at Banerghatta Road. Yes, Savit. He also runs daily, like, in one sprint, he runs for 10 kilometers. So that's his hobby. Apart from available for all the neurologists and neurosurgeons 24/7. Yes, Savit.
Good afternoon, all. I thank the organizing committee for giving me this opportunity. So I'll be speaking on dural arteriovenous fistula. These dural arteriovenous fistula are very important to know because the clinical presentation can mimic any of the spinal neurological condition. And your routine treatment for any demyelination or a transverse myelitis does not work here because it causes significant worsening and worsening of the symptoms in these patients. So these are the ones which needs to be picked before you do your regular workup or treatment for any of your transverse myelitis like presentation in a clinical setting. So I'll cover my topic under the following headings. So spinal vascular malformation, like dural arteriovenous fistula, are very rare. Not treated leads to considerable morbidity and progressive spinal cord symptoms. So clinical presentation overlaps with most of the other neurological conditions which involves the spine. So this finding is usually picked up by the neuroradiologist or radiologist if the clinician is not thinking of it during his clinical assessment. So selective spinal DSA is one which is very important for making a diagnosis and planning the treatment. And endovascular treatment always is the treatment of option. So to understand the vascular malformation, the knowledge of anatomy is very important. The spinal arteries, you have two longitudinal anastomotic system, which is formed by an anterior spinal artery and posterior spinal artery, which are reinforced by multiple segmental arteries. So these segmental arteries give the radiculomedullary branches, and which are present at the cervical level, thoracic level, and the sacral level. So each of these longitudinal spinal arteries gives off three branches, gives off a segmental branch, which gives off three branches. That is your lateral branch, which forms the intercostal or a lumbar branch, the middle one, which forms the muscular or cutaneous one, and the spinal, the one which is more important for us, which enters the spinal canal. Now, once it enters the spinal canal, it again supplies the anterior aspect of it supplies the vertebral body and the dura. So the dural branches, which are also called as the radicular arteries, gives away branches which supplies the cord. So the arteries or branches which supply the cord are called as the radiculomedullary branches. Now these radiculomedullary branches can reinforce the anterior spinal artery, which is called as the anterior radiculomedullary branch, or the posterior spinal artery, which forms the posterior radiculomedullary branch. And there's a similar system of drainage in the venous system. Now this is an angiogram showing the segmental artery. So this forms your lateral branch, which continues as your intercostal or lumbar branch. So this forms your middle branch, which supplies the skin and the muscles on the posterior paraspinal region. And here, is your spinal, and this spinal branch gives off your radiculomedullary branch. This is an anterior radiculomedullary branch, which we can identify by this hairpin-like configuration. Now, if you have a hairpin-like configuration which overlaps the spinous process on an anterior posterior projection, that is your anterior radiculomedullary branch. And if you have a similar configuration which is in paramedial location, then that becomes your posterior radiculomedullary branch. So this is an illustration of your posterior radiculomedullary branch. You see this is the
hairpin-like configuration, the posterior radiculomedullary branch. So the intrinsic arterial supply is mainly by your sulcocommissural, which supplies most of the central part of the cord, and the peripheral part of the cord is supplied by the vasa corona. Now, similarly, there is an intrinsic venous supply. Now, the venous territory distribution is different from that of the artery. Now, venous supply drainage is mainly through these radicular veins, which drain into the anterior and posterior spinal veins. And then you have this sulcal vein, which drains into the anterior spinal vein. So these anterior and posterior spinal veins also travel alongside the arteries, and they form the longitudinal venous network. And these in turn drain via the radicular vein into your azygous and the hemiazygous system, and then into the IVCs and SVCs. So again, similar to the arterial system, you have a anterior and posterior spinal venous longitudinal network, which in turn drains via the radicular veins into the azygous and hemiazygous system and the IVC and SVC. So, so once we have seen the anatomy, the classification. Now, why classification is important? Because it helps in planning your treatment and also in prognosticating, because different types of vascular malformation have a different demographic presentation, different your urgency to treatment is different, because AVMs can be treated later, whereas AV fistulas has to be treated earlier. So broadly, there are many classifications, but broadly they're classified as fistulas and AVMs. The fistulas are again classified as intradural and extradural. The one of our interest is the intradural dorsal type of fistulous vascular malformation, which is called as which is a dural arteriovenous malformation. So here what we have is a direct connection between the radicular artery and the medullary vein, and this is intradural within the nerve root sleeve in the neural foramen. This is most common, usually seen in elderly, 55th to 6th decade onwards. The common site for such fistulas are in the thoracolumbar level, and they are acquired. Now, this is again an illustration. You see, so this is your segmental artery, and this is the spinal artery, and here we see a transition. The vessel distal to the spinal artery becomes bigger in caliber. So this is the site where the fistula is there, and then this is the fistula's drainage into the vein. Now you look at the configuration. This does not have a hairpin-like configuration, rather it has a coat hook-like configuration. So this is a radiculomedullary vein. So this is the fistulous site. Now, how the symptoms are produced? Now, what actually it happens is there is a congestive myelopathy which develops. So that is what is called as a venous hypertension. So when there is fistula between the artery and the vein, there is arterialization of the vein. The pressure gradient is distorted. The venous pressure increases, and this leads to increased accumulation of the fluid within the spinal cord. Now, this leads to most of the symptoms and imaging appearance. So the clinical presentation is they may present with back pain, and the sensory symptoms, which will be in the form of paresthesia, loss of position or vibration sense, and weakness, which will be usually, it could be proximal or distal, but usually starts distally and ascends proximally, and bowel bladder symptoms and impotency. Now, usually it starts unilateral, becomes bilateral, progresses from distal to proximal, and it's an ascending type. The sensory symptoms are the ones which appear first, then the motor, then subsequently the bladder and other symptoms. So they have a slow progression. They will have episodes of deterioration of the symptom with recovery, not a near complete recovery, but a partial recovery. This is always associated with the strenuous activities. Again, the relation between increased intra-abdominal pressure and resultant increased pressure within the venous sinuses, within the spinal canal, increasing the venous hypertension in a pre-existing fistula. If left untreated for 6 months, they become they become bedridden. So in 50% of them, in 3 years, it leads to complete paraplegia with bowel and bladder incontinence. In 15% of them, there's rapid or subacute worsening of the symptoms. And there is rapid clinical deterioration immediately following a lumbar puncture or giving a steroid administration. Now, this is related to increased venous hypertension, and steroids lead to increased retention of the fluid progressing or causing a sudden deterioration of the symptoms. That is why it is very important to identify this condition, because most of your other workups involve doing a lumbar puncture and then following up with steroid administration. So your workup, a detailed clinical examination, documenting the extent of the neurological deficit. MR is the preferred modality of the choice because CT has very limited application in this condition. DSA, spinal DSA for confirmation and planning your treatment. And also your workup should include the assessment of the urinary bladder, because these are certain symptoms which will persist in spite of treatment, and which requires an additional care and additional follow-up. So mainstay of imaging is MRI. The most common imaging finding which we see in these patients is a longitudinal extensive transverse myelitis or long segment centromedullary T2 hyperintensity. And if you look at this axial image, you see a hyperintensity followed by a rim of hypointensity. Now, this is again classically seen in patients with venous hypertension in conditions like these dural arteriovenous fistula. Now, this hypointensity is because of deoxygenated blood getting accumulated in the vascular system along the periphery of the cord. The other finding what we see is the presence of the flow void. The flow voids are more prominently seen along the posterior aspect of the cord rather than the anterior. Because there is disruption of the blood CSF, the barrier between the blood and spinal cord in these patients, they may show intense post-contrast enhancement. And one sign which is classically described in this condition is called as a missing piece sign, where you have enhancement followed by a normal segment and again enhancement. Now, this missing piece is because of variable disruption of the blood CSF barrier. The site where there is no enhancement, there the barrier is still intact, whereas the site where there is more enhancement, the barrier is disrupted. So presence of cord hyperintensity, flow voids, and intense cord enhancement are the imaging findings in this condition. We can also use imaging to localize the site of the fistula, which will reduce your time of picking up the fistula or confirming the fistula on the angiogram. So there are two ways for how we can do it. We can use a heavily T2-weighted high-resolution imaging using multiplanar reformats and tracing these flow voids to localize. And there are studies shown that up to 95% of the fistula localization can happen to the accurate site or once level above or below the presumed site of the fistula. The other way of localizing the fistula is to use a dynamic contrast imaging technique called as a TRIX. Again, they have shown a very high sensitivity and specificity in picking up the site of the fistula, especially in patients with dural arteriovenous fistula. Spinal angiogram, it's a gold standard investigation because it helps us to confirm the diagnosis and plan the treatment. Various catheters are available, preferring on based on the anatomy, the catheters can be chosen. So, so what we see on an angiogram is to look for a early draining vein and the configuration of the vein corresponding to that of a radiculomedullary vein. And also what we should look for is the relation of the anterior spinal artery or the posterior spinal artery to the segmental artery, which is supplying the fistula. Management. So the general principle in management is to exclude the shunt or occlude the site of the fistula. So while we are doing this, we have to preserve the blood supply to the spinal cord. That is, we should not block any of the anterior or posterior spinal arteries, preferably the anterior spinal arteries. And both surgical and endovascular options are available, with endovascular being widely followed. So the interventional hardware, there are various guide catheters and microcatheters which are available. The main embolic agent which is used in most of the cases is glue or a liquid embolic agent called as N-butyl cyanoacrylate. Whereas people have also used the other liquid embolic agent that is onyx or squid, that is called as EVOH, also in patients with dural arteriovenous fistula with a good result. So, one important thing what we need to see while doing an embolization is we have to embolize the fistula zone, that is the artery feeding the fistula, the segment where the fistula is, and the footplate of the vein. Once we have achieved this is when we can say that we have achieved a complete cure. Now, prognosis. So the neurological recovery of the patient post-embolization depends on what is the extent of deficit he had prior to the intervention, and also what is the duration from the his symptom onset to the treatment. Because the symptoms which reverse first after the embolization is the gait disturbance and the muscle weakness, and followed by his sensory symptoms. But the symptoms which tend to never reverse or to persist for a longer time is his bowel and bladder disturbances and paresthesia. Impotency is the one which usually never recovers post embolization. So this sequence of recovery is knowledge of this is very much essential, because this helps in counseling the patient. So and also this all is now the extent of recovery, again, as I told you, depends on what all of symptoms have already appeared before we have started treating him. So let's see a few case illustrations. This is a 74-year-old male who presented with progressive weakness of his left lower limb with sensory symptoms, which was more on the right side compared to the left side. He had urinary bladder symptoms, no constipation. So MRI shows long segment T2 hyperintensity or transverse myelitis involving the lower involving the dorsal cord up to the conus medullaris. There are multiple flowoids which are seen, perimetrial flowoids which are seen in the dorsal and lumbar canal. So this is the angiogram. So angiogram confirms the presence of a dural arteriovenous fistula. Now you see this is the fistula spot here. The branching of the segmental artery is seen very well. So this is the fistulous point and this is the draining vein. So this is a microcatheter injection, again demonstrating the anatomy of the dural arteriovenous fistula. So once the microcatheter is taken, few more minutes, I'll just finish it. Once the microcatheter is taken, this is the tip of the microcatheter, taken as close to the fistula site as possible, it is embolized with a liquid embolic agent. So this is the spread of the liquid embolic agent. If you look at this, the feeding artery, the fistulous point, and the proximal aspect of the draining vein has been embolized. So this ensures that we have ensured that there's a complete cure, and there's the chance of recurrence is extremely less. So this just to show the pre and post embolization angiograms showing complete exclusion of the fistula. Another illustration, a 69-year-old male presenting with progressive lower limb weakness and sensory symptoms with bowel and bladder symptoms. Again, the typical imaging features of perimetrial flowoids and cord hyperintensity. This case was unusual because he had two feeders. Usually it will be only one feeder which will be feeding the fistula, but here he had two feeders, one from the L1 spinal artery and the other one from the T12 spinal artery. So progressively each feeders were cannulated. So this is the cannulation of the L1 spinal artery feeder, the microcatheter position, and this is the glue cast filling the fistula site. From this feeder, complete exclusion of the fistula was achieved, but there was some persistent filling from the other feeder. So this is a microcatheter angiogram and followed by the glue cast in the glue percolation in this from the second feeder. So the final angiogram showing complete exclusion of the fistula. So this is a glue cast seen from both the feeders. Follow-up showing complete resolution of the perimetrial flowoids and the cord hyperintensity with significant improvement in his motor symptoms with some persistent bladder and bowel symptoms. So to conclude, these vascular malformations are rare. So, and they have a clinical presentation with overlaps with other neurological conditions. So, and the usual way of evaluation of other spinal cord neurological condition, which includes lumbar puncture and steroid treatment, can cause rapid progression or deterioration of these, deterioration of the symptoms in these patients. So, for a diagnosis and planning of treatment, the knowledge of anatomy is of utmost importance. Early treatment is important because the neurological recovery depends on the to what extent the neurological damage has happened at the time of initiation of the treatment and what is the duration since the onset of symptoms to the initiation of treatment. Thank you.
Thank you, Savit. Like, we'll take the questions at the end once Vinayak finishes his presentation. Vinay, slide, please. Yeah, Vinay is working in Mysore Apollo. At the same time, he has both expertise in pediatric and adult neuroimaging, and he's the man who's taking care of neurointerventions, and he's back into action with carotid. How carotid stenting and how do I do? Yeah, Vinay.
Thank you everyone for having me here. I would like to especially thank Satish Chandra sir and other organizers for giving an opportunity for me to speak here. Today, anyway, this is the last talk for today. So I wouldn't want to bore you. I'll try to keep it as short as possible and as simple as possible. I'll be talking about the carotid artery stenting, how I do it. So as we all know, atherosclerotic carotid stenosis is one of the common causes for stroke. It is responsible for close to around 10 to 20% of the strokes what we see. And most of the times it is asymptomatic. Majority of the patients who come to us are all diagnosed to have carotid stenosis on presentation. Rarely we have asymptomatic cases, and there are always risk factors who are prone for carotid artery stenosis. And treatment of carotid artery stenosis is important for a few things because it reduces the risk of further stroke. There have been a lot of evidence for carotid artery stenting or anything. So this is a very short list of the trials which I've done. And again, they have few of the trials are in favor of stenting, whereas few are favoring of endarterectomy. Still with probably a slight favor of towards endarterectomy. Still high risk cases which are high risk for endarterectomy are always favored for stenting. So this is this is a recently, which was published in 2016, the CREST trial. This is which showed a 10-year follow-up, which showed that between endarterectomy and stenting, there was not much significant difference in the short or the long-term risk of stroke. So the CREST True trial is ongoing with almost, this has a patient, the intake is around 2,480 cases. Almost last 50 or less than that are remaining right now. Probably expected to be published this year or maybe next year. So anyway, imaging evaluation. So we usually do carotid Doppler is the first line of imaging. But for the sake of the further management, especially for carotid artery stenting, this might not be enough. So we always advise to further imaging like a cross-sectional imaging like a CT angio or a MR angio. CT angio is relatively more preferred for few things like the identification of the arch one, the presence of calcification, and even to demonstrate the collaterals. Again, MR angiogram can be done if not CTA cannot be done in case of raised creatinine or impaired renal functions. There are like at least 2 studies are required if catheter angiogram is not done at that point of time. And usually the NACET and the ECST were the initial trials which actually showed how to measure the carotid stenosis. The thing is that there is a lot of variable between the two. Usually there is some amount of discrepancy between the staging or the measurement of the stenosis. So in any case, we usually follow the NACET criteria. If it is asymptomatic, usually more than 60% stenosis on catheter angiogram or 70% on CTA is considered as the recommendation for indication to treat. Whereas in symptomatic, anything which is more than 50% on the catheter angiogram is a recommendation to treat. So there are few exceptions where we probably treat even if the stenosis is less than 50%, like a carotid web and symptomatic carotid web and a vulnerable plaque with less than 50% stenosis. Again, these cases are probably not very common. And again, always the first line management would be a medical management. The planning, how do we plan it? First thing is a detailed neurological evaluation. You don't want to end up with a deficit and then probably consider that whether this was there before the procedure or it happened because of the procedure. So detailed neurological evaluation is a must. And if the patient has a stroke, a poor MRS, a baseline MRS of 3 or more is not a usual recommendation. These patients are usually not recommended for further treatment. But again, it all depends on a case-to-case basis. You have a patient who has some hemiparesis who may not be, who is still dependent, but whose speech is preserved. Probably it might be still worth intervening in such cases rather than probably leaving him to develop a complete hemiplegia and probably for him to develop complete aphasia. Again, it all depends on the case-to-case basis. Always assess the risk factors. All of these patients have some of the other risk factors. It's always better to optimize them before planning for a treatment. And always evaluate the imaging beforehand. Evaluate the brain parenchyma and also the vessels. Hardware, all these things helps us to plan the hardware and what type of stent, how long the stent is, whatever the types of the stent, and all depends on the initial imaging. And all patients are treated with dual antiplatelets. If he is asymptomatic, most of the patients who come to us are already on dual antiplatelets. Some asymptomatic may be on single antiplatelet. We change over to dual antiplatelets before the procedure. And always before the procedure, we inform them regarding the procedure. You take an informed consent. So while assessing the parenchyma, the strokes might be because of an embolic with a watershed pattern of stroke, or it can be a deep watershed where it's because of the hemodynamic factors, or it can be a territorial stroke like this. So if it is more than 1/3 of the territory, we usually delay the procedure. Again, it all depends on the individual cases. Small vessel disease by itself doesn't have any significance, but it might have a neurocognitive or an implication in such cases. And SWI, always look for the bleeds. A patient who has symptomatic infarct, who with SWI or with bleeds with a hemorrhage transmission, we tend to wait in such cases. We don't intervene immediately. So imaging analysis, we tend to divide the CT angiogram into functional and the anatomical functional zones. Zone is where we look for the aortic arch, and the zone 2 is the proximal vessels. Zone 3 is the stenting zone or the carotid bifurcation. Look for the distal vessels and the intracranial. All of these have a significance because it might be abnormal in each levels. It actually defines how the procedure is going to be, how difficult, technical, easy or difficult it's going to be, whether it's feasible for stenting or not. There are few things to assess like the arch anatomy. This is a simple arch, whereas this is the type 3 arch. So anything which is in a type 3 arch or a bovine configuration where there is a common origin of the brachiocephalic and the left CCA, it's going to make the case slightly more tougher during the procedures. So you can plan ahead, plan early. That is one thing. The second thing is that always look for the plaque morphology. You look for most of the times we don't do a baseline CT or a non-contrast CT, but it might be worthwhile to do in some cases. Always look for the morphology. What is the plaque characteristics, whether it's a fibrotic plaque or a calcified plaque, the length and the degree of the stenosis, and the calcium. Anything which is probably a 360-degree calcium is more than 3 millimeters in length, probably not a very good indication for a carotid artery stenting. These people tend to do much better with a endarterectomy. Always look for the angulation because any stents might be difficult to take this turn. So look for the angulation. Then always look for tandem stenosis, look for the collateral, how the circle of Willis is. All those things need to be assessed before planning the procedure. So what are things which probably are not a good cases for artery stenting, carotid artery stenting, which probably gives us an idea on this one. Any loops or tortuosity, a very tortuous ICA, the origin, the proximal ICA, and heavily dense calcification. All these things are, again, few of them might be a relative contraindication, but again, we try to look for each of these things. When to intervene? Probably this is one of the very common questions. In symptomatic cases, again, it all depends on the baseline infarct. If it's a relatively small infarct, a TIA, or the patient is having this one, usually we plan it as early as possible. Usually within 2 weeks, again, the earlier the better. If it's a relatively large infarct with hemorrhagic transformation, we tend to wait. Sometimes waiting for a longer time might be beneficial, but it always has a risk of re-stroke. So again, asymptomatic patients, most of these are the ones who are diagnosed incidentally, like they are planned for CABG, they are evaluated and who have diagnosed to have a carotid stenting. Again, if, carotid stenosis. Again, if the patient is referred in such a situation, probably the earlier the better. Sometimes it's the patient preference. I have had patients who have been consulted 3 months back and then they don't come as early as possible. As per the recommendation, this is the recent guidelines based on the European, the vascular surgery recommendations. So it's always better to do it within 14 days, 2 weeks. So what antiplatelet medications, most of the patients are on dual antiplatelets. Those on single antiplatelets are converted into a dual antiplatelets pre-procedure. Usually, if elective, usually if planned early, we give clopidogrel and aspirin for 5 days, prime them, and then take for the procedure. If it's kind of an emergency, semi-emergency, we try to load them with antiplatelets. Right now, our antiplatelet medications or the regime has changed over. We usually start them on prasugrel or ticagrelor. Ticagrelor is preferred most of the times. And in such situations, if it's it has to be done as a loading, ticagrelor 2 tablets in the morning of the procedure, or if the patient is already on clopidogrel dual antiplatelets, we just switch over to ticagrelor. Anesthesia during the procedure, we always tend to have a neuroanesthetist or a cardiac anesthetist on standby. He is inside, and always take a radial line for monitoring BP during the procedure and even after. In the ICU, we have a very strict rules for monitoring the BP, managing the BP. We have at least 2 peripheral lines. Femoral venous access, we always keep a temporary pacemaker in situ. I think probably this is one thing which I have learned in the last few years. Not all centers do that, but they keep a venous access, because if the patient goes in for an asystole or a bradycardia, you might not have time to take a venous access again at that time. Again, urinary catheterization is again controversial. I usually tend to avoid it because patients are on dual antiplatelets. I don't want to cause a urethral injury, but still and the procedure is relatively short. So for that reason, I tend to avoid it, but few centers or few operators do it with urinary catheterization. Anxiolytics or conscious sedation during the procedure if the patient is anxious. Otherwise, I tend to avoid it also. Again, only if the BP is very high, all those such things only I try to do it. Otherwise, it is avoided. Deep sedation is completely avoided. Atropine is kept and loaded alongside, but and it is connected to the IV line. In spite of that, people might argue that I already have a temporary pacemaker, need for an atropine, but there is every chance that it might actually might not work, or it might actually have malpositioned. So for that, we keep the atropine ready. Post procedure, we have a very, very strong aggressive, we manage the BP aggressively. Procedure checks, we always take a femoral or a radial axis. Again, radial axis in few cases, but as of now, preferring femoral. Can switch over to radial probably in the near future. Always do the puncture under ultrasound or fluoroguidance. This is the usual course. You don't want to end up with a case in situation like this where there is a transient ooze here from the vessel. So this was managed just by compression probably, but this was having an expanding hematoma during the procedure. Post-procedure, post-stenting, we just took a sheath injection and then saw that there was a leak here. And then considering what needs to be done, we just gave a compression and luckily it stopped. So this is a temporary pacemaker here. We always use that. Probably this has become a common thing for me. Patient is adequately heparinized during the procedure. We usually give around 5,000 international units of heparin during the procedure. Sometimes if it's obese, relatively high, this one, we usually raise it up to 7,500 units. We usually avoid diagnostic angiograms if the CT angio quality of the CT angiogram is good. Otherwise, if it is not sufficient, we tend to look for do a diagnostic angiograms, sometimes to look for the vertebral arteries, which are probably difficult to assess on CTA. I'll just finish. To demonstrate the circle of Willis and collaterals. Again, access the carotid, we have a lot of catheters, especially in difficult carotid, aortic arches, and always carefully exchange for the guiding sheath and the catheter. And once we have done an angiogram, we do the measurements, we'll plan the landing zones for the embolic protection device, the stent and all, we usually do it based on the bony landmarks. And once this is done, we prepare the hardware and then keep it ready. So you have the plaque here, and then you carefully take the embolic protection device across the stenosis and then put the stent. Few things to remember here, that the filter we have to ensure that it is at least 2 centimeters away from the distal end of the stent. And then you have enough landing zone. The plaque should be covered well, at least 1 centimeter beyond the plaque and 1 centimeter before the clot. So the stent length has to be chosen accordingly. So once this is done, you very carefully cross the stenosis with the wire. The wire can be shaped as necessary. For example, in this case where you have the vessel is quite tortuous, the CCA is quite tortuous, and a very, very thin, very, very fine ICA, very stenotic. And then again, the ICA is quite tortuous here. In such cases, again, you have to, maybe you'll need to curve the wire as necessary. And the embolic protection device is deployed in a relatively straight segment. In this case where it was quite tortuous here, the embolic protection device was not able to, we are not able to cross across this tortuous vessel, ICA. So had to use you had to have one wire, and then across that, we had to put the embolic protection device. So that helped. So, so embolic protection device can be of many things. It can be a distal protection or a proximal balloon, or it can be a filter-like device. Usually we have a consensus for filter-like device. So a lot of things. The thing is, embolic protection device, remember that it protects when the pore size is more than 70 mm. Anything which is less, the embolic particle less than 70 microns, they can embolize even in spite of having a protection device. So macroemboli can still go through when the embolic device is not well opposed to the wall. So, and also causes, sometimes we have seen it causing dissection and causes further damage. So different embolic protection devices are available and have different characteristics for each of them. There's a lot of evidence, there is a lot of argument whether to use it or not. But as of now, it says that if it is available, if it is possible, you have to use it. And once the embolic protection device is deployed, the next would be the stent deployment. So there are different types of stents, one either an open cell or a closed cell. It all depends on it's all based on the free cell area of the given stent. In the sense, the closed cells have a very small free cell area, or the open cell designs have a relatively larger ones. The advantages and disadvantages is that the closed cells have a relatively more bulky, and then they straighten the segment, whereas they have a more protection. In the sense, any plaque protrusion, all those things are much less with this. Whereas the open cell design have a relatively more, they take the curves, but they have a larger free cell area, and the plaque can protrude out of it.
Vinay, it will be nice to conclude.
Yes, sir. 5 minutes.
Conclude, yeah. 5 minutes will be too long.
Yes, sir. So it's all decided based on the individual factors, and even based on the individual factors. This is the thing where a stent design, where it is the tortuosity, it is kind of relatively not, it has taken the curve. Whereas in case of a closed cell design, you can see that there is a shelving here. You can even have a micro mesh. There are newer devices available with a micro mesh, which actually prevent the protrusion of the plaque across. So a case here with a plaque ulcer, then across once the micro mesh, the stent with the micro mesh is placed, you can see the stasis, and then after plasty, you can see that is completely obliterated. So this is another case where you have a soft plaque. This one not very significant stenosis, but once we actually deployed the stent, it actually conformed to the shape of the vessel. In the sense, there was something was amiss here. So probably there was, because of that, didn't do a plasty. And 1 week later, when we do a Doppler, we see that the plaque is, or the thrombus is there inside, protruding inside the stent. So what to do next? We thought of waiting. Around 6 weeks, it has regressed. And then at the end of 6 months, it's completely recanalized. The plaque is not there. So the next would be to dilate. So pre and post dilatation depends on either to take the device or later once when you have a residual stenosis. This is a case where a tight stenosis here once the balloon pre-plasty, and then this is immediately after the pre-plasty before the stent. So always remember that aggressive post dilatation is avoided because they have a very high risk of plaque disruption and then causing embolization. And and they might end up with we are not aiming for a picture perfect result here. So following this, we retrieve the embolic protection device, do the check angiograms of the neck and the intracranial circulation. So post-procedure management, one thing is very strict in the BP management in the ICU. We keep it around 100. The systolic should be around 100 to 120. And few cases here, this was a case with near occlusion of the carotid, very, very thin ICI here, and then barely visible. And then this is the very delayed intracranial circulation. Wire could be crossed easily pre-plasty. And then this is following angioplasty. And then this is with the stent in situ. And then this is with the stent and after post-dilatation with improvement in the flow. These are probably challenging cases. This is after 6 months follow-up with the patent stent. Another case, an 86-year-old, probably quite challenging in the sense he developed stroke when he was in the hospital. This was the at the time of admission, and one day later in the hospital he started developing infarcts. So did an MRA. MRA was showing barely any flow in the ICA. Took him for the angio, which showed collaterals from the PCA, whereas the challenge here was that it was a very tight stenosis. Just skip all these things. So had to do a serial dilatation of the balloon. So post-plasty also doesn't work well. At the end of had to do it with a 5 mm. We usually avoided doing with a 5 millimeters balloon. So in spite of that, because of the calcification, it was not opening up. And then this was the embolic protection device. So in spite of that, we could not actually negotiate the stent across in spite of doing the dilatation with 5 millimeter balloon. So I had to use a cutting balloon, my first experience as such. Post-cutting balloon, we could actually put the stent across. So yeah, with the cutting balloon, we could put the stent across. And then intracranial circulation improved. So this was probably one of the challenging cases, or probably
Vinay, I think
Yes,
people will lose they'll have the flights. I think we need to understand. You've done a wonderful presentation. I'm sorry.
Yeah. Fine.
Yeah.
To conclude,
please.
So there is significant evidence in favor of carotid artery stenting, and we need to know the pre-imaging evaluation is necessary, and even knowing the devices is hardware is necessary to decrease the complications and improve the outcome. Thank you.
I request Sharath and Savit also to come on the stage. If any questions, one question to each, if at all, if it is there. Otherwise, yeah. I think for one photo session, I request the chair. I said questions, one question to each. Come. Right. Yes.
Not a question, it's just a comment. So in the last session, probably because the neurointervention radiologists joined the group of treatment of therapeutics in neurology. Started with neurology, neurosurgery, pathologists. Today, since morning, we know that it's a teamwork. And it starts with you, it may end with you. But we all have to work together in most of the situations, be it stroke, epilepsy, movement disorder, or a tumor today. We cannot run the race alone. Thank you very much,
yes,
all of you.
Come to the end of the session. May I request now Dr. Surya Narayan Sharma, sir, to take over the valedictory ceremony.
Good evening, dear colleagues and friends. Now, after exhaustive after 2 days of extensive scientific feast, we have come to the last part of the session. One, good thing or pleasant surprise to me is that the hall is almost full. That shows the, scientific content, the interest of participants and even the colleagues who have come from across the country. I know it's not easy to take off 2 days of your, busy daily schedule, clinical schedule and come here. So you have all come from different parts of the country with a, intent to spread knowledge, share knowledge and learn new things. So I wholeheartedly thank on behalf of organizing committee, each and every one of you, all the delegates, all the faculty, all the chairpersons who have come all the way from their, respective places and made this Apollo Neuro Conclave a big success. We had almost 175 delegates and close to 70 faculty. That makes around 240. 240, I'm sure you all of you are in many national bodies. I don't think even in some of the national bodies you don't get that much, numbers. So that shows the scientific content of the program, which was duly, planned, designed by our organizing committee under the leadership of Dr. Satish Chandra, Dr. Krishna, Dr. Agdi, Dr. Ravi Mohan Rao, and all of us. So before I call some of you on stage, may I, request one or two delegates, one from student and one from outstation faculty, to come and give feedback about the event. Anyone? If you don't volunteer, I'll take some names. So better you can. Yeah. Anyone? One volunteer, anybody? From student side, we have so many students here. Okay, may I request Dr. Yatish? Yatish, yeah, unit head. I'm not able to see because of the glare actually. Unit head of Apollo Hospitals, Gynaecology, who has been instrumental in, helping us with organizing this wonderful scientific event. We all know how much, we have mugged Yatish to get things done. So over to Dr. Yatish.
No, valedictory speech will be given by sir, but after that I'll be. No, it's not to be about modest. Like all I want to say is we wanted the conference to be at this scale, and even it can be at a higher level, and it's a beginning. And what I see, the participation and involvement of all, like, irrespective of their seniority, the stature, and giving space for everyone to accommodate and make sure that they all given a space in making their presentation, made them comfortable, sharing their expertise work, and grooming them to the next level, and sharing the knowledge and continuing the legacy is what it's all about. Like, it has been done in the last 2 days. So nicely participated across the country. At the same time, like the topics, what has been chosen, how deliberately, crystal clearly, like, it has been every divisions of the of subspecialty of neurosciences has been taken into account. two things like, which always comes across, which next time we need to add is definitely like, we want to get the neuro rehab as well as neuropathology also into that, because it is a multidisciplinary plus the other the cognitive part of it, like, it's another thing, like, we may need to look at it. Otherwise, like, it's a great thing. I personally looking at like, neurosciences before Kalpana was taking care of it. I would say, all I would say is there's a pressure to start, like, when and where. And I was keep going and talking to sir, I need to do one neurosciences conclave. Thing is, finally time has come and we delivered it. And the oration what has been put across by Krish Gopal Krishna and selecting him and putting it across, what an amount of depth of research they've gone into, and it's an insightful thing for all of us. I think in nutshell, everything went on well the way it has been planned and executed. I hope my colleague Ashwini and all of them looked after you well. I also need to mention about her, like, single-handedly worked with every consultants, tolerated each and everyone's tantrums, including our idiosyncrasies. And I would like to acknowledge that. And thank you, Ashwini. Thank you so much. And I definitely, like, thank the organizing team because of so meticulously come prepared, done everything in time, like, and it was seamlessly smooth for us. And of course, Sun Pharma thing is taking the initiatives. I don't want to say it as my this thing, but it's my duty as the person who's taking up the responsibility for this conference to be done. Thing is, it should be, it's my worthwhile to mention. But overall, in general, amazing, great conference, lot of deliberations, lot of involvement, enthusiasm, participation, including the students. I think such a great work need to be projected to larger audience of physician is the only another feedback which I felt I should share it. Otherwise, it's a great thing. The topics, what you have chosen, the way it has been put across, it is amazing. Thank you.
Yeah, thank you, Dr. Yatish. May I request Dr. K. N. Krishna, sir, to say a few words? Sir, come. Yeah, Dr. Kalpana. No. Mike.
Hello. Yeah. Namaskara, everyone. I, like Yatish mentioned that he was taking care of neurosciences Pan India in the Apollo group from the administrative point of view. It rolled out to me somewhere just before Sir told that we have to do the Neuro Conclave. It fell in the lap, I told Sir, we'll go ahead, we'll plan and take it forward. So I can consider myself very lucky that I took over the responsibility of the Neuro Conclave happened. So we get, the network happened. I'm lucky to see the great strength and the great consultants and the great work which is happening across Apollo. Feel very humble moving around with your people. And always we discuss saying that because it happens in Bangalore, and Bangalore is known for neuro work. I don't know how many of you believe in Apollo corporate office, people talk about Bangalore neuro work. We have set the standard saying that some work has to happen, it has to happen like Bangalore neuro team. So I think we have already set the standards, we have to take it forward to greater heights. And Sir always wanted to say that we have to have a neuro conclave in such a way that people take this as a standard, and we have to improve the standards. And having a scientific program in such a great, in a mega form, I think we have set the standards, sir. Thank you for all the support, and you have done that day in and day out. Yeah. We know that. We have been a little support. That's all. I think you have come up with all the strategies, and hope we were helpful to you in whatever little way we could do. And I thank all the senior people, not to mention anybody's name here. I think everyone is has equally participated in this and added to this. I think without you people, I think we are administrative play a small role in this. I think it is just a supportive role what we have played. And wherever we wanted to push ourselves and do this. And thanks all of you. and great talent. I think feel so proud. And this new responsibility has come to me. Hope I'll deliver some justice to this new role. And I have moved around in the country and met all the people whom I met here also. I think we are in par with other people, and maybe a little bit of technology adding to it. I think we are no less than anybody. We can do great heights. We can go to great heights, and we can stand as an exemplary in the world. That's what I feel. I think good luck to all of us, and thanks for allowing me to talk. Thank you, sir.
Thank you. Your team, you, the whole Gynaecology team led by Ashwini and all of you, our volunteers from BG Road, everybody did a fantastic job. A big, thanks to all of you. So, Krishna sir, you want to say something? Come. So, Krishna sir, you want to say something? Few minutes.
It's just that a wonderful thing that has happened. It shows the presence of, we came to know that we have so many friends across. To repeat that I'm told that somewhere around 10% of the neuro talent is with Apollo. I think it's a beginning, looking forward to, it started off as you said, we should have something bigger. And I think you should start using the stimulating other place for the next year conference. And everybody has been enthusiastic, and I think it is a grand teamwork. And of course, administration has been more than supportive, I should say. Thank you.
Thank you. Now you can take it, yeah. You can come, and our back-end team, our marketing team led by Sunil and everybody. Probably you can come for a group photo. Come, sir. Dr. Kalpana. Satishchandra sir. Come. After that, we will, this is for our volunteers. And I especially thank Manju and his team from Skyline, who have done a wonderful job in audiovisuals. I think we have been using their services for last almost 10 years. So they have been very instrumental in doing all the audiovisual work. Now comes the most important part of the ceremony, the prize distribution to the e-poster winners. May I request Dr. Satish Chandra, Dr. Agadi, Dr. Sharath,
and Dr. Ravi Mohan Rao to stay back. And we request them to announce the winners. And I request Dr. Ravi Mohan Rao and Dr. Satish Chandra to distribute the prizes.
Very beautiful duty. Before I do that, I don't want to forget my duty. Exactly on 23rd November 2023, Dr. Yatish gave me a big surprise. I was about to leave the meeting and run away. He said, Dr. Agadi, you cannot go like that. You please stay back. It was 6 o'clock in the evening. He made me to cut a cake. It was my birthday, 67th birthday. So the Apollo Conclave first meeting took place on 23rd of November. From then onwards, now we're at the end of this Apollo Conclave and we're at the valedictory address. Before I announce the winners, I congratulate all the organizing committee members, starting from Professor Satish Chandra, Dr. Ravi Mohan Rao, Dr. Surnahan Sharma, Dr. Sharath, Dr. Krishna, and not to forget our Dr. Ashwini and what's Kalpana? Yeah. So yeah. So though I'm in the organizing committee, I request all of you to give them a very big hand. Join me in giving them a big hand. Thank you. And with the assistance of Dr. Ashwini, so we were assigned the task of selecting the posters. Totally, there were 16 posters, 2 from the radiology department and 3 for the neurosurgery. Rest of them are all from neurology. So it's my pleasant duty to announce the first runner-up in neurology. Yes. So thank you so much. Dr. Subhashini and Dr. UK Mishra, both of them are very senior neurologists, were the judges for the award paper for these posters. And I was keenly following them, and it was a very good learning for me also. So I thank the judges for having agreed to do this job. So now I announce the first runner-up for the best paper in neurology. It was Dr. Srikanth for his paper on NMDR encephalitis with paraneoplastic etiology in childhood. The second prize. So second prize, another Vinadi. Dr. I think he's Ali Asper presented the paper. And who is the first author of this paper, Dr. Satish Chandra? It was Dr. Abdul. Is he here? He is not there. So you can come, Dr. Ali, you can come and collect this thing. It was Abdul is here. Abdul is here, huh? Okay. Whoever has presented the paper, please come. So the paper titled A Rare Case of Rifampicin-Resistant Neurobrucellosis with Status Epilepticus. now it is I'm extremely happy to announce the winner of the neurology subsection award-winning paper. I enjoyed really listening to this particular author, Akash Narayan. He has a series of cases. The title of the paper is Evaluation of Atrial Cardiopathy in Elderly Patients with Non-Cardioembolic Acute Ischemic Stroke, including embolic stroke of undetermined source. This has come from Apollo, Calcutta. So you did a fantastic job. I had a great pleasure in listening to your paper. And Dr. Mishra was very happy, and he was commenting that we should encourage more posters wherein there is a series of cases presentation. So the organizing committee and Dr. Suryanarayan Sharma, they have been very gracious to announce the prize for the first prize. First winner, prize for the winner is rupees 5,000, and they will be receiving the Amazon gift vouchers, and all others winners will get around 3,000 rupees. Now it is time to announce the best paper in the radiology category. So the best paper in the radiology category goes to our a very intelligent and very hardworking colleague of mine at Apollo Hospital, Sheshadipuram, Dr. Chaitra Adiga, for her presentation on. Chaitra is not here. Chaitra is here. Oh. Come. I didn't congratulate you. I did not congratulate you before announcing your name. Yeah, now I'm congratulating you. So for her paper on comprehensive solution for spontaneous intracranial hypertension and overlooked affliction. So give them a very big hand. And congratulations to all the winners. So now I request Dr. Ravi Mohan Rao to announce the best paper award in the neurosurgical category. Thank you, sir.
There were only 2 e-posters in neurosurgery. The judge was Professor Siddhartha Ghosh, and the winner of the prize is Dr. Abhignan, negative pressure wound dressing therapy. He is from Apollo International Hospital, Guwahati. He's gone. Okay. So the certificate has to reach him and the prize. Thank you.
Congratulations to all the poster winners. I hope you get many more laurels in the coming days. Now, without wasting much time, I invite Dr. Satish Chandra, the chairman of the organizing committee and the man behind today's event, to give a final vote of thanks.
Good evening to all of you. We were thinking about having this Apollo Conclave 24 from last about at least 6 months. Then we thought that all the 3 units should join together in Bangalore and conduct this Apollo Conclave. That was the beginning of our thought. Then we started making a committee to look at that. And the people gave me the responsibility to be the chairman of the organizing committee. Then I have to have a right and left hand. Without the hands, I cannot work. So we had Suryanarayan Sharma on one side and Ravi Mohan Rao on the other side, neurologists and neurosurgeons who joined together. Give them a big hand. And they have worked tirelessly for the last at least 3 months to work with the team. And this was all possible because of the support given by the Apollo group of institutions. And I should thank right from the chairman, then to the vice chairman, because their role is very, very important. And they have extended the full support to us in choosing even the orator and agreeing. First is that they agreed to have oration in the name of our chairman. So when we wrote to them saying that we are very keen to have an oration in the name of our chairman, Padma Vibhushan Pratap C. Reddy, promptly came the reply that yes, please go ahead. So that was one of the wonderful moments I cherished. And then we went ahead with choosing the speaker. They helped us in getting Professor Padma Bhushan Chris Gopal Krishnan. And I think all of you enjoyed the oration yesterday. Then we went through the academic program. The academic committee sat together many weeks. It is 1 week after week and a week after, and we designed the program. And what we saw from the last 2 days is the effort of at least the last 3 months. And to make this successful, it is not simple. And all the people, the faculty from different parts of the country have consented to our invitation, and they've all come from different parts of the country, starting from Guwahati. Today, you just now saw a person who got the prize is from Guwahati. So we have the people from north to south and east to west. Everybody was there. And that was the best part of it. And we did not have a directory for the people. So Kalpana, Dr. Kalpana helped us in getting all the names, and we went through Google search and with the help of Ashwini, and we did that work. And then people responded, and all was possible to approach each and every one. And I think we should build it up. We are able to do this level because of the support extended by every one of us, including Dr. Yatish, Dr. Kalpana, Dr. Uday, Dr. Manish Matu, and newly joined Dr. Preetham. All these people have supported us, and without their support, we cannot do. But any conference of this nature cannot be done unless there is a financial support. And I'm very happy to say that Sun Pharma came forward, and then they supported us with a knowledge partner, as a knowledge partner to all our organization. And I thank the team, which is led by Dinesh Purushottam. I think you should come here. We will have to shake hands with you. Dinesh Purushottam, the whole team, along with everybody, please come. Please come. Come. Just give. Okay. We'll shake hands and have a photograph with them. Come. Ravi, please come. Please. Have a So then whatever we start has to, all good things comes to an end. And that is a saying, and that has been now, we are reaching the valedictory, and that is why we are thanking each and every one of it. Our core committee was the most important one. We had a core committee for the organization, and I don't know how much I've troubled and how many messages and middle of the night messages. I think Ashwini must take 3 days rest because I have to send a messages every middle of the night saying that this has been done, this not been done. Look at this, how, whether the printer has sent this or not. And promptly comes the reply. I was thinking that I will just send it because I remembered. But what happens is, if I send it at 3 o'clock, 3:05, the reply comes. That is the part. Same thing with Kalpana. Kalpana used to reply to me straight away in the middle of the night. I don't know whether they were awake and how they were awake. I really admire you people. You have done wonderful job and you are on the back of the stage, but you did a wonderful work more than all of us. Thank you very much. Thank you very much. And the students' participation was excellent. And we wanted to start the students to participate here so that we will encourage that. And this scientific thing has to come in. And it is not just the institution which does, even the Apollo hospitals, we have to do a lot of scientific work. It is expected out of us. And that is the beginning we started. And the students, there were good participation. And that is why we saw today e-poster session. I thank each and every one. There are some winners, there are some losers, but always there is a competition which matters. And I congratulate the winners, but I congratulate each and every one of the students who has participated. That is what is very, very important. And we will take it to a bigger level next time. Having done all these things, now what next is the question. And what next always has to be there in any planning. So the next planning, what we were thinking is, this should become an annual feature. The annual feature year after year, not in one place, all over India. Don't get worried. So we will not have in Bangalore. We will have a roundabout. First thing is the next, already they have, people are asking, and New Delhi has taken it. And the New Delhi and the group led by Vinit Suri, has consented, and he has sent a message today that he will be hosting it in Indraprastha. And I think all of us should be looking forward to go to Delhi and make it bigger than this, what we have done today. Then two other just points. That Apollo Conclave has achieved one of the things, one of the objectives. One of the objective was to disseminate the knowledge what we have and then make the people to be interested and start working in the direction. And that has been achieved. What next has to be done is two more things, that we all have to work together as a team. And we have 38 hospitals with nearly 400 workforce of neuroscientists. And we all jointly work together and make our own data and our own database and our own publications and research. And that is what has to be achieved. We had a long discussion with the administration yesterday with Harshad Reddy and today with Madhu, and they were all for that. They are all supporting us, and shortly there will be something to come out, and we will be working towards making research and academic as also one of the important part of Apollo. That is what exactly we have to do. And the third most important point I wanted to raise is that the optimal utilization of the resources, which is extremely important. We have expertise in one area, another people have an expertise in another area. And there are people who are very good in the technology is available. For example, we all know Zapex is available in Delhi now, Proton is available in Chennai, and we have here epilepsy surgery and other intervention program here. So like that, we all can join together and we refer the patients and also to see that our patients are benefited maximum. That is what exactly our aim should be, at the affordable cost and using optimally the resources what we have, both technologically and as well as manpower. That is what we are hoping for. And I think this Apollo Conclave will take to the next step these two areas, then we'll be very happy. So I thank each and every one of you, including the photographers, the audiovisual aids, and then the people who are caterers and the hotel which is provided the accommodation for us, and all of you have done a lot of work. And I know there are many more people who are on backstage. I think from my bottom of heart, our organizing committee, on behalf of Sunan Sharma and Ravi Mohan Rao and Dr. K. N. Krishna Agadi, all of us join us to help you, thank from bottom of our heart. Thank you, one and all, and have a safe trip when you go back. Thank you.
Thank you, sir. So hope we will all join next year in New Delhi with fond memories. So we close this in a valedictory function with fond memories of 2 days of the event. So before breaking, as a customary, we rise for the national anthem. I request everyone to rise for national anthem.
जन गण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल गंगा विंध्य हिमाचल यमुना गंगा उज्जल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगल जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
ಜೈ ಹಿಂದ್, ಜೈ ಕರ್ನಾಟಕ, ಎಲ್ರಿಗೂ ನಮಸ್ಕಾರ.